transfer of patients to operating rooms and intensive care units. Every unit is equipped to treat all types of procedures, including trauma surgery. Critical excellence is rooted in our team of doctors who are well versed with the latest advancements, which further complemented by highly trained nurses, paramedical staff, an aesthetically inspiring building backed by cutting-edge security with the central monitoring system and consistent pieces of training. It has separate food areas for staff and visitors with the best standards of hygiene. Milestones achieved.
EHCC has its vision of being a center of excellence in the area of medicine. We have served a lot of national and international patients. We at EHCC are committed to serving and bringing good health for all. We will always strive to be better than today. Thank you.
We are first in the country for HOT CRT, TAVI.
His bundle technique CRT procedure, India's first transcatheter double valve replacement in one procedure. First navigation guided balloon sinoplasty in India. We are only center in Rajasthan and fourth in India to implant Impella. The Eternal Hospital has a knowledge-sharing arrangement with Mount Sinai Hospital, New York. It is the only hospital of the state with JCI accreditation. Apart from this, the hospital is accredited by NABH, NABL, and awarded for nursing excellence by NABH. Ours is the first hospital in the region to perform the highest number of successful transplants. The Eternal Hospital is India's preferred center for excellence from the American College of Cardiology. Apart from providing world-class care, we also provide unique services like liver transplant, trauma care, plastic surgery, and more, supported by ultra-modern infrastructure. And wealth of expert professionals who are in the field for over 2 decades and available all the time under one umbrella, ensuring recovery of patients at the earliest. Our institution has been awarded by numerous organizations or media houses, including Most Preferred Multi-Speciality Hospital and Leading Multi-Speciality Hospital of Rajasthan, awarded by Times of India in 2018 and 2019. Entrepreneur Excellence in Healthcare and Community Services Economic Times Business Leader of Rajasthan 2018. Eternal Hospital Jaipur was awarded by Asia's Greatest Brands 2019-2020 in the category of Industry Healthcare at Asian Business and Social Forum, Pride of Asia Series Awards and Business Summit at Bangkok, Thailand. Mrs. Manju Sharma, co-chairperson and MD, was honored by Asia One's Bharatiya Mahantam Vikas Puraskar for her leadership in healthcare industry. A coverage by Forbes magazine, led by co-chairperson and MD, Mrs. Manju Sharma. Eternal Hospital has been internationally recognized for its top-performing physicians and revolutionary research centers. Eternal Hospital has been awarded as the best multi-speciality private hospital of Jaipur by The Week magazine in their recently conducted Best Hospital Survey 2020. Dr. Rajiv Gupta, ranked first in India and 108 globally in general and internal medicine, is listed among the top 2% scientists in the world for research. Eternal Hospital, a unit of Eternal Healthcare Center and Research Institute, where good care leads and good health follows. India's largest state's capital, Jaipur, popularly known as Pink City, surrounded by the world's oldest mountain range, Aravalli. It is renowned for its perfect blend of wealthy heritage combined with its imperishable bygone past and cosmopolitan culture. It is recently inscribed as a World Heritage Site by UNESCO. Apart from being the administrative center of the state, Jaipur is the most preferred medical destination. Eternal Hospital Jaipur emerged emerged as an eternal bliss for mankind across the globe. Founded in the year 2013 in Jaipur, Rajasthan, as a heart care center, which later emerged as one of the most preferred multi-speciality centers in North India by Mrs. Manju Sharma, co-chairman and managing director, and Dr. Samin K. Sharma, chairman and chief interventional cardiologist, based at Mount Sinai Hospital, New York City, New York, USA. He's also known as Master of Rotabulator. He believes the hospital is driven by a single thrust to provide the best standard in patient care through human resources, infrastructure, and technology.
JHRS हॉस्पिटल अपने आप में एक डिफरेंट तरह का हॉस्पिटल है। ये अस्पताल शुरुआत में सिर्फ कार्डियक केयर के लिए स्टार्ट हुआ था, जैसे कि इसका नाम है एटर्नल हार्ट केयर सेंटर। लेकिन धीरे धीरे यहाँ के माहौल में ऐसा परिवर्तन आया कि यहाँ पे सुपर स्पेशलिटी में ऑर्थोपेडिक्स, न्यूरोसाइंस,
Range, Aravali. It is renowned for its perfect blend of wealthy heritage combined with its imperishable bygone past and cosmopolitan culture. It is recently inscribed as a World Heritage Site by UNESCO. Apart from being the administrative center of the state, Jaipur is the most preferred medical destination. Eternal Hospital Jaipur emerged as an eternal bliss for mankind across the globe. Founded in the year 2013 in Jaipur, Rajasthan, as a heart care center, which later emerged as one of the most preferred multi-speciality centers in North India by Mrs. Manju Sharma, co-chairman and managing director, and Dr. Samin K. Sharma, chairman and chief interventional cardiologist, based at Mount Sinai Hospital, New York City, New York, USA. He's also known as Master of Rotabulator. He believes the hospital is driven by a single thrust to provide the best standard in patient care through human resources, infrastructure, and technology.
JHRS हॉस्पिटल अपने आप में एक डिफरेंट तरह का हॉस्पिटल है। ये अस्पताल शुरुआत में सिर्फ कार्डियक केयर के लिए स्टार्ट हुआ था, जैसे कि इसका नाम है एटर्नल हार्ट केयर सेंटर। लेकिन धीरे धीरे यहाँ के माहौल में ऐसा परिवर्तन आया कि यहाँ पे सुपर स्पेशलिटी में ऑर्थोपेडिक्स, न्यूरोसाइंसेज, गैस्ट्रोएंटरोलॉजी, गायनी, लेप्रोस्कोपिक गायनी, ये सब जुड़ते चले गए। और समय दर समय एटर्नल अस्पताल ने इतनी ज़्यादा प्रगति करी कि आज की तारीख में ये सुपर स्पेशलिटी में राजस्थान का नहीं, आसपास के प्रदेशों का नहीं, रादर कंट्री में नाम रखता है। तो हार्ट के मामले में तो ये इंडिया का सर्वोत्तम अस्पताल माना जाता है।
Eternal Hospital is the premium healthcare hospital focused on delivering the highest quality care with a 250-bed capacity spread over 5 floors. All construction and adaptation of technology have been done in adherence to international norms. The top-performing medical professionals in various specialities, highly trained nurses and paramedical staff from across the globe. Center is known for many firsts procedures. obstetrics and IVF, lab medicine, pathology, pulmonology, and urology. Apart from these, Eternal Hospital offers tertiary care, namely cardiac sciences, neurosciences, renal sciences, orthopedics, and joint replacement, critical care, internal medicine, and many other specialties supported by a highly competent team of doctors and medical staff. The center has dedicated 7 operation theaters, state-of-art ICUs, blood bank, comprehensive path lab, sterilization room, Roscovis 6000, biochemistry analyzer, XIV 556 Max hematological analyzer, coagulation analyzer. The infrastructure of hospital is designed to meet the needs of the patients and to provide prompt treatment. Emergency. The emergency unit has special facilities for the immediate transfer of patients to operating rooms and intensive care units. Every unit is equipped to treat all types of procedures, including trauma surgery. Critical excellence is rooted in our team of doctors who are well versed with the latest advancements, which further complemented by highly trained nurses, paramedical staff. An aesthetically inspiring building backed by cutting-edge security with the central monitoring system and consistent pieces of training. It has separate food areas for staff and visitors with the best standards of hygiene. Milestones achieved.
EHCC has its vision of being a center of excellence in the area of medicine. We have served a lot of national and international patients. We at EHCC are committed to serving and bringing good health for all. We will always strive to be better than today. Thank you.
We are first in the country for HOT CRT, TAVI.
His bundle technique CRD procedure, India's first transcatheter double valve replacement in one procedure. First navigation guided balloon sinoplasty in India. We are only center in Rajasthan and fourth in India to implant Impella. The Eternal Hospital has a knowledge-sharing arrangement with Mount Sinai Hospital, New York. It is the only hospital of the state with JCI accreditation. Apart from this, the hospital is accredited by NABH, NABL, and awarded for nursing excellence by NABH. Ours is the first hospital in the region to perform the highest number of successful transplants. The Eternal Hospital is India's preferred center for excellence from the American College of Cardiology. Apart from providing world-class care, we also provide unique services like liver transplant, trauma care, plastic surgery, and more, supported by ultra-modern infrastructure. And wealth of expert professionals who are in the field for over 2 decades and available all the time under one umbrella, ensuring recovery of patients at the earliest. Our institution has been awarded by numerous organizations or media houses, including Most Preferred Multi-Speciality Hospital and Leading Multi-Speciality Hospital of Rajasthan, awarded by Times of India in 2018 and 2019. Entrepreneur Excellence in Healthcare and Community Services Economic Times Business Leader of Rajasthan 2018. Eternal Hospital Jaipur was awarded by Asia's Greatest Brands 2019-2020 in the category of Industry Healthcare at Asian Business and Social Forum, Pride of Asia Series Awards and Business Summit at Bangkok, Thailand. Mrs. Manju Sharma, co-chairperson and MD, was honored by Asia One's Bhartiya Mahantam Vikas Puraskar for her leadership in healthcare industry. A coverage by Forbes magazine, led by co-chairperson and MD, Mrs. Manju Sharma. Eternal Hospital has been internationally recognized for its top-performing physicians and revolutionary research centers. Eternal Hospital has been awarded as the best multi-speciality private hospital of Jaipur by the Week magazine
in their recently conducted
Best Hospital Survey 2020. Dr. Rajiv Gupta, ranked first in India and 108 globally in general and internal medicine, is listed among the top 2% scientists in the world for research. Eternal Hospital, a unit of Eternal Healthcare Center and Research Institute, where good care leads and good health follows. India's largest state's capital, Jaipur, popularly known as Pink City, surrounded by the world's oldest mountain range, Aravalli. It is renowned for its perfect blend of wealthy heritage combined with its imperishable bygone past and cosmopolitan culture. It is recently inscribed as a World Heritage Site by UNESCO. Apart from being the administrative center of the state, Jaipur is the most preferred medical destination. Eternal Hospital Jaipur emerged as an eternal bliss for mankind across the globe. Founded in the year 2013 in Jaipur, Rajasthan, as a heart care center, which later emerged as one of the most preferred multi-speciality centers in North India by Mrs. Manju Sharma, co-chairman and managing director, and Dr. Samin K. Sharma, chairman and chief interventional cardiologist, based at Mount Sinai Hospital, New York City, New York, USA. He's also known as Master of Rotabulator. He believes the hospital is driven by a single thrust to provide the best standard in patient care through human resources, infrastructure, and technology.
JHRS हॉस्पिटल अपने आप में एक डिफरेंट तरह का हॉस्पिटल है। ये अस्पताल शुरुआत में सिर्फ कार्डियक केयर के लिए स्टार्ट हुआ था, जैसे कि इसका नाम है एटर्नल हार्ट केयर सेंटर। लेकिन धीरे धीरे यहाँ के माहौल में ऐसा परिवर्तन आया कि यहाँ पे सुपर स्पेशलिटी में ऑर्थोपेडिक्स, न्यूरोसाइंसेज, गैस्ट्रोएंटरोलॉजी, गायनी, लेप्रोस्कोपिक गायनी, ये सब जुड़ते चले गए। और समय दर समय एटर्नल अस्पताल ने इतनी ज़्यादा प्रगति करी कि आज की तारीख में ये सुपर स्पेशलिटी में राजस्थान का नहीं, आसपास के प्रदेशों का नहीं, रादर कंट्री में नाम रखता है। तो हार्ट के मामले में तो ये इंडिया का सर्वोत्तम अस्पताल माना जाता है।
Eternal Hospital is the premium healthcare hospital focused on delivering the highest quality care with a 250-bed capacity spread over 5 floors. All construction and adaptation of technology have been done in adherence to international norms. The top-performing medical professionals in various specialties, highly trained nurses and paramedical staff from across the globe. Center is known for many firsts, procedures and surgeries in the world, India and Rajasthan. Some procedures and surgeries are TMVR surgery and double valve implant, MyValve TAVI valve implantation, leadless pacemaker, infrastructure. Here, doctors have access to sophisticated equipment to provide quality care round the clock. The latest range of equipment ranging from highly equipped ICUs to FD20, most advanced cath lab in Rajasthan, radiology department, path lab dialysis center, wellness section, etc., which are patient-centric, ensures accountability and transparency, which help doctors to give committed time to each patient. Patient rooms at Eternal Hospital are designed to ensure complete patient comfort, which further bifurcated into the suite. Super Deluxe and semi-deluxe rooms on twin sharing basis with all possible amenities. Multi-speciality. Eternal Hospital brings the best in over 15 multi-speciality treatment to the state of Rajasthan, owing to exclusive services and specialities like cardiology, cardiac surgery, neurology, neurosurgery, critical care joint replacement, spine surgery, nephrology, operation theaters, state-of-art ICUs, blood bank, biochemistry analyzer, XIV 556 Max hematological analyzer, coagulation analyzer.
Hello. Good afternoon. Good afternoon, all. Very soon we are going to start our session. So we are starting with ECG quiz. Those who are participating, please take their voting pad from the organizers. I will request my colleagues like Ashish, Prithvi, who are behind, please circulate these ECG device to all doctors who are sitting in front of us. Thank you.
India's largest state's capital, Jaipur, popularly known as Pink City, surrounded by the world's oldest mountain range, Aravalli. It is renowned for its perfect blend of wealthy heritage combined with its imperishable bygone past and cosmopolitan culture. It is recently inscribed as a World Heritage Site by UNESCO. Apart from being the administrative center of the state, Jaipur is the most preferred medical destination. Eternal Hospital Jaipur emerged as an eternal bliss for mankind across the globe. Founded in the year 2013 in Jaipur, Rajasthan, as a heart care center, which later emerged as one of the most preferred multi-speciality centers in North India by Mrs. Manju Sharma, co-chairman and managing director, and Dr. Samin K. Sharma, chairman and chief interventional cardiologist, based at Mount Sinai Hospital, New York City, New York, USA. He's also known as Master of Rotabulator. He believes the hospital is driven by a single thrust to provide the best standard in patient care through human resources, infrastructure, and technology.
ये किसी हॉस्पिटल अपने आप में एक डिफरेंट तरह का हॉस्पिटल है। ये अस्पताल शुरुआत में सिर्फ कार्डियक केयर के लिए स्टार्ट हुआ था, जैसे कि इसका नाम है एटर्नल हार्ट केयर सेंटर। लेकिन धीरे धीरे यहाँ के माहौल में ऐसा परिवर्तन आया कि यहाँ पे सुपर स्पेशलिटी में ऑर्थोपेडिक्स, न्यूरोसाइंसेज, गैस्ट्रोएंटरोलॉजी, गायनी, लेप्रोस्कोपिक गायनी, ये सब जुड़ते चले गए। और समय दर समय एटर्नल अस्पताल ने इतनी ज़्यादा प्रगति करी कि आज की तारीख में ये सुपर स्पेशलिटी में राजस्थान का नहीं, आसपास के प्रदेशों का नहीं, रादर कंट्री में नाम रखता है। तो हार्ट के मामले में तो ये इंडिया का सर्वोत्तम अस्पताल माना जाता है।
Eternal Hospital is the premium healthcare hospital focused on delivering the highest quality care with a 250-bed capacity spread over 5 floors. All construction and adaptation of technology have been done in adherence to international norms. The top-performing medical professionals in various specialties, highly trained nurses and paramedical staff from across the globe. Center is known for many firsts, procedures and surgeries in the world, India and Rajasthan. Some procedures and surgeries are TMVR surgery and double valve implant, MyValve TAVI valve implantation, leadless pacemaker, infrastructure. Here, doctors have access to sophisticated equipment to provide quality care round the clock. The latest range of equipment ranging from highly equipped ICUs to FD20, most advanced cath lab in Rajasthan, radiology department, path lab dialysis center, wellness section, etc., which are patient-centric, ensures accountability and transparency, which help doctors to give committed time to each patient. Patient rooms at Eternal Hospital are designed to ensure complete patient comfort, which further bifurcated into the suite. super deluxe, and semi-deluxe rooms on twin sharing basis with all possible amenities. Multi-speciality. Eternal Hospital brings the best in over 15 multi-speciality treatment to the state of Rajasthan, owing to exclusive services and specialities like cardiology, cardiac surgery, neurology, neurosurgery, critical care joint replacement, spine surgery, nephrology, urology, and many more. It also offers unique services like nuclear medicines, infectious disease department, fast-track surgeries, preventive health department. Our centers of excellence. Besides excellent results in cardiac care, the hospital also offers endocrinology and diabetics, gynecology and obstetrics.
Good afternoon. Very soon, like in 10 minutes, we are going to start our first session. Make yourself comfortable and take this ECG device. Thank you.
Its capital, Jaipur, popularly known as Aravali. It is renowned for its perfect blend of wealthy heritage combined with its imperishable bygone past and cosmopolitan culture. It is recently inscribed as a World Heritage Site by UNESCO. Apart from being the administrative center of the state, Jaipur is the most preferred medical destination. Eternal Hospital Jaipur emerged as an eternal bliss for mankind across the globe. Founded in the year 2013 in Jaipur, Rajasthan, as a heart care center, which later emerged as one of the most preferred multi-speciality centers in North India by Mrs. Manju Sharma, co-chairman and managing director, and Dr. Samin K. Sharma, chairman and chief interventional cardiologist, based at Mount Sinai Hospital, New York City, New York, USA. He's also known as Master of Rotabulator. He believes the hospital is driven by a single thrust to provide the best standard in patient care through human resources, infrastructure, and technology.
EHCC हॉस्पिटल अपने आप में एक डिफरेंट तरह का हॉस्पिटल है। ये अस्पताल शुरुआत में सिर्फ कार्डियक केयर के लिए स्टार्ट हुआ था, जैसे कि इसका नाम है एटर्नल हार्ट केयर सेंटर। लेकिन धीरे धीरे यहाँ के माहौल में ऐसा परिवर्तन आया कि यहाँ पे सुपर स्पेशलिटी में ऑर्थोपेडिक्स, न्यूरोसाइंसेज, गैस्ट्रोएंटरोलॉजी, गायनी, लेप्रोस्कोपिक गायनी, ये सब जुड़ते चले गए। और समय दर समय एटर्नल अस्पताल ने इतनी ज़्यादा प्रगति करी कि आज की तारीख में ये सुपर स्पेशलिटी में राजस्थान का नहीं, आसपास के प्रदेशों का नहीं, रादर कंट्री में नाम रखता है। तो हार्ट के मामले में तो ये इंडिया का सर्वोत्तम अस्पताल माना जाता है।
Eternal Hospital is the premium healthcare hospital focused on delivering the highest quality care with a 250 capacity spread over 5 floors. All construction and adaptation of technology have been done in adherence to international norms. The top-performing medical professionals in various specialities, highly trained nurses and paramedical staff from across the globe. Center is known for many firsts, procedures and surgeries in the world, India and Rajasthan. Some procedures and surgeries are TMVR surgery and double valve implant, MyValve TAVI valve implantation, leadless pacemaker, infrastructure. Here, doctors have access to sophisticated equipment to provide quality care round the clock. The latest range of equipment ranging from highly equipped ICUs to FD20, most advanced cath lab in Rajasthan, radiology department, Path Lab Dialysis Center, Wellness Section, etc., which are patient-centric, ensures accountability and transparency, which help doctors to give committed time to each patient. Patient rooms at Eternal Hospital are designed to ensure complete patient comfort, which further bifurcated into the suite. Super Deluxe and semi-deluxe rooms on twin sharing basis with all possible amenities. Multi-speciality. Eternal Hospital brings the best in over 15 multi-speciality treatment to the state of Rajasthan, owing to exclusive services and specialities like cardiology, cardiac surgery, neurology, neurosurgery, critical care joint replacement, spine surgery, nephrology, urology, and many more. It also offers unique services like nuclear medicines, infectious disease department, fast-track surgeries, preventive health department. Our centers of excellence. Besides excellent results in cardiac care, the hospital also offers endocrinology and diabetics, gynecology and obstetrics and IVF, lab medicine and pathology, pulmonology and urology. Apart from these, Eternal Hospital offers tertiary care, namely cardiac sciences, neurosciences, renal sciences, orthopedics and joint replacement, critical care, internal medicine, and many other specialties supported by a highly competent team of doctors and medical staff. The center has dedicated 7 operation theaters, state-of-art ICUs, blood bank, comprehensive path lab, sterilization room, Rauschkovas 6000, biochemistry analyzer, XIV 556 Max hematological analyzer, coagulation analyzer. The infrastructure of hospital is designed to meet the needs of the patients and to provide prompt treatment. Emergency. The emergency unit has special facilities for the immediate transfer of patients to operating rooms and intensive care units. Every unit is equipped to treat all types of procedures, including trauma surgery. Critical excellence is rooted in our team of doctors who are well versed with the latest advancements, which further complemented by highly trained nurses, paramedical staff. An aesthetically inspiring building backed by cutting-edge security with the central monitoring system and consistent pieces of training. It has separate food areas for staff and visitors with the best standards of hygiene. Milestones achieved.
THCC has its vision of being a center of excellence in the area of medicine. We have served a lot of national and international patients. We at THCC are committed to serving and bringing good health for all. We will always strive to be better than today. Thank you.
We are first in the country for HOT CRT, TAVI.
His bundle technique CRD procedure, India's first transcatheter double valve replacement in one procedure. First navigation guided balloon sinoplasty in India. We are only center in Rajasthan and fourth in India to implant impeller. The Eternal Hospital has a knowledge-sharing arrangement with Mount Sinai Hospital, New York. It is the only hospital of the state with JCI accreditation. Apart from this, the hospital is accredited by NABH, NABL, and awarded for nursing excellence by NABH. Ours is the first hospital in the region to perform the highest number of successful transplants. The Eternal Hospital is India's preferred center for excellence from the American College of Cardiology. Apart from providing world-class care, we also provide unique services like liver transplant, trauma care, plastic surgery, and more, supported by ultra-modern infrastructure. wealth of expert professionals who are in the field for over 2 decades and available all the time under one umbrella, ensuring recovery of patients at the earliest. Our institution has been awarded by numerous organizations or media houses, including Most Preferred Multi-Speciality Hospital and Leading Multi-Speciality Hospital.
Good afternoon. Good afternoon, ladies and gentlemen, esteemed doctors and respected guests. I, Nitesh Tiwari, General Manager Marketing, Eternal Hospital, Jaipur, on the behalf of Jaipur Heart Rhythm Summit, welcomes you all. It's an absolute delight to have each one of you here today as we embark on this journey of knowledge, innovation, and collaboration in the realm of cardiac care. We are honored to be joined by renowned faculty members from across India, whose insights and experience will undoubtedly enrich our understanding and open doors to new horizons. As we come together in the spirit of learning, we encourage each one of you to actively participate in the engaging session, share your knowledge, and connect with fellow professionals. Before we immerse ourselves in enriching experience, we would like to extend our deepest gratitude to organizing chairman, Dr. Jitendra Singh Makkar sir. He is the HOD and Director, Cardiology at Eternal Hospital, Jaipur. And of course, our organizing secretary, Dr. Kush Kumar Bhagat sir. He is Associate Director, Electrophysiology and Heart Failure at Eternal Hospital, Jaipur. For their dedication and efforts in making this event a reality, please give them a big round of applause. And I would like to say thanks to Manju Madam and Prachi sir for their blessing and support in each and every event to make this a huge success. So to take this forward, I would like to invite and introduce, of course, there is no introduction of Dr. Makkar sir. Everyone knows, but still Dr. Makkar is a senior interventional cardiologist with a special interest and expertise in the field of clinical electrophysiology, pacemaker, heart failure device management. He has more than 27 years of experience in the field of cardiology and has worked with leading cardiac institutes across the country. He has done fellowship in complex arrhythmia ablation from Korea Institute Medical Center. He has performed thousands of coronary angioplasties, RF ablation, pacemaker and heart failure devices. He is a pioneer in this field in the state by establishing the first EP lab and pacemaker clinic in Rajasthan and implanting many devices first in state. So let's warmly welcome to distinguished doctor and talented singer and organizing chairman of the conference, Dr. Jitendra Singh Makkar sir. Please give a big round of applause for him.
Thank you, Nitesh. Good afternoon and very warm welcome on behalf of Department of Cardiology and Team Eternal. This is our annual program which couldn't happen last year, but I remember we were the first one to restart physical conferences after COVID in 2021, and that was a huge success. And last year we had some other engagements, so we couldn't do that. But this we are almost doing since year 2013, almost every year, and we are very happy that we always get very good, renowned national faculty every year from across India and sometime from abroad also. So I welcome Dr. Anoop Gupta, uh, very senior electrophysiologist and our senior colleague from Ahmedabad, Dr. Ajay Nayak from Ahmedabad, Dr. Daljit Kaur, all the way from Hyderabad. She is a very, very talented electrophysiologist, very well renowned in the country. Dr. Niti Chadda is also joining us soon from Faridabad. Then we have Padam Bhushan Dr. T.S. Clare, who is not able to come physically, but he will deliver his talk online. Also Dr. Anil Saxena, who is like a fatherly figure to all electrophysiologists of our era. And Dr. Aparna Jaswal also would be delivering her lecture online. So it is good, amalgamation of physical and online lectures. And I once again welcome you all. And we start with ECG quiz. So I'll invite Dr. Kush Bhagat for that. And I thank you again once to all of you to spare your time on Saturday afternoon. So I'll request my junior colleagues from departments of medicine from all medical colleges, if you can be on the front seats if they are empty. And I hope you are ready with your buzzers, with your voting pads. Kush will explain you some rules and then we'll start the ECG quiz.
Thank you so much, sir. And on behalf of Eternal Hospital, I would like to invite you all. So before starting the quiz, I would just give some instructions about the quiz. So I think most of you have the voting pads. All those who don't have the voting pad and want to participate in the quiz, they can raise their hand. Our organizers will get back to you and give the voting pads. We have to submit the answer when the music will start. So I'll tell the question and give the options, and when the music will start, only then you have to submit the answer. After submitting the answer, you have to press the OK button, and total time duration which will be given to you is 30 seconds. And needless to mention, we have very exciting gifts which will be given to the first and second winner. So I think all of you have the voting pad, and I would request everyone who want to participate, you can please come and sit with your lunch. So for the ECG quiz, I would like to invite Dr. Daljit ma'am, as sir mentioned, a very, very trained electrophysiologist all the way from Hyderabad. Anoop sir, again, no introduction. He himself is from Rajasthan. Makkar sir, and I think Dr. Niti Chadda ma'am and Dr. Ajay Nayak sir are on their way. They will come here soon. Makkar sir, please. We can start the ECG quiz. So all of you have the voting pads? Perfect. So we have 10 to 11 questions, and just make sure that you have the questions over there also. The ECG quiz questions over there. Okay, perfect. So without any further delay, I'm starting the quiz, and this is the first case. He's a 26 years old male with history of chest pain and dyspnea on exertion. And all the investigations were done, and there was no evidence of any structural heart disease. So this is the ECG of this patient with history of dyspnea on exertion and chest pain. And I'll get back to the option, and these are the options. So young patient with history of dyspnea on exertion and chest pain. You can start the time. Music. Yeah, so these are the options, and this is the ECG. Okay. Yeah, just a moment, sir. So we have to make sure that, here is, at one slide should be ECG, the options. And when the ECG will get displayed, then only we will start the music. Is it fine? When the ECG will get displayed, then only start the music. Perfect. Yes, sir. On the back screen, it's there only. So I think we can start the music again, and or all the voting has been completed. Again, we will start the voting again. So I think you have the ECG on one screen and the options there. So you can start the music, and now you can vote. And after pressing the right option, you have to press OK. So young patient with sudden onset dyspnea on exertion and chest pain with a normal heart. So we have total 70 voters and perfect. So most of them have answered it as C, SVT with aberrancy. So, sir, you would like to take forward?
I think audience may someone can talk who has given answer, no?
Sorry, ma'am?
Audience, whosoever
Yeah, definitely,
someone
ma'am.
can take over, like it's a white QRS regular tachycardia. And it's, so how do you walk through the ECG? So it's a white QRS regular tachycardia. What is the bundle branch? It's a bundle branch, left bundle branch block kind of tachycardia. Then next what you see is, it's the axis. It looks like a normal axis tachycardia. Then next what you see is, it's a typical left bundle branch block or atypical left bundle branch block to differentiate it from VT or SVT. So it looks like you're having a typical left bundle branch block. So it's a fast tachycardia. It's difficult to appreciate P waves. At least I'm not able to appreciate P waves, whether it's associated or dissociated. So faster tachycardia, sometimes you are not able to appreciate it. But yes, your initial part also is very sharp part. If you see LBBB initial part, so it's going through some conduction system. So if it's a VT, the initial part will be little wider part. Your other options were fascicular VT, but fascicular VT you will have right bundle branch block kind of morphology. It's a left bundle branch kind of morphology. It's not sinus tachycardia, not able to see P wave before the QRS. So I think mostly, as most people have answered it correctly, like the
Yes,
maximum chances is your SVT with aberrancy. So anything if someone wants to add.
Yeah, so I think most of you have answered it correctly as SVT with aberrancy. And as mentioned by both the doctors, that most important thing is the initial deflection. If the initial deflection is fast, probably we are dealing with an SVT with aberrancy. And if the initial deflection is slurred, then probably we are dealing with some kind of ventricular tachycardia. So coming to the next question, yeah. So case 2, he's a 40 years old male with history of giddiness or pre-syncope since last 3 years. So this is the ECG, and these are the options. So can we get the ECG here? Okay, Perfect. So this is the ECG, and that are the options. We can start the music now. So most of them have answered as torsades d pointis, that is option C. So anyone would like to explain the ECG? Anyone? Can you give the mic to Dr. Manoj? I think he wants to answer. Dr. Manoj, please stand. You can come forward. Okay. So you mean to say that there is an R-on-T phenomenon and varying morphology. So that is why you are telling torsades d pointis. Okay. Any comments, ma'am?
So I think it's very nice what you said, it's a long QT and it's torsades. So usually R on T phenomenon doesn't happen with the first PVC. You can see it is starting on T, but usually the second PVC, which is happening on the T wave, initial component of the T wave of the first PVC, is inducing your torsades. How do you manage this patient? Should search for the causes of the long QT first. It's acquired or congenital. So directly will not give magnesium, but yes, that's a good answer. Very good answer. You can think about magnesium, but search for the causes, whether it's acquired or congenital. And electrolytes is one of the most common cause, followed by some drugs. If you have given, if patient is in ICCU, so give a lot of antibiotics to the patient, or patient is having electrolyte imbalance. But if this patient comes, he has said that the patient has come with syncopal episodes.
Yeah, pre-syncopal episode.
So think about congenital long QT syndrome.
So what will be the treatment, Dr. Manoj? Suppose you have already ruled out the secondary causes of the long QT syndrome, and you have diagnosed in this case as a congenital long QT syndrome. So what will be the management for this patient? Give? What do you want to do for this patient so that he doesn't have syncope or, ICD implantation? So this patient requires an ICD implantation. So actually, the answer is right, torsades d pointis. And again, there was a history of sudden cardiac arrest in this sibling. So we are dealing with long QT syndrome. She was treated with beta blockers and underwent ICD implantation. Yes, you're right. So coming to the third case. So he's a 28 years old male with history of palpitation since last 5 hours. TROP-T was done, echo was done, which was normal. So this is the rhythm of this patient, and these are the options. And can you tell us what is going on so we can start the voting? Perfect. So you can vote. So there are 70 voters. So there is no negative marking. So I would like everyone to vote. Young patient with sudden onset palpitation. So I think in fact, most of the people think that it's, so can we get the voting? Yeah, so most of the people think that it's SVT with aberrancy. Perfect. Yeah. So, so anyone would like to answer the question?
So very direct question. You say field narrow QRS. What is the cause of that?
I think ma'am wants to answer there. Can you give the mic to ma'am, please? The black shirt. Mic, please. Black shirt, ma'am, please. Please answer the question. So what do you feel, what is this beat? The sixth beat? Yes. You're right. Don't worry, you're right. Can you tell again, what is this beat? So she's telling capture beat.
So fusion beat and intermediate QRS. Intermediate QRS between sinus and that, and timing would be almost same when the capsule is approaching. Capsule beat would be little earlier, and it would be absolutely narrow QRS or baseline QRS.
So what will the management, ma'am? Apart from the medical management? Ablation, yes. So it's fascicular VT, and coming to my next case, she's a 67 years old female with history of chest pain and sweating 2 hours ago. So when she came to ER, she had cold, clammy skin. She was in shock, and bilateral basal crypts were present. So this is the ECG of the patient, and I think these are the options. So this is the ECG, and these are the options. A 67-year-old female patient with history of chest pain, and on exam, we can start the timing, we can start the music. And on examination, she has bilateral crypts, and she is in cardiogenic shock. The options are there. So we have 70 voters. I want everyone to vote, please. Okay, so most of the doctors feel that it's RV ST elevation MI. Okay, so anyone would like to explain the ECG? So we have exciting prize for them also, who would from the audience who would explain the ECG correctly. Anyone would like to explain? Anyone? Yeah, I think sir wants to explain. Kishore, wait. Sir, okay. So, so you mean to say there is an ST elevation lead in lead V1. That is why it's RV ST elevation MI. Uh, okay, sir. Okay. So, sir, you would like to comment? Dr. Kishore, you want to answer the question, I think? Left main pattern ECG. Okay. Okay. Yeah. Perfect. Perfect. So you mean to say there is an ST elevation lead AVR also in lead V1 and widespread ST depression, so going in favor of left main pattern. Okay. Sir, you would like. So would like to thrombolize the patient? Perfect.
AVR suggests like it's a very proximal block. It could be left main or it could be osteal phalangeal artery. But do you want any apart from lead? Do you want any other lead in this patient? Suppose you see this kind of ECG and you want to see really which territory is involved more. You want to see any other leads?
Any other leads you want to get in this patient? You want the technician to tell you want any other lead? Any other lead means any other area. V7, V8, V9.
V3R, V4R, V5R.
Exactly. Who answered?
Right ventricular.
Perfect. Perfect. Yeah. So the answer is left main pattern, and I think we will take this patient to the emergency in emergency situation to the cath lab. Answer is basically none of the above. Yeah, and very few of them answered it correctly. So coming to the fifth case. So he is a 68 years old male with a history of sudden onset breathlessness. So what is the diagnosis in this patient? This is the ECG and these are the options. So we can have the options over there and we can start the music. So a 68 years old female with a history of sudden onset breathlessness on exertion. Sudden onset dyspnea, I would say. Okay, so most of you feel that it's pacemaker with inferior wall MI. Okay, so anyone would like to explain this? Anyone?
Yeah, any volunteer? This is
Anyone? All of you have mostly voted it rightly.
an elaborated answer. Like it's the
Yeah.
answer is only inferior. So before more than that.
So any of our DM, residents or students, you want to answer the question? Please, please, please. Please give mic to that blue shirt guy. Yeah, sitting beside ma'am. Yeah. So please explain in detail about the ECG so that our physicians understand. Okay, so you mean to say that this patient has been implanted a pacemaker with inferior wall MI, with probably a posterior wall MI. And what about this, sir? Any comments on this lead, V5, V6 elevation? Sorry? You're right. Exactly. So we are dealing with a pacemaker implanted pacemaker with inferior posterior lateral wall MI. Perfect. Any comments, sir? Sir, Ajay, sir. Sir, please come here, sir. Okay. Okay, sir.
So the important thing is that when a patient has a pacemaker and for inferior MI, you don't need any criteria. So the Garbosa criteria is all for anterior method. So for inferior MI, you don't need any criteria. So you can see clearly estimation to the area. And the important thing is reciprocal changes. So V2, V3 is significant depression with V5, V6. So it is a very large area of infarction. It's a correct is inferior plus posterior plus lateral MI. And if you see there's a PA, AB division or PA division, it means it's a single chamber pacemaker.
Yes.
Single chamber pacemaker.
Important. Perfect, sir.
Posterior and lateral.
So an additional question, RCA or circumflex?
Left, sir. Left circumflex.
Circumflex, who said?
Yes.
Yes, explain please.
So because sometimes left circumflex supply inferior wall as well as posterior wall along with lateral wall as is known as wraparound phenomena. All take.
Why not RCA? What goes against the RCA? What goes against the RCA?
V1, V2 will have ST depression only. Third elevation is more than second. So that goes in favor of RCA.
So that is why we have a talk on ECG localization for MI, sir.
Yeah.
By Dr. Niti ma'am. So
Yeah, I think it is a dominant RCA.
yeah. So anyone would like to tell what sir mentioned about this Garbosa criteria? So sir mentioned that with a temporary pacemaker implanted pacemaker patient or a LBBP patient, it's very easy to diagnose an inferior wall MI. So what about anterior wall MI? How will you diagnose a patient with left bundle branch block or a paced rhythm ECG with an anterior wall MI? About this Garbosa criteria. Anyone would like to answer? Anyone knows about that criteria? I think Dr. Kishore wants to answer. Dr. Kishore, please tell about the criteria. Mic, please give mic.
If discordant ST elevation more than 5 mm
Okay.
and ST depression more than 1 mm in V1
Okay.
to V3. And, sorry sir, discordant ST elevation more than 5 mm, concordant ST elevation more than 1 mm and discordant ST depression more than 1 mm.
Okay.
These are the three.
Okay. Yeah, I think he wants
Sir,
to answer.
in V1 and V2, there is a discordant ST elevation of more than 5 mm and
Perfect.
concordant ST depression of more than 1 mm. And in V6, there is a concordant ST elevation of more than 1 mm is known as modified Garbosa criteria.
It's perfect. So suppose that criteria is met and you have a patient with this LBB with MI. So what will you do? You will manage the patient conservatively or you will take the patient to the cath lab immediately. So you don't have an ST elevation as such. So still you would like to take the patient to the cath lab or you would like to manage the patient conservatively? New onset LBBB with meeting this criteria. New onset LBBB who patient has met all the criteria for MI. So what will you do? You will take the patient to the cath lab or you will manage the patient medically right now? Cath lab, perfect. Yeah. So, yeah. So the sixth question. So he's a 25 years old male with history of sudden onset palpitation. So this is the ECG and we can have the options over there. Yeah. So this is the ECG and those are the options. We can start. A 26 years old male patient with history of sudden onset palpitation. So most of you feel that it's atrial tachycardia from superior pulmonary vein. Perfect. Who wants to answer? Who wants to describe the ECG? Before we take expert opinion from all our respected seniors, anyone would like to explain the ECG? Anyone? Most of you have, got the right answer. Yeah, please give the mic to that. So what's your name? Doctor? Sheikh. Dr. Sheikh, please.
So it's a narrow-complex tachycardia, and P wave is inverted, which is coming before the QRX complex, and there is a PR, RP interval is longer than PR interval, so basically it's suggestive of atrial tachycardia with locus mavis pulmonary vein.
So, I think, sir wants to, please.
Yeah, I think Dr. Kush just put that to confuse everybody. So you were right, this is long RP tachycardia. It's a regular narrow QRS tachycardia. The RP interval is longer than the PR interval. It's a long RP tachycardia. Now the classic diagnosis, differential diagnosis for this is one is going to be atypical AV nodal reentrant tachycardia. Okay, that is fast, slow or slow, slow AV node reentry. Second is ectopic atrial tachycardia. And third one is what is mentioned here at the bottom, PJRT, permanent junctional reciprocating tachycardia. So, and even if it is a ectopic atrial tachycardia, look at the morphology of the P wave. You correctly mentioned P wave is negative in inferior leads. So it cannot be coming from the superior pulmonary veins. If at all, it will be coming from somewhere in the lower region. It could be from the right inferior pulmonary vein, it could be from somewhere in the junctional region. So basically these are small skinny P waves, short skinny P waves, negative in inferior leads. So they are coming from somewhere in the AV nodal region. And all these three differential diagnoses, the mechanism of the arrhythmia the focus is somewhere in the AV nodal region. So ectopic atrial tachycardia, probably somewhere in the coronary sinus os region. Or atypical AV node reentry, fast slow tachycardia, which is again in the AV nodal region. And third is, we call it permanent junctional reciprocating tachycardia, but it is not a, it's a misnomer, it's not a junctional tachycardia. It's actually a type of accessory pathway which conducts slowly. So that is why it gives this long RP morphology. But again, this pathway is somewhere close to the coronary sinus os region. So all these three mechanisms are arising from somewhere in the AV nodal region. The atria are activated retrogradely from below upwards, so the P wave is negative in inferior leads, and they are short, small, skinny P waves. So septal region, both the atria are activated simultaneously. So in fact, the right answer would be PJRT in this because there are no other diagnoses available here. So any idea how you take care of PJRTs? What does PJRT produce? What is the problem with PJRT? Especially in a young person like this. There's a 29-year-old gentleman having PJRT. The name itself, permanent junctional reciprocating tachycardia. That means the tachycardia is going on for a long time. And if a tachycardia at this rate, 150, is going on for hours, days, weeks, months together, what will it produce?
Exactly.
Absolutely, tachycardiomyopathy.
The best part is when you ablate the tachycardia, most of the times the cardiomyopathy reverses and the ejection fraction comes back to normal.
Yeah, so this patient was in this rhythm most of the time during his Holter. Though his LV functions were normal,
yeah, it was normal, sir.
But very symptomatic, and we did radiofrequency ablation. Now he's doing all right. So as sir said, all three differential diagnoses of long RP tachycardia are right, But Dr. Kush wrote superior pulmonary vein just to prove that option wrong. But atrial tachycardia is definitely a DD in this.
Perfect. So moving to the next question. So answer is T, PGRT. So she's a 44-year-old female with history of sudden onset palpitation, and she has frequent hypertensive crisis, episodes of hypertensive crisis as well. So this is the ECG which was taken during episode of palpitation and accelerated hypertension, and those are the options. So we can start that timer. Yeah. So what are we dealing with in this patient? History of sudden onset palpitation and accelerated hypertension in a probably young female. So bidirectional VT. So most of you have answered it as bidirectional VT. So many of you have also, chosen the option as none of the above. So what do you feel? What is the answer? Those who have opted for none of the above, or anyone would like to explain the ECG in this patient? Anyone? Any volunteer from the, you want to answer the question? You can come, you can answer, no issues. Don't worry, even if you're wrong, nothing will happen. And if you're right, maybe you can get a prize. Okay, okay, sir. What have you answered? Then you have to come forward.
I have answered it as bidirectional VT.
And why?
Because the QRS morphologies axes are changing with each beat.
So the axis is changing with every beat. So it's an LBBB morphology, VT. And LBBB morphology is remaining same. Only the axis is changing, you mean to say?
But in the V5, V6, the
Okay.
alternate beats are having the different QRS
Okay.
direction.
Okay. And why VT? So bidirectional was very easy. So this was a relatively easier ECG. And what are the causes of, what can be the causes of bidirectional VT? The next question.
Digitalis toxicity.
And?
CPVT.
Any other cause, you know?
Anderson-Tawil syndrome.
Okay. Okay. So, perfect. So this is actually bidirectional VT in this patient. And she actually had pheochromocytoma. And because of that pheochromocytoma, she had episode of sudden onset palpitation and hypertensive crisis. And that is the reason she had this. And we can see, some sort of AV dissociation over here. That is why it's VT. So we can come to the next case.
This is a highlight that you should see for the systemic diseases in the patients. Don't run and ablate each and every case.
Sorry, ma'am.
We should not be thinking of cardiac as a cause for each and every case. It's really unusual case. It's
Yes,
and
ma'am.
I think
Yes.
it should be reported.
Can be,
It's
sir.
really
Can be.
unusual case. It's bidirectional VT presenting as an extra cardiac reason of a bidirectional VT because we always search for the cardiac cause. And I think sir is highlighting that the systemic disease issue. We had one case of pituitary adenoma who had gigantism presented with incessant VT, and as soon as the pituitary adenoma removed, everything went off. So I think it's a highlight to search for the systemic causes in these patients.
So because she had sudden onset, hypertensive crisis, episodic palpitation, so she was evaluated for pheochromocytoma as well. And then it came out to be pheochromocytoma.
Okay, that's a coincidence because bidirectional VT, pheochromocytoma is not.
Yes. Yes, sir. Yes. So coming to the 8th case, 58 years old male with history of sudden onset breathlessness and altered sensorium. So this is the ECG. So we have the ECG over here and we have the option. So 58 years old male with history of sudden onset breathlessness, we can have the music on. So I want maximum number of vote in this case. It's a very, very easy ECG. and a very common ECG which you come to you can see in day-to-day basis in an emergency. Okay, so most of you have answered it as D. So again, anyone would like to explain the ECG? Anyone? It was an easy ECG. You want to answer? Anyone? Please come forward. You want to answer? Please come. Yeah.
Irregularity
Yes.
broad complex. Sometimes
Okay.
it becomes shorter and then
Yes.
I don't much explain about it, but
No issues. Yeah.
What is your guess of quotation in this ECG?
I didn't ask you because the patient has a sudden breathlessness and it can be hyperkalemia also. It can be hyperkalemia also because hyperkalemia also the patient can present with VF also or VT also. More than 8 or no, more than 7, 8.
So anyone else would like to explain this ECG? Anyone? Anyone you want to answer? Dr. Kishore, please come. Please explain this ECG.
This is a sine wave pattern.
Okay.
And this is mainly due to hyperkalemia. In this ECG, the P wave well defined between wide QRS complex and tall tented T wave. They're slightly changing the morphology and become wide.
Yes.
Most likely sine wave pattern.
Okay. So, what will be the management for this patient?
Sir, insulin drip.
Insulin drip. Okay. And you want to manage hyperkalemia, you mean to say? Okay.
Yes,
fine.
Sir,
So, any comments, sir? Can you tell the stages of hyperkalemia? ECG manifestations of hyperkalemia as such.
Tall tented BP.
The ECG corresponds very well to the potassium level, and at each level you will get changes. Unless it's sort of chronic hyperkalemia, when you may not get the exact ECG pattern which is described. But whenever there is acute hyperkalemia which is occurring, the ECG changes pretty much correspond to potassium level. And when you look at the ECG, even before you get your electrolyte levels, which may take half an hour or more, you should start treating, because this patient will not give you too much time. You have to start treating immediately on your instinct after looking at this ECG. And you will be able to save the patient's life.
And you might require hemodialysis as well in this patient if if you're not able to correct the hyperkalemia. Perfect.
So I think rightly many of them have reported it as polymorphic ventricular tachycardia because there are various kind of morphologies.
Yes, sir.
But the fact is this is not tachycardia.
Exactly.
This is bradycardia. So hyperkalemia will lead to bradycardia. So first to mention tachycardia, it should be tachycardia. It is not a tachycardia.
So the heart rate is more or less 100 beats per minute, and it is varying.
So one point I also want to make about this is that actually the CCG needs to be looked very carefully, and it is very important to rule out an artifact on this ECG. It is a mere fact that the patient is symptomatic with this ECG and having breathlessness, that this just cannot be an artifact, and the electrolytes need to be immediately checked. This is a wide QRS sine wave pattern ECG. There is no atrial, maybe a sinus arrest or a atrial rhythm is not seen. And the mere fact that the patient is symptomatic catches this as electrolyte disturbance. The other, as Dr. Jitendra pointed out, that polymorphic VT cannot be the thing in this because this is not a tachycardia.
Perfect. So many times these patients will receive shock by the time the ABG report comes. So coming to the next case. So it's basically a spot diagnosis. So this is an ECG and what we are dealing with. So this is the ECG and those are the options. So we can start the time music. A relatively easier ECG. most of you feel it's SVT with aberrancy. And okay, and then atrial fibrillation with fast ventricular rate. Perfect. So who wants to answer this question? Anyone want to answer that question? Anyone? Okay, I think Dr. Abhishek wants to answer. Please. Dr. Abhishek, please come. So what do you think, what we're dealing with? Please give mic to Dr. Abhishek. We have only 4 options. Just explain the ECG first and then come to the diagnosis.
Sir, it is SVT with aberrancy.
SVT with aberrancy, okay. And
Because,
why?
Sir, because all the other 3 have been ruled out actually.
So can you speak loudly?
All the other 3 have been ruled out, sir. VT, it is not VT because there is not the QRS concordance, not the extreme axis deviation, so it is not VT. And atrial flutter with 2:1 AV block, it is also not there, sir, because why there is the LBB type of pattern is also in there.
Okay. So you have ruled out atrial fibrillation, you have ruled out atrial flutter, very rightly. But how can you rule out VT? How have you ruled out VT in this ECG?
Sir, actually,
So what is the hallmark of VT?
sir, the AV dissociation.
So can you see AV dissociation in this ECG?
Dur hai, sir.
Now you can see? Or no? So you can't see from there?
Yeah.
Okay. So anyone else wants to answer this question? So actually yeah, I think someone wants to answer. Please, ma'am.
Sir, it's a narrow QRS complex with absent P wave and it's a regular. And with aberrancy is because VT is broad QRS complex and there is a QRS complex of 0.15 second around.
Okay.
So we could
So you mean to say that every narrow QRS complex is SVT and not VT?
with aberrancy, SVT with aberrancy,
So what is the QRS duration over here, ma'am?
around 0.15 seconds.
I mean 110 maybe, or less than 120 you mean to say?
Yeah.
So less than 120, so we are not dealing with VT.
Yeah.
So again, if you have a narrow QRS complex tachycardia, we can't have VT. Am I right?
Yeah.
So am I right or wrong?
Yes, you are right.
Wrong. So please answer. So we can have narrow QRS tachycardia in VT. Exactly. So we can have a narrow QRS tachycardia with a VT if you are dealing with a VT arising from the conduction system. So what is the hallmark of VT in an ECG? AB dissociation. So you have to look for AB dissociation. So can you see AB dissociation in this ECG? Where? See, very easily in this long lead 2, we can see AB dissociation in this ECG. So we have to look for AB dissociation in an ECG. So probably we are dealing with VT in this ECG and most likely maybe coming from the conduction system. Sir, any expert opinion?
Yeah, so let me, so it is a regular tachycardia and it's easy to call it narrow QRS, but whenever you are looking at QRS width, you have to look at the QRS which is widest.
Exactly.
So look at the precaudal leads. In V5, V6, the QRS is wide. So whenever you are calling a tachycardia either narrow or broad, you have to look at the widest QRS and then decide whether it's wide or narrow. Okay? Because calling it narrow, you are mitigating your responsibility by treating it like SVT. You might end up with trouble. So this is a regular wide complex tachycardia. It's not as wide as you see in other VTs because the focus could be from somewhere in the septum. And whenever there is simultaneous activation of both ventricles, the QRS may not be that wide. So you may get a narrower looking wide complex tachycardia. And whenever we talk about AV dissociation, technically this is more correct to call it VA dissociation because the driver is the ventricle.
Yeah.
The QRSs are more, the atria are less. R waves are more, P waves are less. So more ventricular activity, less atrial activity. So it's VA dissociation more likely. I would also call it, instead of calling it VA dissociation, with such ECGs you actually have to sit with a ladder diagram and draw it. You may actually get something like 4:1 VA conduction. That is why the P wave is negative in inferior leads. right? If it was complete VA dissociation, the P wave would be positive whenever it would come. But whenever it comes, the P wave comes after the QRS, it comes after every fourth QRS, and it's negative in the inferior leads. So it's VA 4:1 conduction, which is good enough. The ventricle is the driver. The arrhythmia mechanism is arising from the ventricle, VT.
Perfect.
So what is the background of this patient? What is the VT?
So, sir, actually, I think he had ARVC. If I'm not wrong, he had this. He came with this, sudden onset tachycardia, which was cardioverted. He had hemodynamic compromise, and then in the baseline ECG, we had suspicion of some sort of ARVC. Did a cardiac MRI.
Do you have the sinus rhythm ECG?
So not in this PPT. I have the whole case with me. So
Sure.
he underwent cardiac MRI, which was suggestive of ARVC. So we tried radiofrequency ablation as well, and then ultimately he required an ICD. So we implanted an ICD and did an RFA as well in this patient. So coming to the 10th case, last case, perfect. So a 50-year-old patient with implanted pacemaker for complete heart block presents to us with this ECG. And so this is the ECG and these are the options. So what we are dealing with, some sort of pacemaker malfunction or some sort of fusion complexes or pseudo fusion complexes or something else we are dealing with. Pseudo fusion complex versus conduction system pacing. So anyone wants to answer this question? So what is pseudo fusion complex? So anyone wants to answer this question? Anyone? From the first bench, anybody want to answer this question? No? Dr. Manoj? No, please come. Please come and answer this question.
This is the paced rhythm, sir.
Sorry?
Paced rhythm.
Paced rhythm, perfect.
Yes, sir. And ideally it is like conduction system pacing.
Okay, why? So what is conduction system pacing first?
Sir, if we pace the like in the his bundle or then that is called conduction system pacing.
Okay, so you pace the conduction system. So when you pace the conduction system, that is called as conduction pacing. We can pace either his bundle or the left bundle.
Yes, sir.
Okay. And so the QRS is narrow or wide?
Sir, wide complex QRS.
Sorry?
Wide, sir.
Wide. So how much is the QRS duration?
Sir, around approximately 120. Yes.
Okay, so 120 is wide. Okay, so you are.
It's not more than 100 milliseconds. Not
So usually in a paced rhythm, you get a broad QRS or a narrow QRS.
In paced rhythm, sir, we will get.
Whenever we pace the apex or the septum, you get a broad QRS or a broad QRS. So what is the advantage of this conduction system pacing?
Sir, we will get the narrow QRS.
Narrow QRS and clinical outcomes. What will you have from the clinical
Sir,
outcome
in clinical
point of view?
outcome also, sir, if we pace the conduction system, then both the ventricles will
Okay, perfect.
contract simultaneously. So then ventricular both the simultaneously pacing. If we pace in the one ventricle, then broad QRS complex will be there.
Okay, and regarding the ejection fraction outcomes,
Yes,
any
sir. Ejection fraction will be better in case of conduction system pacing, sir.
Okay, perfect, sir. Perfect.
So
Sir.
suppose you take out the spikes. Suppose you take out the spike, and then what do you say? It's a normal ECG or abnormal ECG?
Sir, every QRS is preceded by P waves. That is.
So all P are followed by QRS. So obviously it's a sense V pace going on, but
Yes,
suppose
sir.
you take out the spike. So what would you say? It's a normal ECG or abnormal ECG? Probably say, what will you say is an incomplete RV, little small RSR pattern in V1
Yes,
or
sir.
small S in 1, lead 1.
Yes, sir.
So if you're pacing the ventricle, you cannot have one S wave in V1 or RSR pattern in V1.
Sir.
So this is like, if suppose you take out the pacing spikes, probably it's more like almost like a normal ECG.
Yes,
so when
sir.
do you get normal ECG? When you're doing a conduction system pacing, either a his bundle or a left bundle pacing.
Sir.
And this QRS duration is not more than 100 milliseconds, not
Yes.
120. Good.
So the advantage of conduction system pacing is, so this is basically conduction system pacing, and this was the patient ECG. He had complete heart block on temporary pacemaker, and this is how you actually do conduction system pacing. So this is the right ventricular septum. So the lead is throughout inside the right, from the right ventricular septum towards the left ventricular septum towards the left bundle area. So the whole lead is inside the septum, and then you get this QRS. So we calculate the LV activation time in lead V5, V6, which is also very narrow, which is suggestive of this conduction system pacing. So you will get more and more these kind of ECG in coming days. So I think, sir, we can end this ECG session. And as far as the result is concerned, it will take some time, and maybe we have some sort of tie also. So we have some tie breakers as well. So in coming sessions, we will let you know who is the winner, and if we have tie, then we can probably call them, and we have few ECGs as well to give the prizes. Okay, thank you so much. So we can start the second session. Ma'am, you want to present first?
So thank you very much. It was really engaging and entertaining session. Thank you very much for your active participation. For the next session, I would like to invite chairpersons Dr. Arvind Sharma sir, Dr. B.M. Goyal sir, Dr. Deepak Gupta sir, Dr. G.L. Sharma sir, Dr. Nikhil Chaudhary sir, Dr. Supriya Jain sir, Dr. Rahul Ajmera sir, Dr. Pushpendra Garg sir, Dr. R.D. Pandey sir, Dr. Ram Chitlangya sir, Dr. Rohit Chopra sir, and Dr. Sahil Jindal sir. Please come forward. May I request Dr. Kush Mehrotra sir. Dr. Sahil Jindal sir. Thank you. And may I request our next speaker, Dr. Kush Kumar Bhagat sir, for the presentation. Thank you.
So thank you so much for your patient listening. And we come to the second session, the ECG session. And again, I hope that it will be an interactive session. So very basic topic, ECG in bradycardia. I'll explain in very brief about the ECGs which we see, the bradycardia ECG I mean to say. So we all know about this, the conduction system, the SA node, the AV node. So we can have problem in the SA node, we can have problem in this AV node, again in the His bundle, or further down, which can cause bradycardia in any patient. So first of all, dealing with these problems in the sinus node. So what is sinus node dysfunction? So sinus node dysfunction is, we have actually 5 things which can tell us whether we are dealing with sinus node dysfunction or not. First is sinus bradycardia, rate less than 60 beats per minute. Sinus pause, when we have a sinus arrest for 3 seconds, and sinus node depolarizes for more than 3 seconds after the last atrial depolarization. I have the ECG, I will show it to you. Sinus node arrest, no evidence of sinus node depolarization. Chronotropic incompetence, which is defined as inability of the heart to increase its rate with increased activity or demand, and approximately 80 to 85% of the expected heart rate reserved during exercise. If anyone, it's failure to attain this much value, then we label them as a chronotropic incompetence. We come to know by treadmill test. And tachybrady syndrome, very important. We have episodes of bradycardia, and we have episodes of tachycardia in the same patient. Tachycardia can be atrial fibrillation, atrial flutter, or any sort of abnormal atrial tachycardia. So first, this is a sinus bradycardia ECG, heart rate of approximately 40-50 beats per minute, with every QRS is preceded by a P wave. Sinus pause, this is a P wave QRS complex, again a P wave QRS complex, then we're getting a long pause, and then again a P wave and a QRS complex. So this is a sinus pause, and sinus node depolarizes more than 3 seconds after the last atrial depolarization. This is basically a definition. But if we have a pause and then again the sinus activity gets resumed, we call it as a sinus pause. Sinus node arrest, there is no evidence of sinus rhythm or a sinus node depolarization. We can see there's a long pause, then probably this is a junctional rhythm, no sinus activity in this patient. Episode of tachycardia, which terminates, and then we are getting a long pause, again an episode of tachycardia. So we are dealing with a tachycardia and a bradycardia in the same patient. We call it as a tachybrady syndrome. So this is all we have for the sinus node dysfunction. Now coming to the AV node dysfunction, as we all know about the first degree AV block, when we have a PR interval, the normal PR interval is from 120 to 200 milliseconds. Whenever we have a PR interval of more than 200 milliseconds, then we are dealing with first degree AV block. We call it as a first degree AV block, prolonged PR interval. So this is a normal PR interval, and then we can see a P wave and a long PR interval. So this is first degree AV block with the first degree AV block with 380 milliseconds, more than 200 milliseconds. Second degree AV block, again categorized in 2 types, Mobitz type 1 and Mobitz type 2. So what is Mobitz type 1 second degree AV block and Mobitz type 2 second degree AV block? So second degree AV block is basically present when some of the atrial impulse fails to conduct to the ventricle. So if we talk about Mobitz type 1, in Mobitz type 1 second degree AV block, we call it as an AV Wenke-Back block as well. It is characterized by gradual PR interval prolongation prior to block of an atrial impulse. So we can see there's a P and an R PR interval and a QRS, then there is a gradual prolongation of this PR interval. This PR is more than this PR, again this PR is more than this PR, and then we have a P wave which does not gets conduct to the ventricle, and then again the normal PR interval it starts. So we are dealing with Mobitz type 1 second degree AV block, and the important thing to note is that this type of block, it is usually localized to the AV node and associated with a normal QRS duration, although sometimes we can have bundle branch block present as well. It is seen most often as a transient abnormality with inferior wall MI or drug intoxication, particularly digitalis, beta blockers, and occasionally with calcium channel blockers. So in short, if you have some sort of group beating in the ECG, we are dealing with a Wenke-Back type of AV block, group beating. So this is, we can see this ECG, even if you don't look at the PR interval very carefully, we can see that this QRS, these comes in group. So we are dealing with some sort of Mobitz type 1 Wenke-Backs. So this is PR interval, gradual prolongation of this PR interval, then a P wave, it drops, does not conduct to the ventricle, Then again a small PR interval gradually prolongs, and then this things happens again. So this is Mobitz type 1, type 2 AV block. Mobitz type 1 second degree AV block, and coming to the Mobitz type 2 AV block. In Mobitz type 2 second degree AV block, which is more advanced form of AV block as compared to type 1, conduction fails suddenly and unexpectedly without a preceding change in the PR interval. So if we have a look at this ECG, this is a P wave PR interval QRS complex, then a P wave does not conduct, P wave does not conduct, then a P wave conducts, then does not conduct. So we are dealing with 2:1 AV block with RBB morphology and a posterior fascicular block. So this is sinus rhythm with 2:1 AV block, and most likely, since the important thing to recognize in this block is there's a high incidence of progression to complete heart block with an unstable, slow, low escape pacemaker rhythm, and therefore pacemaker implantation is very important in these kind of patients. And this block may occur in setting of anteroseptal MI or in the primary or secondary sclerodegenerative or calcific disorders of the fibrous skeleton of the heart. So, and usually we have a broad complex escape rhythm in these patients, and so this is the ECG of this patient with RBBB with left posterior fascicular block and Mobitz type 2. Mobitz, this is 2:1 AV block. And coming to the complete heart block, there is no evidence of AV conduction. I think we see these kind of ECG daily, almost daily in our emergency. So P wave, there is no correlation between the P wave and the ventricular complex, the atrial complex and the ventricular complex. There is no correlation. There is a complete AV dissociation going on. So we are dealing with complete heart block with escape rhythm having a morphology of right bundle branch block. So what is advanced or high grade or high degree AV block? So more than two consecutive P wave at a constant physiologic rate that do not conduct to the ventricle with evidence for some AV conduction. So basically you have some sort of AV conduction, and then we have a long pause with kind of intermittent complete heart block, or actually we call it as a high grade AV block. So if we have two or more than two P wave which does not conduct to the ventricle and some evidence of conduction to the ventricle, we are dealing with high grade AV block. So this is all about the sinus node, about the AV node block. Now again coming to the question and answer session, I think I have few minutes left. So this was the ECG which was recorded from 75 years old woman who complained of attack of dizziness. So what is happening in this ECG? So who would like to answer? A very simple question. Anyone? Anyone can answer. What is, so I'm dealing with bradycardia ECGs. So what is happening in this ECG? Anyone would like to answer? Dr. Kishore, please answer. First degree block. So very easy. So it's first degree block because the PR interval is prolonged. So how much is the PR interval? I think it's obviously more than 200, maybe 240 or 280 milliseconds PR interval. So what will you do? You will go for a pacemaker implantation in this ECG for this patient. Suppose a patient comes to you. So you are a cardiologist and a patient comes to you with history of dizziness and this first degree block. So you are going to implant a pacemaker, or you will evaluate further? Sorry? Okay, please give mic to him. So please tell. So you want to evaluate further, or you want to opt for pacemaker, or refer to me for pacemaker implantation?
We evaluate to other causes of first degree AV block.
Okay.
If these are normal, then we go for pacemaker.
Okay, so you want to evaluate for other causes of first degree AV block and then implant a pacemaker.
नहीं, यदि अपन को कोई correctable cause नहीं मिलता,
नहीं मिलता है, नहीं मिला, कोई correctable cause नहीं मिला, suppose
नहीं मिला और patient symptomatic है तो we go for pacemaker.
So without even demonstrating that patient has higher degree AV block. So you mean to say that if patient is having first degree AV block and you don't have any other cause of first degree AV block and patient having dizziness, you go for pacemaker implantation. So basically you have to demonstrate. So first degree block, so basically in this ECG, this is obviously first degree AV block with the PR interval prolongation, and it is basically first degree block is of no significance as such, But since this patient has history of dizziness, so there might be episodes of second or third degree AV block associated with this. So there is some problem in the conduction system. So you have to evaluate further before referring the patient for pacemaker implantation. Probably a Holter monitoring or some sort of loop recorder, external or internal loop recorder, just to make sure what is happening at the time of dizziness in this patient. Whether this first degree AV block is progressing to higher degree AV block. And if it is progressing to higher degree AV block, or patient has intermittent high degree AV block, then you refer patient for pacemaker implantation. As such, first degree AV block itself is not an indication for permanent pacing. But with this patient, you should evaluate further. So that is important, not pacemaker implantation. So no need to oblige me. So what is happening in this ECG? This is, I think, a easier ECG. First degree, second degree, type 1, type 2, complete heart block. Anyone would like to answer? Anyone? I think Dr. Abhishek wants to answer. Anyone? This is a very easy ECG, so I don't have much time left. Sorry, yeah, please answer. Please stand up. So this is second degree heart block and Mobitz type 1 heart block.
Yes,
very nice.
Second degree with Mobitz type 1.
Yeah. So we can see the gradual prolongation of the PR interval before a P wave gets stopped. So we are dealing with Venki back. So we see we are getting a group beating. So this is Mobitz type 1 second degree AV block. So also called as AV Venki back. So this ECG, what is happening in this ECG? Anyone? Dr. Manoj, please stand up. 2:1. So this patient comes to you and complains of dizziness or pre-syncopal episode. So you want to evaluate further, you want to refer patient to me for pacemaker implantation?
If the patient is symptomatic with 2:1 block, we can go for the pacemaker implantation.
Okay. So what about the escape, 2:1 AV block with underlying left bundle branch block? So probably we are dealing with, this 2:1 AV block, it can happen with Mobitz type 1 or Mobitz type 2 also. So but with this, with the escape rhythm of broad QRS, more suggestive of second degree AV block. Mobitz type 2 second degree AV block. So yes, this patient should be referred for pacemaker implantation. So this ECG. This is an interesting ECG. Anyone would like to answer? Excuse me, please give mic to that green t-shirt. So you would, yeah, green back. So you would like to answer? Just explain what is happening in this ECG. Try to answer. I think I don't have options for this ECG. So this is a regular rhythm or an irregular rhythm? Sorry? Regular or irregular? Regular rhythm. So can we see a P wave in this ECG? P wave. Can you see a P wave in this ECG? So no P wave and a regular rhythm. So what can happen? Sorry?
Sinoatrial exit block.
Sorry, sir. Can you please repeat?
Sinoatrial exit block.
SA exit block. Okay. In SA exit block, but we have no P wave activity in this patient. Any kind of P wave activity in this patient.
Junction.
Also, if you look at lead V1, so can you see P waves?
Flutter.
Can you see P wave in this ECG in lead V1?
No.
Some P waves? No. So basically, these are actually, fine fibrillation waves. So with a regular rhythm, with this fine fibrillation waves, we are dealing with atrial fibrillation with complete heart block. So I think my time is over, and thank you so much for all your patient listening. Do we have time? 1 minute. Okay. So what is happening in this ECG? Anyone? Yeah, please answer.
WPW, pre-excitation syndrome.
Yes. We can see a slurring in the onset of the QRS with a short PR interval. So we're dealing with a WPW syndrome. I mean, pre-excitation with probably if patient has tachycardia, then we are dealing with WPW syndrome. And this is actually a 35-year-old female patient who is asymptomatic from cardiac point of view. And this is the ECG of this patient. She had 2:1 AV block, and she had intermittent complete heart block as well. So a young patient with an intermittent complete heart block. So how many of you would like to go for a pacemaker implantation in a young patient with complete heart block? So we won't go for pacemaker implantation until and unless patient has all these things. Patient is symptomatic, or in asymptomatic patients with ventricular dysfunction, prolonged QT interval, complex ventricular ectopic rhythm, wide QR escape rhythm, ventricular rate of less than 50 beats per minute. So probably then we have to go for a pacemaker implantation. Otherwise, in congenital CHB, probably don't have to go for any kind of intervention as such. Thank you so much. So any questions? So you can call the next speaker. You can call the next speaker, sir.
Our next speaker is Dr. Neeti Chadda. Please come. Thank you. She will be enlightening us on myocardial ischemia and ECG, localization, the culprit vessel.
Hello, good afternoon, everyone. I'm Dr. Neeti Chadda Negi, and I'm the head of cardiac electrophysiology at Metro Heart Hospital, Faridabad. First of all, I thank Dr. Makkar and the entire organizing team of EHCC for this kind invite, and I welcome all the delegates. My topic for today is myocardial ischemia and ECG, localizing the culprit vessel. So I'll try to make a sense of it. First of all, we all know what is a culprit vessel. The vessel wherein there is a plaque rupture and with the acute clot which forms inside the coronary artery, the blood flow is occluded, and there is a myocardial ischemia, or mostly a myocardial infarction which happens. And the good part of it is, the only good part of it is, we can recognize it on ECG, and we'll try to localize the culprit vessel on the ECG. Sorry. Okay. So I think in my presentation, this should be the most important slide, wherein I have tried to show the three coronary arteries: the right coronary artery, the left main, which gets divided into the left circumflex and the LAD, and the ECG electrode placement. So if we look very carefully, I'll try to point with a marker. So V1 falls on the center and V2 is there. So V1 and V2 are closely associated with the left anterior descending, and they also lie close to the septal vessels. And as we go laterally in the V3, V4, they are also close to the left anterior descending. And as we reach the V5, V6, these are the lateral lead placements, and they are somewhat close to the left circumflex, and then there are posterior leads. On the right side, the V1 also lies close to the right coronary artery, and then there is a V3R, V4R, and these are the right-sided leads. Okay. So V1, V2, the septals fall near. For the diagonal is mostly on the lateral side, and the V3, V4, V5, V6 are the important electrodes which signify the vessels when the coronary artery before the LED is involved, the diagonal is involved. So what all can we localize with the ECG? We can localize the left main coronary artery occlusion. We can also localize the LED when it is occluded proximally. We can localize the LED when it is occluded distally. We can localize the left circumflex occlusion, the right coronary artery from the proximal side or the distal side. So we'll try to see the ECG patterns which show what coronary occlusion is it. So before we start with the slides, first and foremost, we have to ensure that the lead placement is accurate. The V1 and V2, V1 is on the right side, fourth intercostal space. V2 is on the left side, again fourth intercostal space, both V1 and V2 abut the sternum. And V4 is on the mid-clavicular line at the fifth intercostal space, and V3 is between the V2 and V4. The V5, V6 is on the anterior axillary line, and the V6 is on mid-axillary line. So first of all, the accurate placement of the leads. Why are we discussing the ECG localization? Because ECG changes are mostly specific. They have got high positive predictive value. The specificity is good. Proximal, this is for the inferior wall MI, the proximal right coronary artery occlusion with right ventricular infarction. With the ECG changes, the specificity is 100%. And again, for the left circumflex coronary artery, the specificity is 96%. So a good specificity is there. And similarly, for the LED occlusion, the specificity of the ECG changes is good. So it's good to know the changes which happen with the occlusion. And with these diagnoses, we can do our clinical decision making. So this slide shows this is the predictors of LED occlusion proximal to septal leads and predictors of LED occlusion proximal to the diagonal. So if we look carefully, when we talk of LED occlusion proximal to septal leads, when we are talking of the septal arteries, we talk of the AVR lead, the V1, the right bundle branch block pattern. There is a ST depression in V5 and there is ST depression in inferior leads. So these are specific changes. When these changes cumulatively are seen, the specificity is very high. We'll see the ECG examples and we'll get to know. When we talk of the LED occlusion proximal to diagonal, when we are talking of the diagonal vessel, we are talking of the Q wave in AVL, and we are talking again of the ST depression. So one thing is important, when we are talking of the proximal LED occlusion, usually there is a ST depression which is there for the inferior leads, and for the precordial leads, we talk of the V1 and V5, V6 for the proximal to septal arteries, and when we are talking of proximal to diagonal, we are talking of AVL vessel. So again, these are the ECG changes which are there. Again, similar thing, proximal LED, you'll have a combination of things, ST elevation AVR, right bundle branch block pattern, ST elevation in V1, which can be more than 2.5 millimeters, ST depression in the inferior leads, and ST depression in V5, V6. So when again I'll specify this, we can again understand that LED occlusion before the diagonal. When we are talking of the diagonal, we have to look for the AVL leads. So Q in AVL and Q in V4, V6, that shows that the LED, you can say that the LED is occluded before the diagonal. And when there are in the proximal coronary LED coronary occlusion, there is a ST depression for the inferior leads. When we talk in context to the septal artery, LED occlusion before the septal arteries, we will have to talk about the AVR lead, the V1 lead, and there is an ST depression in AVL, and actually there are ST depressions available for inferior leads as well. When we are talking of the distal LED, then there is a ST depression in AVL, Q in V4, V6, and no ST depression for the inferior leads. For the distal LED, the inferior lead ST depression will not be there. For the proximal leads, the LED depressions, the ST depressions for inferior leads can be there. Now these are with some examples, it will be easy to know. The precordial leads are showing ST elevation in V1, V2, V3 and V4. So V1, V2, V3, V4. So we are talking of this particular area. Because there is an ST depression for V5, V6, this occlusion is proximal to septal artery, and there is an ST elevation for AVL and 1 and AVL as well. So 1 and AVL ST occlusion is before the diagonal vessel, and the ST depressions in the inferior leads. So a combination of this. So I'll again point out, we'll see V1 and AVR. V1 is ST elevation, AVR is ST elevation, and there is an ST depression of V5, V6. So ST depression of V5, V6 is occlusion is proximal to septal artery, and because there is a Q wave in AVL and there is an ST elevation of AVL, then it is proximal to diagonal as well. So this is a proximal occlusion of LED and needs to be emergently dealt with. This patient can get serious. So again an example, when we are talking in context to the septal artery, we have to talk of the V1 and AVR. Both are showing ST elevation, and there is ST elevation of the precordial leads. The V5, V6 are not showing neither ST elevation, and there is a slight ST depression in V5, V6, and so this is proximal to S1. So when there is a distal, now this is important, when this LED occlusion is distal to S1, see that the V1 is not showing any ST elevation, even the AVR is not showing ST elevation, the other precordial leads are showing ST elevation. So we know that this is not proximal to S1, this is distal to S1 which is there. And when there is the LED occlusion is happening distal to S1 and distal to D1, see that now talk of the distal to S1, there is no ST elevation in V1, there is no ST elevation in AVR. And because this is distal to D1, there is no Q wave in AVL as well. And even the inferior leads are showing slight ST elevation. So this is not a proximal LED occlusion, this is more of a distal LED occlusion is there. This is same, I have repeated it again. So septal artery, we have to talk of V1, we have to talk of the right bundle branch block pattern, we have to talk of ST elevation in AVR and ST depression in V5. And when it is when we are talking in context to diagonal vessel, we have to talk of the AVL, the Q wave in AVL and inferior ST depressions. And when these are distal to S1 and D1, there is an absence of inferior ST depressions. The right bundle branch block pattern with precordial lead ST elevation, we know that this is a proximal LED occlusion and immediately needs to be dealt with. So this I have repeated, so I won't do it again. Inferior leads ST elevations along with precordial lead ST elevation are usually seen with distal occlusion of LAD like a wraparound vessel. For the right ventricular infarction, it is good to have the right ventricular leads, the V3R, V4R, and so the specificity of these changes are also good. And sorry. So when there is a V1 is showing ST elevation and in the right sided lead, the V4R is showing more than 1 millimeter of ST elevation, we know that this is a blockage of proximal right coronary artery. When there is an upsloping ST segment but there is no ST elevation, we know that this is a distal right coronary artery. Just 1 or 2 slides more. And when there is no ST elevation with downsloping ST segment, we know that this is a circumflex artery. So here the AVR is, the ST elevation for AVR is more than in V1, and we also should be seeing the right ventricular leads to assess that this is a proximal left circumflex occlusion. So can you go wrong with the ECG? Surely. Post-bypass patients can have different ECGs, large individual variations with the coronaries, previous or multiple lesions, inadequate representation of certain hearts, especially the posterior segment, and the quality can be bad for an ECG. Non-ST evaluation MI, you usually are not able to clearly localize the culprit vessel. So good localization is possible for proximal LAD, distal LAD, left circumflex, proximal RCA, distal RCA, so, and these should be utilized. There are certain other syndromes like Wellens syndrome where are deep T-wave inversions in precordial leads that's specific for proximal LAD occlusion and needs to be recognized. This is a D-Venter sign wherein there is an ST depression for the precordial leads, but there is a rapid upsloping and there is a tall T-wave, and this is known as a D-Venter sign, also specific for proximal LAD. To summarize, the ECG provides reasonable clues in most cases to the occlusion of the culprit vessel. Specific ECG features are worth knowing which can lead to accurate ECG-based localization. Non-ST elevation ECG changes may not lead to localization, and it's a simple and accessible tool and should be used to get early diagnosis. Thank you.
Thank you, Dr. Niti, for detailed exhibition of the localization of ECG. Our next speaker is Dr. Anugupta sir. He will be teaching us narrow QRS tachycardia, clinical diagnosis.
Shall I start? Okay. Good afternoon. Thanks Makkad and Kush for inviting me. Being from Jaipur, always good to back in home. What I've been asked this afternoon to talk for next 15 minutes is narrow QRS tachycardia clinical diagnosis. Actually, Khush has shown a lot of ECGs in the quiz only, so I'm going to repeat the same thing, what we discussed during the ECG quiz. So now the terminology, like previously what we used to say is supraventricular tachycardia and ventricular tachycardia, SVT versus VT. Now the terminology has changed to narrow QRS tachycardia because narrow QRS, VT could be narrow QRS and SVT could be wide QRS also. So narrow QRS and wide QRS. So what is important? The first and foremost important thing you have to see whether it's a regular tachycardia or is it irregular. If it is regular, whether you are able to see P waves or not. If it is not seen, most of the time it is AV node reentrant tachycardia. And 70% of what we call as a paroxysmal supraventricular tachycardia are AV node reentrant. If P wave is seen, you have a pattern, like a sawtooth pattern, it's an atrial flutter. If it is falling before the QRS, it's atrial tachycardia, and it is falling after the QRS, what we call as a AV reciprocating tachycardia, or a XA pathway is mediated. Irregular, we all know atrial fibrillation, flutter with varying condition, atrial tachycardia with avidation or Wenke backing or multifocal atrial tachycardia, these are causes. So how to differentiate it on ECG? Short RP versus long RP, and this again we discuss. So short RP is two things, AV node reentrant versus AVRT. And again, if it is less than 60 millisecond, what we say it is AV node reentrant tachycardia. If it is more than 80 millisecond, probably we're dealing with AVRT. You will have a pseudo R or pseudo S pattern. Pseudo R, what we call as R prime, normally seen in lead V1. And pseudo S pattern, what you see in inferior lead. Like, you can have a pseudo Q pattern also. So 2, 3 AVF, you can have a pseudo Q or pseudo S pattern. And the most important thing is that ST concordance you will see in AVR and AVL in AV node reentrant tachycardia. AVRT is more than 80 millisecond but should be less than 90 millisecond, and you will have ST depression. The reason of ST depression is because P wave is falling on the ST segment. So you can have a ST depression. Sometimes you can have a QRS alternance also, like every QRS changes. But again, if the tachycardia is rapid with AV node reentrant, you can still have QRS alternance. Long RP tachycardia, again Ajay was discussing PJRT, atypical AV node reentrant and atrial tachycardia. These are the variant of long RP tachycardia. So this is how it looks, the classical example of a narrow QRS tachycardia. So this is a very narrow QRS tachycardia. And if you see the V1, so you will see a RSR dash pattern. So you will have a blip at the end of the QRS, what we call as a pseudo R pattern. Now why this R is coming? Because this is a P wave. The circuit is within the AV node. So what is happening? It is depolarizing the ventricle and the atrial simultaneously. So the P wave is falling within the QRS. So you will have a classical R prime pattern, or you can have a pseudo S pattern in inferior lead. So this is quite typical of a AV node reentrant tachycardia. And when you compare with the sinus rhythm, so if you see the shouldering in the V1, you will not have anything here. So there is nothing in V1 over here. So that's quite typical. If you compare with the sinus rhythm and the tachycardia ECG, it's quite typical, like, R prime suggests AV node reentrant tachycardia. One form, sometimes, you can have a very slow tachycardia, like rate of 150 or maybe 140. And the P wave is falling exactly in between the two QRS. So most of the time, probably you'll say that probably you're dealing with junctional rhythm or AV blocks. But this is typical of a 2-to-1 AV node reentrant tachycardia. So, if you see here, the RR interval between here and if you see between the two, it's exactly the same. So, this is 1-to-1 AV node reentrant. This is 2-to-1 AV node reentrant. So, many a times if you see clinical ECG in which P wave is falling exactly in the middle of the 2 RR interval, it's quite typical of 2-to-1 AV node reentrant tachycardia. And what is the mechanism? We know that, normally there's only one, that is what we call as a fast pathway. So the from the atrium through the AV node, from the fast pathway, it goes down to the ventricle to depolarize the ventricle. 10% of population, they can have additional slow pathway. So what happens when atrial ectopics comes and it goes down through the slow pathway? Why it goes down through the slow pathway? Because at that time, the fast pathway is refractory. So whenever the P wave travels down in the AV node, and if it goes back again through the fast pathway, when it is not refractory, so it starts the circuit and you will get a narrow QRS, typical AV node reentrant tachycardia. And this is what I discussed, like, V1, you will have a shouldering, like, RSR pattern. This is retrograde P waves. And if you see the inferior lead, you can have a retrograde P wave. It can fall right at the end of the QRS or it can fall right at the start of the QRS, depending upon the conduction through the atrium and the ventricle. So other thing is, again, the second narrow QRS tachycardia is AV reentrant tachycardia. Again, if you see here, so if you see here, the P waves are falling outside the QRS. So if you see here, the P waves are falling outside the QRS. So if you can see P wave, which is following the R wave, which is not preceding the R wave, and the RP interval is small, it means you are dealing with AVRTs. Again, the same thing, like, sinus rhythm ECG will be normal, absolutely normal. Although, you can have a WPW syndrome at the baseline. They also produce AVRTs. So if you have WPW pre-excitation in the baseline ECG, you can diagnose WPW. Otherwise, these are orthodromic tachycardias. And what is the mechanism? Normally, they produce orthodromic tachycardia because when we call as a concealed pathway, it means there is no antegrade conduction. It's only retrograde conduction. So it can go from below up. So the impulse comes down through the AV node, goes up through the XA pathway. Because it is not within the AV node, it is taking a longer route. That is the reason the P wave is falling outside the QRS. So it is coming down through the AV node, going up through the XA pathway. That is why it is initiating the tachycardia. And the P is falling outside QRS because it is taking longer route. And these are the two things. Suppose it goes down through the AV node, comes back through an XA pathway, what we call as a typical orthodromic tachycardia. If the sinus rhythm has got a WPW syndrome, you still can have an antidromic tachycardia, in which situation what happens? The impulse will go down through the XA pathway and it will come back through the AV node. So that will produce a wide QRS tachycardia because that is going to be pre-excited tachycardia. So this is again one ECG which Kush has shown, and that was very good ECG. So again, if you see here, the P is preceding the QRS, and if you see the RP interval, so this is what we call as a long RP tachycardia. So RNP is a long RP tachycardia. So this is what we say, long RP tachycardia. And what has happened, the purpose of putting this ECG, when we were debating, when Ajay was saying that it is very difficult to make out whether it's an atrial tachycardia from the Cox triangle or it is the PJRT. So if a PVC can terminate the tachycardia, if the PVC comes which terminate the tachycardia, it means that you are dealing with a PJRT. And these are normally incessant. They don't stop. They keep on going on and produce tachycardia. So this is one type of long RP tachycardia, what we call as a PJRT. The other subset of second long RP tachycardia, again, if you see here, the P wave is preceding the QRS, but there's a definite pattern, there is a notching of the P waves. So this is quite typical of a atrial tachycardia. And again, if you see the inferior lead, the P waves are all upright. So the P wave morphology is more or less looks like a sinus rhythm. So probably what you are dealing with the right atrial tachycardia, probably from what we call it from the crista terminalis, very near to the sinus nodes. So these are the A wave, bifid A wave, which are coming preceding that thing. And if you can compare both the thing, simultaneously, there's a tachycardia ECG and there's a sinus rhythm ECG. So the P wave morphology, if it differs, so in this ECG, probably the P wave is little different in V1 than the panel B. So probably this is not coming near to the sinus rhythm, probably it's coming from the left side of the atrium. And there's an algorithm which I'm not going to go in detail. So this is the algorithm. The most common thing, if suppose you see a positive P wave in V1, it means you're dealing with the left-sided. If it is a negative or biphasic, probably you're dealing with the right side. And the other important thing, if the inferior lead has got an inverted P wave, it means it is coming down from the atrium, probably coronary sinus or from the floor or from the inferior pulmonary veins. So that's very, very important. And what are the mechanisms of long RP tachycardia? Three mechanisms. The atrial tachycardia, it goes down and depolarize the ventricle. It could be PGRT, XA pathway, and when we call it a PGRT, these are very slow conducting pathways, very, very slow conducting pathway. That is why it is producing long RP tachycardia, coming down through the AV node, going up through the pathway, but it's a very slow conducting pathway. That is why it happens. And atypical AV node reentrant tachycardia, atypical AV node reentrant, it is taking longer route. Probably the atrium is depolarizing late because atrium is depolarized later on. That is why it's producing long RP tachycardia. So compare simultaneously all three AV node reentrant, AVRT and atrial tachycardia. You will not see any P wave. You will see a R prime in V1. Here the P waves are falling outside the QRS, and atrial tachycardia, the P waves are going to precede the QRS, which is what we call a long RP tachycardia. Coming to the irregular thing, AV node independent tachycardia, it could be atrial tachycardia, could be flutter, or could be fibrillation. So when we talk about multifocal atrial tachycardia, what is more important that three consecutive P wave morphology should be different. And this is quite often seen in a metabolic or in a COPD patient in an ICU when you will see multifocal atrial tachycardia. But to diagnose multifocal atrial tachycardia, you have to have three different morphology, all consecutive three different morphology. Atrial flutter, no question, sawtooth pattern. You can see a sawtooth pattern classical of a atrial flutter. If these are inverted in lead 2, 3 AVF and positive in V1, what we call as the typical flutter, counterclockwise flutter, probably KO tricuspid ischemous dependent flutter. These are very good subset for ablation, even in 2D mapping. Nowadays flutter we do in 3D, but it's very, very important. So this is how it looks like, the flutter waves. This is very common and quite often seen. Irregular, the most important thing is the atrial fibrillation. The take-home message again, once you diagnose an atrial fibrillation, see the age of the patient. If it's a very, very young patient and has got a recurrent atrial fibrillation, think about secondary AFibs. This guy was an 18-year-old guy and was coming to ER every time, and whenever he used to ER, his tachycardia used to be AFib. But when we subjected him inside the cath lab, this was quite typical of a AVRT. So it was an X-ray pathway which used to degenerate into atrial fibrillation, and this was totally curable. Other thing now, if it is an idiopathic atrial fibrillation, you can still ablate, you can do PV isolation, and you can treat those patients. Then last subset, VT with narrow QRS tachycardia. And again, you have seen these things arising very near to his Purkinje system. Fascicular VT, we discussed it during the quiz, upper septal VTs or a nodovascular VTs. So this is like, the clue is enteroseptal MI 2 years back, middle-aged man. So this, if you see here, this in a first impression, probably you'll think you are dealing with a narrow QRS, probably you're dealing with an SVT, and you will be tempted to give adenosine. So if you give adenosine and this is VT going on, you may land up in performing CPR. So if you see here, it's 1-to-1, VA, VA, VA. So if you see here, the relation of VA is 1-to-1 relation. Simple protocol, simple ER maneuver, perform a carotid sinus massage, and what you have seen, you have made it at 2-to-1. So 2-to-1 VA. So VA, they know A, VA. So it's a clear-cut VT going on. So if it is VT, it means probably you are dealing with a scar VT. If you have got procainamide in your ER, you give procainamide. Otherwise, the safest thing is do cardioversion, maybe as less as 50 joules or maybe 40 joules. So that's very, very important. Other subset, again, if it looks very typical of a supraventricular tachycardia or a narrow QRS tachycardia, and most of the time, probably we also diagnose like probably are dealing with the AV node reentrant, because you can see a R prime here. But if you see all the leads, probably there is no R prime here. So in some, it is conducting, in some, it is not conducting. So it means that narrow QRS tachycardia with a VA dation going on. So probably it's a very atypical type of AV node reentrant, or it's a upper septal VT. So we ablated this patient, and this was a VT, and young girl, almost 18, 20 years with a situs inversus dextrocardia. So this is one subset, and the last is fascicular VT. It always looks like a very narrow QRS, but the catch point is, if suppose you have got a right bundle with a left axis deviation, right bundle, left axis, very, very unlikely you will have an SVT, because your right bundle is blocked, your left bundle is blocked. So the focus, the tachycardia focus is from left posterior fascicle. So it is fascicular VT, and if you search here, you will find a VA dation also. So algorithm for short-term management of SVTs, if it is a regular hemodynamic stable or unstable, so if it is a regular, you diagnose an SVT, give adenosine in ER, see what exactly it is. If it doesn't terminate and you can make out, like, you slow down the AV node and you can get out the P waves, probably you can diagnose atrial tachycardia or atrial flutter. Or you can terminate, it means you are AV node dependent tachycardia, probably you are dealing with AV node reentrant or a AVRT. And the most important thing, what the long term has happened nowadays, is the patient preference, like, whether you really want to keep on medication or not. Suppose the first episode, single episode, very infrequent, probably you will leave all alone. You will not give any medication also. If it is recurrent, most important thing is patient preference. Now it is a class 1 indication, subject for RF ablation. Believe me, like, the success rate is almost like 99%. And this is one of the thing in cardiology which is totally, totally curable. I think I'll stop here and I'll take your question. Thank you very much.
Any questions?
Yeah. So first of all, sir, if a patient comes to you with the first episode of PSVT, so will you directly go for radiofrequency ablation, or maybe some medications, you will try some medications, or just reassurance? And second, if you have a patient with asymptomatic pre-excitation with no history of any kind of SVT or a syncope episode or a palpitation episode, so again, would you like to go for a radiofrequency ablation, or how will you evaluate that patient?
No, if I means what you asked, let me repeat your question. You said a patient comes in SVT.
Two questions, sir.
Yes, first question is patient comes with SVT, get IV medication, first episode, get IV medication, and you discharge.
Yeah.
So this is first episode. So, you need to discuss with the family whether you go for RF ablation, yes or no, because you have got a documented SVT. Now it's a class 1 indication. And the second option is whether you want to observe and get the second episode or not. Probably one episode, you are not going to write any antiarrhythmic medication. So give option of no medication with coming back with the second episode versus RF ablation. If it is a recurrent, see the indication for a oral medication is if it is a recurrent SVT, not for single episode. And if second episode, what you said is if the patient is asymptomatic.
Pre-excitation, asymptomatic pre-excitation in the ECG.
Asymptomatic?
Pre-excitation, sir. WPW, pre-excitation.
Okay, so WPW asymptomatic. So yes, so very important thing. Now, it all depends upon what kind of job he or she is going to perform. If it is a high-risk job, it needs ablation. So if suppose the asymptomatic, what is the protocol? You perform a treadmill test. Why you want to perform a treadmill test? To see what is the accessory pathway refractory period. Suppose you subject the patient on a treadmill and the delta wave disappears. It means probably you are dealing with a very long refractory period of the accessory pathway. Probably that is not a candidate for an RF ablation. If it persists and patient doesn't have any symptoms, it's a very low profile, low job, medical management. If the patient has got a high profile job, ablation. Other thing, patient choice. You discuss with the patient and the family, like you have got a WPW syndrome. In a future, you can develop atrial fibrillation, which could be a risk for a sudden cardiac death. So it is better to ablate rather than waiting for that. If the patient opts for ablation, go for ablation.
Thank you, sir. Thank you.
Thank you, sir. Our next speaker is Dr. Daljit, broad complex tachycardia. What a clinician should know.
And all. I would like to thank Dr. Makkar and Dr. Kush for having me here. So I think Dr. Kush has already covered a lot of components of, okay, I'll use this. Yes. So a lot of components of wide QRS tachycardia. I'll be talking about few of the important points which will help us to diagnose when you are having an ECG and sitting in emergency, because usually you don't have lot of time to sit and go through the ECG in detail. So one is we should know what is the diagnosis, what do you mean by wide QRS tachycardia. So whenever you have any QRS which is wider than 120 millisecond, it is called wide QRS tachycardia. Anything which is less than 120, it may be a narrow QRS tachycardia, it may be SVT or it may be VT. Then then anything which is, this is the conduction system of the heart. So any tachycardia which arises above the level of the His, below is called as a supraventricular tachycardia. It can be anything. So any tachycardia which is arising below the level of the His. It may be arising from the Purkinje fibers. Dr. Anup spoke about it, fascicular VTs, or it may be arising from the muscle. These are all ventricular tachycardias. Origin can be anywhere. I feel this is very important for any one of us to understand. So why a ventricular tachycardia or VT has a very wide component? So we need to understand that whenever there is a conduction through the His-Purkinje system, it's very narrow. And why does that happen is, His-Purkinje system has a very fast conduction velocity. It conducts very fast from one cell to another cell. So it's like a bullet train in front of muscles. So if there is a conduction from one muscle, myocardial cells, to another myocardial cells, the conduction velocity is like 0.3 to 0.4 meters per second. Whereas whenever it conducts through the conduction fibers, that is His-Purkinje system, it's like 3 to 4 meters per second. So it's 10 times faster. So that's why whenever you have anything, any arrhythmia which is going through the conduction fibers of the heart, it will be a narrower tachycardia, whereas any arrhythmia which is going through the muscle myocardial cells, you'll have a wider QRS. So whenever you have a VT, your initial component, you can say, because why I'm telling this, I don't like people to mug up the criteria. So you need not mug up the criteria, you need to understand the mechanisms. So whenever there is a muscle to muscle to muscle conduction myocardial cell, your initial part will be very wide. That's why your all components, I think Dr. Naik was also talking about initial slurring, wider initial part of the QRS wider. That means it's a muscle to muscle conduction. It's unlikely to be a supraventricular tachycardia. Mind you, I'm using a word unlikely. One point you need to realize that no ECG criteria for arrhythmias is 100% sensitive and 100% specific. That's why you have an ECG, you have intracardiac electrocardiography which has more specificity and sensitivity to diagnose tachycardias. So what happens? We need to understand that whenever you have a normal conduction from the right side and the left side, in the lead V1, Dr. Nidhi showed very nicely unipolar chest leads. So V1 represents predominantly right side of the heart. That's why, and the ventricle chamber, LV is a big thicker chamber and RV is a thinner chamber. So whenever you see V1, V1 is on the right side of the heart, right side of the sternum, and LV is on the left side of the sternum. That's why you have because all wavefronts are going away from the V1. So you have predominant negative component. In the normal people, small r, big S component. Whereas V6 is sitting on the LV side, correct? Which is a big chamber, and all the wavefronts are coming towards the V6. That's why you have a predominant positive component. This is the basic. So whenever you have, for example, a right bundle branch block, because it's a block here, the conduction will go first from the left bundle, and activation of the right bundle will happen from muscle to muscle transeptally to the RV, and you will have a small component, small R prime in V1, because this is a delayed activation of the RV. If you have a VT which is a RBBB morphology, which is RBBB morphology means it is coming from left ventricle, it is going towards the RV. So your initial part will be very wide, as I said, because it's a muscle to muscle conduction. And you will have a first big, because many people talk about rabbit ear, RBBB, how to differentiate RBBB of VT to the bundle branch block. If your first rabbit ear is wide and bigger, it goes in the favor of VT. If your first rabbit ear is very tiny and small, and second rabbit ear is wide and bigger, it is right bundle branch block aberrancy. Whatever you have a bundle branch block, whether it's right or left, your wavefront when it comes towards the left ventricle, your V6 should have a predominant positive component. V6 having a predominant negative component goes in the favor of ventricular tachycardia, because its activation is going from here towards the basal. It's from apex and going opposite to the V6. So wavefront is going opposite to the V6. So this is the basis. I think I can stop my talk here if you have understood this basis. And all the criteria depends upon this basics of our ECG. So as I said, if you have an RBBB pattern, bundle branch block, your second rabbit ear is bigger and the wider because of the delayed activation of the RV, and the V5, V6 is predominantly positive. Whereas, I think this ECG has been seen since morning multiple times. Fascicular VT, which is comparatively a narrow QRS, ventricular tachycardia, has RBBB, which is not typical RBBB, like small first R and a bigger second R, and terminal, you can see V5, V6 is predominant negative. And Dr. Anup has already spoken about left bundle with right axis in a structurally normal heart should be going in favor more of a ventricular tachycardia than supraventricular tachycardia, unless patient has underlying RBBB and the left axis, left anterior fascicular block, and if you have a baseline ECG available. Same concept which I spoke about. So if you have an SVT with aberrancy, you have a initial R and it's a rapid descent. Whereas if you have a VT, because the conduction is from myocardial cell to myocardial cell, can you see you will have a big delay. It goes very slowly, myocardial cell. That's why you get the studies has been done which says that from the onset of the R to the peak of the S wave, if this is more than 70 millisecond, it favors, because it's a slow conduction, more of a VT. If patient has an RBBB morphology, this I've already spoken about. In typical RBBB, second R prime will be bigger. First R prime will be very small and narrow. Any atypical RBBB, that is monophasic R in V1, QR pattern, or even with RBBB where first R is very big and wide and stout, fat R, it goes in the favor of VT than SVT. Whenever you have a wide QRS tachycardia, you have a patient in emergency and patient is hemodynamically unstable, you have a wide QRS tachycardia, that's why it is said that the chances, that's what clinical real life scenario has shown in, mostly it is VT. Whenever in a doubt, it's better to diagnose the tachycardia as a VT as compared to SVT because the outcomes are better. You may still be wrong. What are the remaining 30%, 20 to 30% chances why the patient supraventricular tachycardia will have wide QRS? I think we are talking since morning repeatedly is SVT with aberrancy, pre-excited supraventricular tachycardia, that is patient has a pathway which is conducting antegradally through the pathway, or SVT with because any patient who is already having a structurally abnormal heart, congenital heart diseases will have an abnormal QRS. Patient has a myocardial disease will have a baseline IVCD, and if they develop supraventricular tachycardia, it will be wide QRS tachycardia. And I think we have seen ECG of hyperkalemia as well. We should not forget there are few drugs which causes widening of the QRS. Classically is class 1C drugs, that is flecainide and propafenone, and amiodarone and sotalol can rarely cause widening of the QRS. Always remember this. So this is just a pictorial example of whatever I've already spoken about. Like if you have a supraventricular tachycardia, which is going equally through both the bundle branches, it will be narrow QRS. But if there is one of the bundle branches blocked, it can be functional, it can be pathological. You will have a wide QRS, which will fix into typical bundle branch block, either right or left. If you have a pathway sitting, if there is a conduction from this pathway, then because this pathway is sitting on the AV canal, AV groove, and it's actually a muscle, again because it's a muscle to muscle conduction, it's not conduction through your Purkinje system, it will have a wider QRS, and of course VT will have a myocardial VT will have a wider QRS. So this is a case example, one of the real life case scenario. You can see that this is a wide QRS, regular tachycardia. What do you feel, whether it's a VT, it's a sinus tachycardia, SVT with aberrancy, cannot be sure. So as I already spoke, any wide QRS tachycardia, to say it's a bundle branch block aberrancy, it should be fitting into some kind of aberrancy, right? Even RBBB typical aberrancy or LBBB typical. So it's a RBBB tachycardia with big negative in V5, V6. Plus, what is the axis? Can you see lead 1 is negative, AVF is negative. It's weird. It's a northwest axis, right? It's not fitting into any of the bundle branch block. So ideally, it should be going in the favor of ventricular tachycardia, right? I always feel that you should be knowing about the clinical background of the patient. Always try to have some clinical background of the patient. So this guy is a 35-year-old male, hypertrophic cardiomyopathy. He has palpitation. He walks through the clinic. He's not having any other symptom, just palpitation comes. And you just zoom this ECG. And if you see that there are 2 P waves between 1 QRS, I've just spread this ECG as 50 millisecond, and you can see there are 2 P waves between 1 QRS. Why this abnormal morphology of the QRS? Because this patient has a structural heart disease. Can you see? He's having little atypical RBBB. He's having negative V5, V6, and patient's 1 and AVF is already negative. So knowing the clinical background of the patient and having whatever the presentation scenario always help. That's why I'm trying to say that no criteria is 100% sensitive and specific in making the diagnosis. This is another case example, a child, 9-year girl, she's having recurrent palpitation. And I think everyone can make out, we are discussing about narrow QRS tachycardia pre-excitation. So there is a delta wave. Can you see there's a nice delta wave? She had some pathway sitting there. And she presents with this ECG. So if you don't give me any other thing except this ECG, if you just show me this ECG and ask me what is the diagnosis, I think maximum 99% of us seeing only this ECG will think about it's a ventricular tachycardia, right? Because I know the clinical background, because it's difficult to diagnose now patient is having supraventricular tachycardia or ventricular tachycardia because it's very wide QRS tachycardia. So I know this child has the same morphology, delta waves in the surface ECG, and it's a hemodynamically stable, it's a pre-excited supraventricular tachycardia. So if you go by simple approach, as I said, if it's a supraventricular tachycardia with aberrancy, it should be having a classical features of bundle branch block. It should not be atypical bundle branch block. QRS duration, usually VT is wider, but you may have 30% narrower. We have already spoken about fascicular VTs. Left bundle branch block morphology VTs are more wider as compared to right bundle branch block morphology VTs. This is an example of 9-month boy, structurally normal heart, just accidentally detected to have tachycardia. Now let's walk through this ECG. It's an RBBB. What is the axis here? I think most important thing here in this ECG is axis. A child who's less than 1 year, ideally children less than 1 year has rightward axis, which by 1 year or after 1 year start becoming normal axis. Why a child should have a leftward axis? That is one. Second, Dr. Kush spoke about in the morning, you can see there is an evidence of AV dissociation. Can you see here P wave? Can you see here P wave? So because child is completely hemodynamically stable, we should not throw away the diagnosis of ventricular tachycardia. There's a fascicular VT, and you can see now, after it's reverted, your AVF has become 2 has become completely positive, and then now it's a typical RBBB. So second axis, if there is an LBBB and right axis, it favors ventricular tachycardia. Right bundle branch block with a normal axis is very uncommon in VT. And if the patient has myocardial infarction and any space, any area which has formed a dense scar, has formed a QS pattern, it's a scar. In the VT, that QS pattern will be persistent because it cannot generate anything. So that scar area will have QS. So if you have a tachycardia which is having QS in 2-3 AVF, tachycardia having Q wave in V1, V2, V3, it goes more in the favor of ischemic VT. So it can be stable, unstable, regular, irregular, monomorphic, polymorphic. If polymorphic, watch for QT interval. I think morning we had a very nice ECG. So this is an example of polymorphic VT. If its baseline QT is prolonged, then you should watch for the causes. If QT is normal, we should rule out ischemia. We spoke about fusion and capture beats, which are very highly sensitive and very high specificity. That's the reason we spoke, because, and why it's the specificity is high for fusion and capture beats, but the problem is it's not seen so easily. Why it's not seen? Because your capture beats are seen in a slow VT. That it's difficult to appreciate or it doesn't happen in the very far. This patient was having a slow VT, and you can see a narrow QRS running behind, within the wider QRS. So if you have a wide QRS tachycardia, patient is having history of MI, go for the diagnosis of VT. Long-standing palpitations, more in the favor of SVT. History of congestive heart failure in the past, chances of VT is more. Syncope is not always helpful. Even supraventricular tachycardia can have syncope. Brugada criteria, I'm not going to go into the detail, but what it talks about, you have negative concordance. For example, here, V1 to V6, similar negative concordance cannot happen any supraventricular tachycardia with aberrancy down, because you can see V5, V6 negative. So whenever you have V1 to V6 completely negative, it favors more in the chances of ventricular tachycardia, very high specificity. Vericke criteria, same. I'm not going to go into detail, but it is using the same mechanism we are talking about. Initial component wide as compared to the distal component. So initial deflection becomes very slow as compared to terminal deflection. So they call it VI by VT ratio. If it is less than 1, that it goes in favor of ventricular tachycardia. I think AVR is a very underutilized lead. We saw one left main equivalent in the morning. Same happens for VT. So if you have an initial R in AVR, it says that it is apex to basal activation. Always say that it cannot happen with a normal, structurally normal heart supraventricular tachycardia. So if patient has old MI, unless prove otherwise, it's a VT. More QRS complexes than P wave, it's a VT. AV dissociation confirms VT, but VA conduction may be present during VT. This is a case example, young child, DCMP, LBBB, left axis, there is a VA conduction. Why I'm showing this ECG? Because this child was diagnosed with junctional rhythm, I don't know why. Patient was stable, so I just did something. I did carotid massage. Now you can see there is a VA dissociation seen. A became less, and then there is a VT going on. I'll stop here. Thank you. I think I'm overshooting the time.
Any questions, please? Thank you, Dr. Dalji.
No questions. I'll come down. Thank you.
Thank you, ma'am. It's a time for tea break for 15 minutes. Thank you.
So we are continuing the next session. We trust you found this session enlightening. Okay. So let's take 10 minutes break. See you. Thank you. Good evening. We are going to start our next session in next 2 minutes. Thank you.
ये बाइट्रोनिक का वो आपने बोला था
हेलो
अतुल सर अगर हो सकता है नहीं आए तो आपको
हेलो हेलो हेलो
सर नहीं आए तो सिराना सर को बोल दिएगा टॉप देने के लिए एक बार अनाउंस कर दीजिएगा तो सिराना सर को बोल दिएगा टॉप देने के लिए बात हो गई मेरी ठीक है
हेलो
ऊपर
हेलो
इनको तो इनवाइट करेंगे करेंगे इनको इनवाइट करेंगे ऊपर गौरव सिंह सर को विवाह सिराना सर जो भी हैं उनको बुला लीजिएगा
नॉर्मली जो चेयरपर्सन है ये स्पीकर को इंट्रोड्यूस करता है
हाँ हाँ
एक व्हाट्सएप May I have your attention, please? We hope you enjoyed the refreshing tea break. As we resume our journey through the Jaipur Heart Rhythm Summit, we are excited to bring our next enlightening session. So the next session is New Frontier in Heart Failure. And for this session, I would like to invite the chairperson, Dr. Gaurav Singhal sir, Dr. Gaurav Singhal sir, Dr. Vibha Vasu Gaur, Dr. Sanjeev Sidana, Dr. Niti Chadda Negi, and Dr. Daljit Kaur, and Dr. Shalini Garg. Thank you. I would like to invite our next speaker, Dr. Atul Kasliwal sir. Thank you.
So just a very small announcement to make. So we have the result of the ECG quiz. So after this session, we have actually very interesting results. So there's a tiebreaker. Basically, there's a tie between two students. So we will have a tiebreaker round after this session. So I'll announce the name after this session, and we will have a tiebreaker round for that. So I would like to invite Dr. Atul sir for his presentation on ARNI.
I would like to announce the name of chairpersons again. Dr. Amit Gupta sir, Dr. Ankit Gupta, Dr. Anil Gupta, Dr. Daulat Meena, Dr. Dinesh Gautam, Dr. Manoj Kumar Sarowa, Dr. Milind Srivastav, Dr. Prashant Dwivedi, Dr. Supriya Jain, and of course Dr. Gaurav Singhal, Dr. Vibha Vashu, Dr. Sanjeev Sidana sir is already here. So now I will request Dr. Atul Kasliwal sir for his next presentation. Thank you.
Well, good evening, everybody. Well, first of all, I would like to thank the organizers who have invited me on this talk. Well, we'll be discussing something about this session for heart failure, and I've been given the topic to discuss about ARNI. Well, we all know that despite guidelines, different guidelines available, recommendations, still the heart failure therapy is not currently optimized. And you can see in this, well, ACE and ARBs, they are given in 59% of the cases. ARNI is given just only in 12.8% of cases. And combined ACE and ARNI is given just in only 72% of cases. Well, this is from CHEMP SF registry. Well, coming to the topic ARNI. Well, we all know that ARNI is a compound. It contains two drugs, valsartan and sacubitril. And this combination simultaneously inhibits nephrotic peptide system and RAS system. Well, we all know that in the heart failure patients, the neurohormonal, there's an activation in our body. There's one system that is we call renin-angiotensin system. We all know that by activation of renin-angiotensin system, there's a more vasoconstriction, more increased blood pressure, more increased sympathetic tone, more aldosterone is secreted by renin-angiotensin system. And by these factors, it can lead to fibrosis and hypertrophy. So this is the renin-angiotensin system. The one of the drug which is there in this combination is valsartan. This valsartan basically blocks the AT1 receptors, thereby controlling the renin-angiotensin system. On the other side, we have got another hormonal system in our body, what we call vasoactive peptide system. If I would like to say, I can say that even a heart acts like an endocrine organ in the sense that it stimulates the vasoactive peptides like ANP, BNP, and CNP. We all know this is secreted by heart. BNP is secreted from the ventricles whenever there's a myocardial stretch or there's increased pressures. The BNP is secreted. These vasoactive peptides, basically they are good for us in the sense that they cause vasodilatation, they decrease the sympathetic activation, and by acting on the renal kidney, they cause natriuresis and diuresis. So in this sense, what's the hemodynamic effects of this ARNI combination? On the one hand, we have got increased natriuretic peptides, and there's a decreased RAS system and decreased sympathetic activation. Thereby, these both increased natropeptides and decreased RAS will lead to myocardial protection, natriuresis, and vasodilatation, leading to decreased preload, decreased pulmonary pressures, and increased contractility in the sense that it increases the cardiac output. Well, we have got a number of studies now available which compare ARNI with the enalapril. And it has shown that if you use enalapril, there's the number of components of quality of life is improved. If you use ARNI over enalapril, where the quality of life is improved in the sense that peak VO2 is increased, your 6 minutes walking distance can be increased, and the respiratory efficiency is increased. So nowadays, ARNI is preferred over ACE and ARBs. And that has also been seen in the, we'll be seeing that the trials are supporting the ARNI. Well, we all know that when we talk about heart failure patients, well, we divide the patients into 3 groups. Basically, the patient with reduced ejection fraction. That means the patient has got ejection fraction less than 40%. Those patients of heart failure, they belong to, we call HF heart failure with reduced ejection fraction group. Then we have got a mid-range ejection fraction, which is when your ejection fraction is between 40 to 50, and preserved ejection fraction when your ejection fraction is more than 50. So we all know that in the reduced ejection fraction, we have got 4 drugs which were now called 4 pillars of, 4 pillars by which we treat the heart failure patients. These 4 drugs basically are RAS inhibitors or ARNI, beta blockers, MRA, and SGLT2 inhibitors. So these are the class 1 indication 4 drugs. Any patients who has got ejection fraction less than 40%, all these 4 drugs should be given. So today we'll be discussing about ARNI, the role of ARNI in these group of patients, though we know it's a class 1 indication. Well, we have got a trial on reduced ejection fraction, paradigm HF trial. And this trial has shown that in the primary event in this trial, in these patients, basically they belong to the reduced ejection fraction group. And the primary endpoint was a combination of cardiovascular death and heart failure hospitalization. And in this trial, it was clearly shown that if you use ARNI over enalapril, then there will be a 20% risk reduction in the primary endpoint, which includes cardiovascular death and heart failure. And if you take, separately secondary endpoints like cardiovascular death or all-cause mortality, that is also reduced in the tune of 15 to 20% over enalapril. So overall, this drug is better than enalapril or ACE inhibitors. So whenever you should get a chance, you should switch these patients to ARNI. And the studies have also shown that if you use this ARNI, there's a improvement in the NT-proBNP levels, and there's an improvement in the patient's diastolic dysfunctions. Yeah, there's an improvement in the left atrial size, and even the patients, they have shown that NYHA class improves with this drug. So with this drug, number of questions has arisen. The most important question being asked, if the patient is on ACE and ARBs, whether we shift the patient to ARNI. Well, based on this trial, paradigm HF trial, whether the patient is stable or unstable, we must switch from ARBs and ACE to early ARNI therapy. Because you see the stability, whenever the patient with heart failure, even though you can say that this patient is fine on enalapril, he's on ACE inhibitor and is stable. But the trial have shown that these 20% of the stable patients had a primary event during the progression of the trial. And around 50% of these events were death, and 60% of these events were sudden death. So ARNI reduces sudden death as well as cardiovascular death, and it has incremental benefits in reducing mortality compared to ACE inhibitors. Now, in the second group, we have got another group of heart failure patients who had got, their preserved ejection fraction. That is, their ejection fraction is more than 50%. So we have got another trial, Paragon HF trial on ARNI, in which patients were of NYHA class 2 and 4, and their ejection fraction was more than 45%. And in these patients, the ARNI, that is the combination of sacubitril valsartan, was compared with the valsartan. And in this trial also, well, the primary endpoint was composite of total heart failure hospitalization and cardiovascular death. And in this trial also, it was shown that if you use this combination of sacubitril and valsartan, even in the preserved ejection fraction, there's a relative risk reduction of almost to the tune of 13%. You can see the hazard ratio is 0.87. Similarly, the heart failure hospitalization, if you use this drug in preserved ejection fraction, has also been reduced. There's a relative risk reduction of almost 15%. Though in this trial, the cardiovascular death was not reduced. So what is the conclusion? What about the ARNI preserved ejection fraction? This trial, Paragon HF, told that the ARNI can be given in this group of patients to reduce heart failure hospitalization. This will mean that all patients with signs and symptoms of heart failure, elevated NT-proBNP and LVH ejection fraction, in males 40 to 57%, or even in females who has got ejection fraction 60%, they benefit from ARNI, and this has been evidenced from this Paragon and Paramount study. So at present, this drug, in preserved ejection fraction has been assigned class 2B drug. Well, then there is another category of mid-range ejection fraction group where the ejection fraction is 40 to 50%. And even in this group, there have been trials which have been done, and recently it has been shown that even this drug can be used in the patients of mid-range heart ejection fraction where the ejection fraction is 40 to 50%. So, RD is now class 2B indication in the patients who has got mid-range ejection fraction or if they have got a preserved ejection fraction. Now, it has been shown, there's a number of trials which have shown, when you give this RNA, the combination of sacubitril valsartan, this is a reverse remodeling. If your heart is dilated, there's a diastolic dysfunctions, it can be reduced or it can decrease if you use this RNA. We have got trials on this which have shown this reverse remodeling. Now coming to the dosing of RNA, well, we know that in these trials the target dose of RNA was 200 milligram 2 times a day. And this dose has been shown to cause a maximum reduction in mortality and heart failure hospitalization. However, all the twice doses, because this drug comes into 50 milligram, 100 milligram, 200 milligram. So all the twice doses, if you give either 50, 100 milligram or 200 milligram, they have shown the benefits. And the lowest dose have shown 12% reduction in primary composite endpoint compared to the overall trial in which the 200 milligram was given, and they have shown 20% reduction. So low dose RNA can be given in heart failure patients, and they have shown the long-term benefits in those who do not tolerate high doses. So a low dose is still better than no dose. Now, when we talk about the heart failure patients, initially we used to give this drug in the OPD patients, the patients who are coming to visit you, and you're just prescribing this drug. Well, that was based on the paradigm HF and titration studies, but nowadays there's a focus of even the indoor patients, the patients, IBD patients of acute heart failure who are admitted in the hospital. Now there's a concept is coming that you should start this RNA in those patients also. And we've got trials like Pioneer and Transition trial in the indoor patients who are acute decompensated. Well, based on this Pioneer HF study, which have shown that RNA should be started in all patients with acute decompensated heart failure before discharge, once they are off the inotropes and vasodilators. And it has been shown that it is feasible even if you start in the hospital, and it reduces the 8 weeks mortality and rehospitalization rates in patients with reduced ejection fraction. And this benefit is seen in all groups, whether it is acute decompensated patients, they are coming for the first time, or they are already decompensated, and irrespective of the presence or absence of background ACE therapy. So in acute decompensated patient, one can start this drug safely. Now, when do we start RNA? Well, I've shown you, it can be safely initiated in de novo heart patients, and it should be initiated whenever you are discharging the patient. The pre-discharge, you should try to start this drug. Now, even we have got studies with acute MI. Patients admitted with acute MI, should we start the RNA? Well, we have got a Paradise MI trial, which has shown that in acute MI setting, one can start it, and they have shown the reduction of 10%. What about hypertension? Patients of heart failure having hypertension, well, it has been shown that it can be safely used even in patients with borderline systolic hypertension. And even nowadays, even as studies are coming that even in resistant hypertension, you can start this. RNA with diabetes. It has been shown that if you use this RNA drugs, that there's a reduction in the need of insulin therapy, and it reduces HbA1c by 0.6 to 0.7%. And it has been shown that if the Trivandrum heart failure study, that RNA reduces cardiovascular death by 20%, all-cause mortality by 16%, and hospitalization by 20%, even in these diabetic patients. Well, what are the contraindications we all know? Well, there's the absolute contraindication in pregnancy and lactation when your EGFR is less than 30, history of angioedema, severe hepatic failure, bilateral renal artery disease. Well, in the CKD, if you talk about CKD, well, one should be cautious by by using ARNI in the patient of CKD stage 3 and 4, because we know these patients are prone to hyperkalemia and dehydration. Well, if the patient has got hyperkalemia, well, one should follow a strict low potassium diet, small doses of loop diuretics, potassium binding resins, and even glucose insulin drips in severe cases. Well, there's another problem related with ARNI is hypotension, because in the trials they have given if your blood pressure is less than 100, one should try to restrict using of ARNI. But if their hypotension is there, it can be easily managed by down titrating the loop diuretics, increasing liquid intake judicially, and stopping all other drugs that can cause hypotension but are not helpful in reduce heart failure, such as nitrates and calcium channel blockers. Well, it is clearly given that when you use this RD, there's normally increase of serum creatinine around 30 to 50%, and creatine is around 2.5. Or if your EFR is more than 30, you can still use ARNI. And sometimes, the patients are on ARNI and they are doing well, and we sometimes find the ejection fraction has improved. So there's a question arises, shall we stop the ARNI? The question is that we should not stop even those patients who have, they have improved their ejection fraction. And it has been shown that ARNI withdrawal may increase all-cause mortality. And the studies have shown that if you use this ARNI in the reduced ejection fraction group, there's a reduce in the need of device therapy. Device therapy like ICDs, LV assist devices, right ventricle assist devices, and biventricular assist devices. This use has been reduced by using of this ARNI. And similarly, the need of heart transplant and mitra clip has also been shown to be decreased if you use this ARNI. Thank you.
Thank you, Dr. Atul. So, just one comment in the Paradise HF trial in which ARNI was compared with AC inhibitor in setting of acute MI. So that was a negative trial, so it did not show any benefit in the setting of acute MI.
200 milligram.
Yeah, so there was no benefit found in that trial, Paradise HF. That was done in the setting of acute MI.
Yeah.
And one more thing that if we are using this in the acute setting, so one should aware about the paradoxical response of this drug. So in the case of hypotension or in the normotensive patient, one should be very careful to start with this drug, and at least should be used in the 50 milligram dose BD before, and then titrate according to the blood pressure. And we all know that this ARNI is overall beneficial over the ARB and ACE inhibitor in the reduced ejection fraction. And if patient is stable on ACE inhibitor or ARB, we have to switch to the ARNI for further decreasing the mortality. And various trials show that there is a 12 to 15% more mortality reduction if we switch from ACE inhibitor or ARB to ARNI. And sir, I just wanted to one question. How to switch from ACE inhibitor to ARNI in patient who are stable on ACE inhibitors?
Obviously, it all depends on what dose of patient is taking ACE inhibitor. If already your patient is on enalapril, ramipril for cardiacs, for example, 10 milligram, you can start, I think, from 100 milligram, you can start directly. But if the patient is on low dose, 2.5 of cardiacs, one can start from 50 milligram doses. Okay. In the trials, they have titrated the doses. They've started from the 50, 100, and the maximum dose was 200 achieved. But even, in our practical experience, we have seen a lot of patients whose ejection BP is 90 and 100. And even with start, half dose of 50 milligram, even the 25 milligram, I say it really works if the patient tolerates. And if you see, if your creatine level doesn't increase more than 50%, or your creatine is less than 2.5 or 3.5, well, one can use it. Or if your EGFR is more than 30, you can use this drug safely.
Definitely. And I think 24-hour window period should be off when 24
Yeah, obviously. If the patient on ACE inhibitors, one should wait for at least 24 to 36 hours before starting the ARNI combination. But if your patient is on ARBs, one can start the ARNI directly.
Yes. Thank you so much.
Sir, one more question, please. Sir, in our practical experience, while using ARNI in acute settings, there are more chances of hyperkalemia as compared to ACE inhibitors or ARBs.
No. Otherwise, the trials have shown that if you use ARNI, the incidence of hyperkalemia is less as compared to ACE and ARBs. There's a reverse.
But we have seen such patients that we have to stop ARNI and even as well as MRA also, because patient is having hyperkalemia and because of that patient is having ventricular arrhythmias. So many patients
Well, obviously, whenever you are using this drug, you have to monitor, potassium and creatinine levels, obviously. But the trials, obviously, if the
so
patient
maybe
is on
in
MRA,
Indian patients, because these trials are conducted in US patients, so maybe in Indian patients, the chances of hyperkalemia are high while using ARNI as compared to ACE inhibitors.
well,
So
I've not seen that, but I find that the incidence of hyperkalemia is reduced as compared to the ACE inhibitors.
As an Indian,
with
now
this
we
drug.
should stop underestimating ourselves. We are equivalent to Western population, so we can tolerate all the doses which Western population can.
Yeah, you can publish your data. That will be a better idea.
So this is a clear message that we should start this ARNI on over the ACE inhibitor or ARV if patient is stable, if patient is still stable, and one should also think about the other factors of patient when to start this ARNI. For example, cost factors and other side effects. If the patient is appearing with the side effect, then we are, of course, decrease the dose. So our next speaker is Dr. Sedana sir. He's also throwing some light on this heart failure management by the another pillar of this drugs, that is SGLT2 inhibitors. Dr. Sanjeev Sedana sir.
So now we have Dr. D.K. Garg sir and Dr. Supriya Jain sir. So we request them to chair this session. Thank you. Dr. D.K. Garg sir and Dr. Supriya Jain. Thank you.
Thank you. Good evening and warm welcome in this conference. And in this section of heart failure symposium, I'll discuss on the SGLT2 inhibitor. The exact topic is SGLT2 inhibitors for the heart failure, something to deliver. So definitely we'll focus more on the deliver trial, but we'll discuss all other trials with the SGLT2 inhibitors. So SGLT2 inhibitors, we know that they were originally developed as an anti-diabetic drug. What they do, they inhibit the SGLT2 receptors in the proximal convoluted tube, and they actually stop the absorption of glucose from the proximal convoluted tube and sodium also. So there is osmotic diuresis and loss of glucose in the urine, and that was the mechanism action for the hypoglycemic effect in the diabetic patients. So later on we noted that they have got a lot of other modifying cardiovascular risk factors via many diverse mechanisms, like through their diuresis, glucose excretion, natriuresis. They cause the improvement in the cardiac function, reduction in the preload, reduction in the afterload, and there will be improvement in the cardiometabolic efficiency. There will be a reduction in the left ventricular mass. There will be reduction in the blood pressure, reduction in the weight, and there will be improvement in the kidney function also. So all these benefits were noted with the SGLT2 inhibitors, and the use of SGLT2 inhibitors is not associated with any significant electrolyte imbalance. And this is how the story started. So you know that rosiglitazone was associated with increased cardiovascular mortality, despite the fact that there was good control, glycemic control. So in 2008, the US FDA made it a mandatory to conduct a cardiovascular outcome trial for any new anti-diabetic drug. So while these outcome trials were being conducted for SGLT2 inhibitors, it was noted that in EMPA-REG trial with the empagliflozin, declared TIMI-8 with the dapagliflozin, and CANVAS program with the canagliflozin, it was noted that the use of these drugs is associated with reduction in the heart failure hospitalization. So it was postulated whether drugs can be effective in the non-diabetic patients also. So dedicated heart failure trials were actually conducted, and the first of these dedicated heart failure trial was DAPA-HF, which actually assessed the dapagliflozin in the patient with the chronic heart failure with the reduced ejection fraction, either with or without diabetes. So almost 5,000 patients were included, and 50%, less than 50% of the patient had diabetes, and all the patients, they have ejection fraction of less than 40%. They had elevated BNP, and eGFR was kept as a more than 30. So the primary endpoint was composite of cardiovascular death, hospitalization for heart failure, or urgent heart failure visit, and numerous secondary endpoints were also monitored. So this is the result. Dapagliflozin was associated with significant reduction in the primary endpoint, with a 26% reduction in the primary endpoint of cardiovascular death or worsening of the heart failure, and 18% reduction in the cardiovascular death, 30% reduction in the worsening heart failure. And you can note that the benefit started very early, as early as 28 days, and number needed to treat was only 21, and there was 17% reduction in the all-cause mortality was also noted in this trial. The second trial in this category was Emperor Reduce, in which empagliflozin was tested, and again the drug was found to be very effective. There was 25% reduction in the primary composite endpoint of cardiovascular death or heart failure hospitalization, and the number needed to treat was only 19 over 16 months, and there was 30% reduction in the hospitalization for heart failure, and there was significant benefit in the kidney parameter also was noted. And this benefit was observed regardless of the ARNI use. The drug was effective even in the patient in which ARNI were being used. And again, the benefit started very early, as early as 12 days, and statistical significance was noted as early as 34 days. And in this trial, again, there was a significant reduction in the serious kidney events also, and there was 50% relative risk reduction in the serious kidney events that translated into 1.5% absolute risk reduction. And because of the improvement in the kidney function, there was 22% lower chances of discontinuation of the MRI therapy because of the less chances of hyperkalemia. And it also led to improvement in the erythropoiesis. There was increased chances that patient will have the resolution of anemia. Like in patients who are not being treated with empagliflozin, the anemia was resolved only in 29% of the patient, but in empagliflozin group, anemia was resolved in the 50% of the patients, and overall there was improvement of the hemoglobin in the tune of 0.75 milligram. So we always said that drug is not effective in our Asian or Indian patients. So the regional differences were also noted in this drug. So many Asian patients, almost I think the 248 patients from Asia, and there were Indian patients also in this trial, and drug was rather more effective in Indian patients. So now I'll discuss in this section role of SGLT2 inhibitors in the preserved ejection fraction subgroup. And the first trial in this subgroup was Emperor Preserved, which was published in 2021. This was the first trial in patient with the heart failure with the preserved ejection fraction to show significant reduction in the primary endpoint. None of the prior trial in this category, that is heart failure with the preserved ejection fraction, showed significant reduction in the primary endpoint, whether it was Paragon HF, TopCat, I Preserved, PEP-CHF, or CHARM Preserved. So there was 21% reduction in the primary endpoint. In this trial also, the empagliflozin 10 milligram was compared with the placebo, and these are the exclusion and the inclusion criteria. There was 21% reduction in the primary endpoint, 3.3% reduction in absolute risk reduction, and number needed to treat was 31. And the hospitalization for heart failure was also reduced by 27%. And although the effect was little attenuated when the ejection fraction reached in the range of 60%. So the second trial in this category is DELIVER trial, in which dapagliflozin was compared with the placebo in heart failure with the preserved ejection fraction patient. The patient included were more than 6,000, and the trial was conducted across the 20 countries, and the patients were older, symptomatic, and 25% of the patients were in NYHA class 3, and there were very high rates of comorbidity, and the patient had elevated BNP, and the median anti-BNP and anti-pro-BNP was 1,000, and it actually included all the three category of patients, that is ejection fraction of 41 to 49%, 50 to 59%, and more than 60%. So almost all 1/3 of patients were there in all the three categories. And again, the result showed a significant 18% reduction in the primary endpoint. Number needed to treat was 31. The benefit started again very early as 13 days, and all individual components, they contributed to the superiority of the primary endpoint, that is cardiovascular death, worsening of heart failure, all the two components they contributed. And the drug was found to be very effective in all the subgroup of the patient, whether patient has got age more than 72, whether the patient is male or female, and all ethnicity, including Asians. And all the geographic regions, that is including Asians, whether the patient was diabetic or non-diabetic, whether patient had AF or no AF, BMI was more than 30 or less than 30, the drug was found to be effective even in the patient who has got ejection fraction of more than 60%. And there was also a pre-specified group of heart failure with the improved ejection fraction also, and in this category also drug was found to be effective. And we can see that all the parameters like primary endpoint, the worsening heart failure, hospitalization for heart failure, cardiovascular death, and all-cause death, they were all better in all the three subgroups, whether patient has got ejection fraction of less than 60% or more than 60%. And the drug was found to be very safe, and all adverse events were similar in placebo and the dapagliflozin group. And this is the combined data from the dapagliflozin trials, that there is data of more than 11,000 patients. There's 14% reduction in the cardiovascular death, 10% reduction in the all-cause death, 29% reduction in the hospitalization of the heart failure, 26% reduction in the first heart failure, and 10% reduction in the 3-point MACE. Now coming to the patients with the improved ejection fraction. So we know that patients who are initially classified as heart failure with the reduced ejection fraction, with therapy, they may have improvement in the ejection fraction. They are reclassified as heart failure with the improved ejection fraction. So the DELIVER trial also included almost 1,100 patients with the heart failure with the improved ejection fraction. Again, the drug was found to be quite effective in this subgroup of the patient also, and all the secondary parameters were also significantly reduced in this subgroup of heart failure with the improved ejection fraction. So to summary of DELIVER trial, it is the largest and broadest trial which included patient with the heart failure of more than ejection fraction of more than 40%. It enrolled the patient with the well-treated and with high incidence of comorbidities, and dapagliflozin provided the significant reduction in the primary endpoint, 18% reduction in the cardiovascular death or worsening heart failure, consistent effect regardless of diabetic status, baseline ejection fraction, enrollment during or within 30 days of hospitalization for heart failure, and prior ejection fraction less than 40% or not. So now coming to the evidence of SGLT2 inhibitors in patient with the worsening heart failure. So DELIVER trial also enrolled few patients from the worsening heart failure group. There were 654 patients they were enrolled within the 30 days of the hospitalization. Again, in this subgroup of the patient, the dapagliflozin was found to be better than placebo. The dedicated trial for this subgroup of the patient with the this acute worsening was EMPULSE study, in which empagliflozin was compared with the placebo, and patient should, after the initial stabilization, when the patient has systolic blood pressure of more than 100, there was no increase in the IV diuretic use in the last 6 hours. When patient was not given the IV vasodilators in last 6 hours, and patient was not on inotropes from last 24 hours, the patient was randomized to either empagliflozin or the placebo. Again, there was 36% greater likelihood of the clinical benefit with the empagliflozin. There was the all-cause mortality was 4.2% in the empagliflozin group, 8.3% in the placebo group. Heart failure events were 10.6 in the empagliflozin group, while it was 14.7 in the placebo group. And again, in the acute setting also, the drug was found to be quite safe, and the adverse events were similar in the placebo as well as in the placebo and the empagliflozin group. The second trial in this category is soloist WHF trial, which actually studied the sotagliflozin, and the drug was started either during hospitalization or within the 3 days of the discharge. And we know this is a combined SGLT1 and SGLT2 inhibitor, and this is the trial design. And again, in this trial, in the worsening heart failure patient, there was significant reduction in the primary endpoint with the hazard ratio of 0.67, and again the benefit started very early as 28 days, and drug was again effective in all the subgroup of patients, especially as few subgroups like whether the drug was started before discharge or after discharge, whether the patient has got ejection fraction of more than 50% or less than 50%. In this trial, all the patients were diabetics. So now we have evidence of reverse cardiac remodeling with the SGLT2 inhibitors also, and that was proven in the empatropism study, which showed that with the use of empagliflozin, there is reduction in the left ventricular end systolic volume index, there is reduction in the left ventricular end diastolic volume index, there is reduction in the maximum LA volume, minimum LA volume, and there is increase in the left ventricular ejection fraction and peak oxygen consumption, and there is reduction in the left ventricular mass index, left ventricular extracellular volume fraction, and sphericity index. Now coming to the guidelines, these are the recommendations from the latest ACC-HA guidelines, which were published last year in 2022. And in the stage A and stage B heart failure, if patient is diabetic, SGLT2 inhibitors are recommended as class 1 recommendation. And for stage C heart failure, along with other agents, SGLT2 inhibitors have been given class 1 recommendation. And for heart failure with the mildly reduced ejection fraction, it is a class 2A recommendation. Again, for preserved ejection fraction, it is a class 2A recommendation. And in heart failure with the improved ejection fraction, along with other GDMT, again, SGLT2 inhibitors should be continued, and that is a class 1 recommendation. And all the GDMT, including SGLT2 inhibitors, should be started during hospitalization itself, and this is again a class 1 recommendation. And this is the latest ACC 2023 recommendation for the treatment of heart failure with the preserved ejection fraction. So this was published very recently in the May this year in the JAC. And what are their recommendations? That SGLT2 inhibitors, the class 2A recommendation, that should be started in all the patients with heart failure with the preserved ejection fraction. Then if patient has got evidence of fluid retention, then diuretics is class 1 recommendation. And if patient has got fluid retention and in all the females and in the male with the ejection fraction of less than 55 to 60%, they should be given MRA. This is class 2B recommendation. And for all the women and for men with the ejection fraction of less than 55 to 60%, we can add ARNI, that is class 2B recommendation. And if patient cannot take ARNI, then ARB is class 2B recommendation. Thank you. And just one more point that ESC has recommended that we should actually make the profiling of the patient so that we can better prioritize our treatment. So we should fit our patient in one of these profiles, 9 profiles, and you can see that SGLT2 inhibitors, they are not contraindicated in any of these category. And in rapid sequencing also, the SGLT2 inhibitors have been given first position. And so to sum up, that is, SGLT2 inhibitors are given as one pill once a day, no dose titration. They substantially improve survival and prevent hospitalization. They are associated with meaningful improvement in quality of life and functional status. Their benefit appears rapidly within days. They are exceptionally well tolerated and safe. They does not lower blood pressure, and they improve kidney function also. Thank you. Thank you.
Wonderful talk, Dr. Sidana. So I have 2 questions basically. So we all know that dapagliflozin and the empagliflozin both are recommended for the heart failure therapy.
Sorry?
Dapa and empa,
yeah.
both are recommended for the heart failure therapy.
Yes.
So is there any situation where you prefer the dapa over the empa or the empa over the dapa?
So in the patient with the heart failure with the reduced ejection fraction who has got EGFR of less than 30, in these patients, I will prefer empagliflozin, and in other patients, if EGFR is more than 30, then we can give either of the drug. And if EGFR is less than 30, then definitely between 20, because in Emperor reduced, the patient with the patient were randomized up to the EGFR of 20, but in DAPA-HF trial, the patient was randomized up to the GFR of 30.
And
but in DELIVER trial, now they recruited heart failure with the preserved ejection fraction with the EGFR of up to 25.
If any patient while on therapy of dapagliflozin or empagliflozin developed UTI, so do you recommend to stop the medicine or do you still continue the medication and continue the antibiotics?
So because the drugs are very effective, so I think for the first episode itself, I will not stop the medication. But if patient tend to develop recurrent UTI, then we might have to stop the medication.
And it has also been shown that if you use DPP4 inhibitors with SGLT2 inhibitors, there is a less chance of GI infection, generative infection.
Yeah, for diabetic patient, that is true.
One question from my side. How can we manage the patient of severely reduced ejection fraction with class 4 symptoms? If we give this drug to these patients, so how would you manage the fluid in such cases? Because this drug should be given with at least 1 glass of water. So how would you manage when there is so much restriction of the fluid?
So actually, because in these heart failure patient, we are giving a lot of diuretics also. So if you want to cut down, if you want to add SGLT2 inhibitor, we might reduce the dose of diuretic a little bit, and then we can add SGLT2 inhibitor. It is not necessary that this SGLT2 inhibitor should be taken with the 1 glass of water. It is not necessary.
Okay. Any questions from the audience? So let's move to another topic.
Thank you.
Dr. Sidana, thank you. One more question. If patients of chronic kidney disease stage 5 on maintenance hemodialysis, what would you like to prefer, whether DAPA or AMPA?
We don't have any data for any SGLT2 inhibitors in end-stage kidney disease, so we cannot have. We cannot recommend any.
Maintenance hemodialysis.
We don't have any trial in that category of patients.
So we should not use.
We don't have any trial, so we cannot say whether we should use it or not.
In hemodialysis patients, we can use the low dose DAPA, 5 milligram DAPA we can use, and we have to be very cautious about the decreasing the further GFR in such cases. So next speaker is Dr. Neeti Chadda Negi. She will be delivering a talk on Versigoat, the worsening heart failure management, thinking beyond diuresis and discharge. Dr. Neeti Chadda Negi.
Good evening, everyone. And the topic for this time is worsening heart failure, thinking beyond diuresis and discharge. So what more can we do in a patient whose heart failure is worsening despite stable medical therapy? You have to believe me that this is the most important clinical situation which the clinicians who are treating patients of heart failure face when their patients start deteriorating despite optimized medical therapy. And we are actually looking seriously for options which are available, because other than that you can just counsel your patient that this is a very high risk situation. So clinical worsening despite stable medical therapy is a situation which needs to be recognized early and look for options what are available. Thankfully, there is a new drug in the block, and it is showing positive results, and we'll see what that is. Now, to start with, the heart failure, when there is an initial diagnosis which is made, at the time of initial diagnosis, we need to know that this patient is already high risk, because a heart failure patient, clinical heart failure is already a high risk situation. When this patient goes into a worsening heart failure event despite stable medical therapy, this becomes an extremely high risk situation. However, this is stabilized and the patient is given treatment, management and discharged, followed up, but they enter into this vicious cycle and there are recurrent heart failure events and recurrent hospitalizations which can happen. And in a US registry, it was shown that over half of the patients were re-hospitalized within 30 days of a worsening heart failure event. So the clinical worsening or the worsening heart failure needs to be recognized early and therapy instituted. As the slide show, whenever a patient is diagnosed with a heart failure, despite the fact that this is a stable outpatient reduced heart ejection fraction heart failure, the patient is already high risk, and when they enter into this vicious cycle of worsening heart failure, they become an extremely high risk patient. So again, the slide shows that with a worsening heart failure despite stable therapy, there is some subclinical deterioration which happens into the pathophysiology, and they go on into this vicious cycle and worsening after worsening after worsening, and they move inch towards death early. So, initially when the heart failure risk factors are there, the heart failure risk goes on increasing. There is a clinical risk already which is present, which may go on from months to years, and then they are diagnosed, the diagnosis and treatment, the heart failure risk persists. With the treatment, the heart failure risk may go down somewhat, but it persists. There is a residual risk which is present, and these patients may enter into a phase of worsening heart failure, which then quite rapidly goes into worsening, and they enter into this advanced heart failure, wherein they become refractory to guideline directed medical therapy. Talk about a cardiac transplant or mechanical circulatory support start, IV inotropic therapy start, and palliative care. These patients are usually tough to salvage. So, it is seen that despite the quadruple therapy which is now available for the heart failure, the residual risk stays, and 1 in 7 patients experienced a primary outcome event of hospitalization or cardiovascular death despite confirmed use of quadruple therapy. So, we know that heart failure amounts to a significant burden of heart failure hospitalization, and 1 in 2 patients will be hospitalized again within 30 days. 1 in 5 patients will die within 2 years of their worsening heart failure events. So this slide shows that a chronic heart failure patient is at a risk of all-cause mortality, but it is lower than a de novo heart failure, which has got a higher risk of immediate mortality. But the worsening heart failure fare even worse, and their all-cause mortality rate goes up significantly. It is 27.7%. So, the risk of cardiovascular death or heart failure hospitalization is highest in the early phase after hospitalization. So, once your patient is hospitalized, the next 30 days are actually very important, and then 3 to 6 months are more important, because these patients will be re-hospitalized early. 1 in 2 patients gets hospitalized in first 30 days, and the hospitalization for the first 6 months is also high. These are about 46% higher in patients with recent hospitalization. So, a hospitalized patient should be taken very seriously, because that is the time when you can probably change the trajectory of his life. And now the new therapies are available. So, initially what was happening was, when the heart failure event occurred, every one of us would try and optimize the guideline directed medical therapy. In some patients we succeed, in some patients we do not succeed in initiating the target doses of quadruple therapy, because of there are so many contraindications like renal function, potassium levels, blood pressure. So, all these will deter in initiating a target dose of guideline directed medical therapy. But once a worsening heart failure event occurs, there is a new drug which is now available, which is vericiguat. We will read about it. So, not only does it symptomatically manages the patient, it also changes the trajectory, and it is shown that the clinical risk of a repeat hospitalization is reduced with the use of vericiguat, which is over and above the optimized medical therapy, as compared to the usual care which we were giving, wherein the worsening heart failure goes into this cycle of worsening and reaches the advanced failure. So, advanced heart failure is reached in a lower number of patients when they are put on vericiguat. So, this is a Victoria trial which was done in patients of worsening heart failure, and this studied the drug vericiguat. The vericiguat acts on the soluble guanylate cyclase molecule, and it leads to an increased CGMP levels. So what the increased CGMP levels does is, it reduces the inflammation and fibrosis and the hypertrophy of the heart. It leads to a vasodilation in the blood vessels and improves the renal blood flow. So Victoria trial was specifically designed in view of worsening heart failure patients. So 67% of the patients were enrolled less than 3 months after a index event of hospitalization, and the 17% were in 3 to 6 months after index hospitalization. Now baseline characteristics, they were very high risk patients. So NYHA class 3 and 4 amounted to about 40% of these patients. The EGFR less than or equal to 30 was seen in 10%. And these drugs, the patient was 60% patients were on triple therapy, and as we studied, 67% had an index hospitalization within the last 3 months. So they were actually very high risk patients, the patients you would want to salvage earliest. So even in this heart failure population, the best part was vericiguat as compared to the usual care plus the placebo. It led to a treatment improved, a cumulative incidence rate which was reduced with vericiguat as compared to placebo. The median treatment duration for the primary endpoint was 10 months, and the annual event rate was, with vericiguat it was 33.6, and with placebo it was 37.8, with a hazard ratio of 0.90. So even in the very high risk patients with the usual care, the optimized medical therapy, the trial was able to show the benefit of vericiguat. Vericiguat was good, and the absolute risk reduction happened in all 3 endpoints, which was primary composite endpoint, heart failure hospitalization, and the all-cause mortality. It has got a favorable safety profile, no significant difference in symptomatic hypotension or syncope, and the electrolyte disturbances were also less as compared to the placebo. 90% of the patients were able to achieve the target dose of 10 milligram of vericiguat after 12 months. The cardiovascular benefit of vericiguat is mediated by an early and sustained reduction of NT-proBNP levels. So this was evident at week 16 and maintained throughout the study. So NT-proBNP levels reduced. There was minimal difference in systolic blood pressure as compared to the placebo. So in this slide, the upper slide show age less than 75 years. Even the blood pressure stayed same as compared to the placebo with the use of vericiguat, and the profile was similar for the placebo and the vericiguat, and it was able to show benefit. So in all the other trials like Paradigm heart failure trial, DABA heart failure, Emperor reduced, what was done was one of the usual care medication was changed to a new drug, like ACE inhibitors were shifted to SGLT2 inhibitors, but or ARNI. But here in this Victoria trial, vericiguat was added to the usual care, and it was added to the quadruple therapy. So this is the dosing profile. 2.5 milligram was continued for 2 weeks. Then at the end of 2 weeks, if there is no significant electrolyte issues, hypotension, and the patient is tolerating it well, you increase it to 5 milligram, wait for 2 weeks, again reassess, again change to 10 milligram and continue with all the background heart failure therapies. No specific electrolyte monitoring is required for vericiguat, and usually there is no symptomatic hypotension, but they've suggested that the blood pressure should be at least 100 or 110 millimeters of mercury when you start the vericiguat. Vericiguat is suitable for vulnerable patients due to its favorable safety profile. Even the patients at risk of hypotension you can give, a patient with renal impairment can be given, and patients with hyperkalemia, these drugs can be added, which is not the case for the other heart failure medications. So this is a profile which is suggested after the results of Victoria trial. So there are 3 clinical scenarios which has been shown. The clinical scenario 1 is that the patient has experienced a heart failure hospital, just one or two slides more. So clinical scenario 1 is the patient has experienced a decompensation event under optimal background therapy. So the heart failure therapy is optimized, but still there is a decompensation which has happened. You start this vericiguat on top of a full optimized therapy. Clinical scenario 2 is the patient is decompensated, but there is a suboptimal background, suboptimal therapy which is continued due to contraindications or intolerance or a low GFR, low BP, and you start vericiguat on these patients. The clinical scenario 3 is that your patient has decompensated under suboptimal therapy, and you can optimize these patients. You can still optimize, but even after optimization, you start them on full vericiguat dose. So the key points are quadruple medical therapy is foundational therapy for all eligible patients with worsening heart failure to extend the survival, reduce the hospitalizations, and improve the outcomes. So that is for sure, and we continue with that. We do not change or remove any drug out of this to add a vericiguat. So even the rapid sequencing or a simultaneous initiation of quadruple medical therapy, anyone can be done, and an upfront use of vericiguat should be considered among patients of worsening heart failure, because this is the population which is most at risk but salvageable. Once they enter into an advanced stage, then sometimes it is not possible to salvage. So this is the point when we have to up titrate the therapy. Use of vericiguat should be considered among patients with worsening heart failure, even in patients who have contraindications or intolerance to the completion of an optimized medical therapy, and intravenous iron can be added as required for iron deficiency to improve the functional status. Thank you.
Thank you. One question from my side, ma'am. It is a vasodilator acting on the
CGMP pathway.
GC stimulator. So, since we know that hydrogen and dinitrate combination we are using in the heart failure in the patient who are refractory to these main class 1 drugs, so could it be a the replacement for this hydrogen or dinitrate or something else?
So this discussion is going on that why not use the other nitric oxide donors, and what is the difference in vericiguat. So what they say is that in this heart failure, in this worsening heart failure milieu, the nitric oxide has to be activated before it acts on the body. But this vericiguat, it is acting on the cytosomal guanylate cyclase, wherein no other molecule reaches, and this pathway or this cytosomal guanylate cyclase to CGMP, it is not downgraded in a heart failure milieu. So this is very active. This molecule acts in its full potential even in heart failure patients. So this is not you cannot replace this therapy with the whatever was available previously.
Is there any contraindication for this drug, or it can be given all other subsets of patients?
I know. So this vericiguat, I asked the same question to the people, and this is sounding too good to be true types. So as of now, I don't think there is any contraindication which is known. Maybe Dr. Nayak sir or somebody can speak on it. I don't know of any contraindication which is.
This drug should not be used with a PDF 5 inhibitor and nitrates.
Yeah, the sildenafil and all. At least Indian doctors are going to love it. I mean,
What is your recommendation? Because we are prescribing 2.5 and up to titrate the 5 milligram dose of Versugat in worsening heart failure patient. But we are trying to prescribe on the 10 milligram dose of the, as per the Victoria trial. As such, in my practice, the patients are not tolerable of the 10 milligram
so
dose
even in
because on the
Victoria,
ARNI and so many drugs we are prescribing.
so even in Victoria trial, about 30% patients were Asian population. Asian population has been included in Victoria trial, and so what the trial says is that it does not have any major side effect on systolic blood pressure. You are very right in saying that when we are treating in the actual clinical scenario, there are a lot of patients which will come to you with a blood pressure of 90 or this, and maybe in these patients an up titration is not recommended as well. But there are a lot many studies which will be done before we'll get answer to this question, but yes, below 90 or below 100, it is not recommended.
Thank you.
It's time for the next session. Thank you, Dr. Nikki.
Thank you.
Thank you.
So before moving to the next session, so we have that tiebreaker round. So I would like to invite all our panelists to please come, sir. Ajay Nayak sir, Anup sir, Makkar sir, Dajit ma'am. And I would like to invite two winners. The first, there's a tie between two doctors, Dr. Abhilasha and Dr. Aryant Seth. Both of them are here. Dr. Abhilasha, Dr. Aryant, please come here. So for this, you won't have any option. So you will be shown two ECGs, and you have to describe that ECG. And I think based on your description of the ECG, I think sir will decide.
माइक ऑन कर दीजिए और आप एक माइक के पास आ जाइए. दोनों माइक ऑन कर दीजिए.
So based on that, sir, we will decide who will get the first and the second prize. So can I get the ECGs on here? ECGs? Here, perfect.
Hello.
So we can see the ECGs, case 11. So this is the first ECG. Whom should we ask? Ladies first. So this is the ECG. You have to just describe the ECG. Whatever you can see, whatever you see, just describe it.
It could be a junctional pacemaker rhythm with the wide QRS complex, because after the P wave, there comes a spike wave followed by the QRS. So, yeah, that's a junctional pacemaker maybe.
Keep on describing.
Okay. Also, there's a inverted P wave, and yeah, that's it.
So there is difference between first half and last half of the ECG, no?
Yes,
What
sir.
is the main difference? What is the striking difference? Heart rate is increasing, no?
Yes, sir.
How much? What is the heart rate before and after?
So relatively.
So how do you calculate the heart
so
rate?
It's a
yeah.
so 300 divided by the big boxes, that is 75 around. And in the other half of the side, there is a tachycardia of heart rate around 150, I guess.
So basically,
during this ECG recording, a tachycardia is starting.
Yes, sir.
So can you now think why, what is this kind of tachycardia and why it has happened? So what you are seeing in first 4 beats, क्या है? First 4 beats क्या है? Like you said, paced QRS.
Yes, sir.
So it is a P wave followed by a spike and QRS complex.
Yes, sir.
Then what is happening
And
in
in
the
the next leads, there is a QRS complex followed by the spike wave in the absence of P wave.
Can you speak loudly?
So in the next leads, the other half of the leads, there is a QRS complex followed by
So when you get an ECG like this, don't get flabbergasted by looking at everything at once. You see the first half, it seems to be normal, and something is happening in the second half, correct? That is the problem. The second half is the problem. So in the first half, the first 4 beats, everything seems to be okay. There is sinus rhythm,
yes, sir.
there is a P wave, and there is a QRS.
Yes, sir.
And each QRS is preceded by the spike.
Yes, sir.
So the sinus wave is being, P wave is being sensed, and the ventricle is paced, first 4 beats.
Yes, sir.
Okay, you're saying inverted P wave, but that inverted P wave is in V1. You really, in V1, you cannot say anything about P wave morphology too much. You have lead 3 here, which is inferior lead, which will give you a better idea. Actually, the P wave is upright. It is
Yes,
okay. So it is a sinus P wave here, right?
Yes,
So sinus P wave, A sense, V pace is going on. See, it appears to be a dual chamber pacemaker system, correct?
Okay,
First
sir.
4
Yes,
beats are fine. What happens in the 5th beat? You see a P wave. Look at only lead 1 now. Forget the lower 2 leads. Oh,
Sorry.
it went away from. So the 5th P wave, what happens there?
It's a biphasic, I guess.
Forget about the morphology. What happens? There is a P wave, and there is no immediate QRS following that,
Yes, sir.
isn't
Double
it?
spike.
It's a problem, right? It doesn't look normal.
Yes, sir.
So there's a P wave, there is no QRS like in the 4 preceding beats. Here it is something different. Instead, you see 1 spike and a second spike, and then a QRS.
Yes.
So when there are 2 spikes which are close to each other, what are those 2 spikes likely to be? This is a dual chamber pacemaker system.
Okay,
So the
sir.
first spike will be atrial spike,
Yes, sir.
second spike will be ventricular spike,
Ventricular. Yes.
and the ventricular spike is capturing the QRS. But the atrial spike, there is no P wave after that, isn't it?
Yes, sir.
Because that spike is coming soon after the previous P wave. So already the atria are depolarized, and now the spike is not able to capture the atria. But why did that atrial spike come? There is a P wave there, but still there is an atrial spike. Why is that? That is the crux of the CCG. So there is a P wave, there is an intrinsic P wave, but the pacemaker is not able to pick up that P wave. So the atria are not being sensed properly.
Okay,
So the P wave is not sensed properly. So there is atrial undersensing. Since the P wave is not sensed, the atrial lead, the pacemaker gives a atrial spike. And then naturally it is going to be followed by a ventricular spike.
Yes, sir.
So that's why you're seeing those 2 spikes there. So you get a ventricular spike, and then what happens? Then the tachycardia starts. What is the rate of this tachycardia? The second half, approximate. I don't want
So
to.
150 round.
Almost 150 beats per minute.
Yes, sir.
So what is it likely to? What is possibility? What could be occurring? One possibility is maybe suddenly the patient had atrial tachycardia at 150 beats per minute, and the ventricle started following the atrium. Yeah, that is one possibility, but here the atrium is not sensed properly. The other more likely possibility is what? That the ventricle paced and then there is retrograde conduction from the ventricle to the atrium. And that is now sensed, and then the ventricle is paced again. And atrium, again retrograde conduction to the atrium. Again ventricle is paced. What is that called?
Accessory pathway AV.
Oh, you have a pacemaker system here. यहाँ तो complete heart block है patient को. Accessory pathway will not create a tachycardia here.
Okay, sir.
You can answer if you want.
Why don't
You
you
want to
speak?
comment? You have now.
You are on the right path now. Your path has been shown to you. Yeah, but before each, you're right, there is the ventricular rate is fast. Why is the ventricular rate fast? There is a spike before each QRS. So the pacemaker is giving a spike.
Right ventricle, because it is the LBBB, so right ventricular is getting impulse, so it is conducted.
No, but sir is asking if it is ventricular tachycardia, why there is a spike before each QRS? Ventricular tachycardia में spike क्यों आएगी? Spike आ रही है ना? जब नॉर्मल बीट चल रही थी तब भी QRS स्पाइक से शुरू हो रहा था. अब जब आप वेंट्रिकुलर टेकिकार्डिया बोल रहे हो, even then the QRS is starting with a spike. So now what is this?
Sir, junctional could it be? The pacemaker is sensing the rhythm from the junction and then followed by the ventricular tachycardia.
Okay, I think we can.
I think we can move to the second question.
Maybe it is a little complex.
Yeah, little complex, but well tried. So, simple thing, when it is a tachycardia and every QRS is being preceded with spike, that means it is still paced by the pacemaker, no? So, it is pacemaker mediated tachycardia. So, as sir was explaining, it was atrial undersensing and then ventricle entering into the atria, then sensed by. So this rate is determined by something called upper track rate, which is programmed in the pacemaker. That's really complex. We can go to other one. Yeah.
See, this is a very unique thing. This is a re-entrant circuit, okay? But it's an extra cardiac pathway because it's coming from the pacemaker. Yeah. So it's a re-entrant circuit, but the pathway is like this between the pacemaker and the heart. How do you treat this? Any idea? Instant treatment.
Anybody, how to treat? Yes. Please.
No. Perfect.
So by increasing post-ventricular atrial refractive period, PVAR.
Yeah, but
very nice.
Patient is in the emergency room and you immediately need to do something.
Yes.
We can put the magnet over the.
Perfect.
Perfect. Go to the next one.
So this
now
is the.
You start this describing this ECG now.
Don't jump to the diagnosis. Just keep on describing the ECG.
This is a paced rhythm with both atria and ventricles are being sensed, so it is probably it is a dual chamber pacing, and the QRS morphology is of LBB type, so probably the pacemaker is in right ventricle, and after the first 2 beats there is a drop in a QRS complex. So after the P-wave, QRS complex is not seen.
Why?
So, is this a single chamber or a dual chamber pacemaker?
It's a dual chamber.
Okay. And is it programmed in a atrial tracking mode or a non-atrial tracking mode? Atrial tracking mode, okay. Sensing mode, okay. So the first 2 beats, you are seeing atrial pacing and ventricular pacing, right? And both are capturing because after the first pacing, there is a P wave. After the second pacing, there is a QRS. You said that this is a LBB morphology, which I don't know how you made out there is a LBB morphology because we don't know the lead
There is no 12 lead which is available. So I don't think we should mention that this is any particular morphology which is there. Now, comment on the third beat, wherein you see first one pacing spike and there is a P wave which is following, but after that there is a silence, and then we come on to the fourth and the fifth beat. So what's happening with the third beat? Where is the QRS? Why is it not there? Why is the pacing spike not there? So the pacemaker is working, otherwise it's working very well, but there is no ventricular pacing spike. Why did the pacemaker stop giving a spike? Why was it inhibited? Why did it got inhibited? Did it see something else? Did it see something that it said, no, I'm not giving a spike? You can start.
Heart might have, ventricle might have generated their own impulse, so the pacemaker sensed it, so it hasn't given the spike.
If we want to close this, just two questions. One, whether it is oversensing or loss of capture. Whether it's oversensing or loss of capture. You have to choose one.
Loss of capture.
Oversensing or loss of capture? If there is a loss of capture, there should be a spacing spike and then no QRS. That's a loss of capture. हमें दे दो आप लोग. हम ले लेते.
No, you have to answer. Oversensing or loss of capture?
No, he was saying that ventricle has generated something of his own. So that should have been seen. But there's something unseen has been sensed. So that's why we are calling it is oversensing. But you were very close to it anyways.
So I think, sir, you can decide who will win the first
No,
prize.
then we have the other candidate also.
No, sir.
अच्छा फर्स्ट किसको देना है सेकंड
फर्स्ट एंड सेकंड किसको देना है सर सिंपल सिंपल और लगाऊं सर एक और ठीक है सर
एक सिंपल इसी और लगाओ टाई ब्रेकर
सर ये बता देते हैं बस
ये तो सुबह हो गया था ना
नहीं सर ये नहीं हुआ था सर
Left bundle branch block.
Kush, where are you? Okay. Yeah, so this patient had a sudden onset breathlessness.
History is like this patient developed sudden onset cough and a syncopal episode.
Left bundle branch block, I would go.
Wonderful.
Okay, sir.
Chalo, closed. He's first and you are second.
So I think,
Great.
sir, you can give the prize or sir.
Yeah. फर्स्ट सेकंड के लिए एमआरपी देख लो ना really smart watch for a smart person. You can come to collect it from Dr. Ajay Naik. ओके एक लेडीज है दोनों लेडीज एक साथ दे देंगी ना उल्टा हो गया लेडीज को जेंट्स से दिलवाना चाहिए गॉड ब्लेस यू आ जाओ बेटा आ जाओ दलजीत वेल डन आप दोनों दो इसको Okay, let's start with the
yes, sir.
next
So we can move on to the next session. Nitesh ji, please.
I'll request speakers if they can conclude their talk in first buzzer so that we can have 2 minutes for discussion. Otherwise, we'll extend our So first buzzer is after 13 minutes. So if we can conclude it there, then 2 minutes we'll get for discussion. Thank you.
So ladies and gentlemen, let's give a big round of applause to the winner of the ECG quiz. Congratulations on showing your expertise and winning exciting prizes. As we move forward, get ready for our next session, device therapy in heart failure. Our speaker will dive into crucial aspect of device-based treatment. For this session, may I request the chairperson, Dr. Nirmal Sarma sir, Dr. Naresh Sen sir, Dr. D.K. Garg sir, Dr. Sanjeev Sidana sir, Dr. Kasliwal sir, Atul Kasliwal sir, Dr. Gaurav Singhal sir, Dr. Sanjeev K. Sharma sir, Dr. Prashant Dwivedi sir. Thank you. May I request all the chairperson to come forward. Thank you very much. Dr. Raghvendra Chaudhary, sir, please join. May I request Dr. Deepak Gupta, sir, to chair the session.
Okay. So the second talk which I've been asked to deliver is device therapies in heart failure. Very common, and normally, you know, what we are going to discuss for the next 15 minutes is ICDs, CRTs. Both CRTP, which stand for pacing, and CRTD, which stand for defibrillator along with CRTs. I'm not going to touch about the MCS because that again is a big subject and probably a separate talk. So about heart failure, CRT has become an effective modality probably for last 2 decades in drug refractory heart failure. So this is very important, like, you know, when we advise CRTs, make sure patient should be on optimal medical therapy with optimal dosing. And despite that, if patient remains symptomatic, yes, they are candidate for CRTs. And it's usually indicated with severe LV dysfunction, systolic, and medically refractory heart failure with conduction delay. And the gold standard is left bundle branch block, QRS duration more than 150 millisecond. It improves symptoms, enhances the quality of life, increase exercise tolerance, and reduction, like, you know, again, remodeling, reverse remodeling. And about AICD is proven to reduce mortality both in primary as well as secondary with LV dysfunction. And primary normally comes with ischemic heart disease, MI 40 days, and still the LV function less than 30%, what the MEDIT2 has taught us. So let us go first with the CRTs and then the ICDs. So what is the rationale of CRTs? So improve contractile function, reverse ventricular remodeling, decrease secondary MR, which is because of the dilatation of the left ventricle. It does improve diastolic function also, and it improves the heart rate variability also. And what are the study endpoint for CRT trials? So whatever the trials have seen, 2 things: acute hemodynamic effect, what the acute hemodynamic effects, and what is the short and long-term effect, and what you are going to measure. Measure the heart failure progression, mainly like, you know, echocardiography, what is the ejection fraction, what are the LV dimension, what is the status of MR, what is the NT-proBNP level. Then this is very simple. In your outpatient clinic, you can perform these things: 6-minute walk test, what is the exercise capacity of the patient, and other important thing is how many hospitalization for heart failure, what is the mortality and what is total mortality. So these are the study endpoints for all the trials. So what is the latest recommendation? So, European Society of Cardiology, if you say 2023, left bundle branch block, LV dysfunction, QRS duration more than 150 millisecond on optimal medical therapy, class 1A indication. So that's very important. If it is borderline between 130, 150, so it is 2A indication. And again, if it is a wide non-LBB QRS duration of more than 160 millisecond, again it's a 2A indication. What are the criteria in NYHA class? So normally we advise CRTs in class 3 and 4. Exception is only one when the patient is a candidate for ICD with class 1, NYHA class 1 and 2. Probably we will give a CRTD on those patients. Etiology, again, probably non-ischemic are the best. Ischemic may be responders, may not be responders. Sinus systems are good. Atrial fibrillation, if suppose you are doing a AV node junction ablation, in that situation, probably CRT or a conduction system pacing is required. QRS duration, what I said, LBB with more than 150 millisecond. PR interval, that is more important for a device programming rather than the indications and all this thing. So mild heart failure indication for ICD, this is the exception of CRT implantation. So class 1 or 2, ejection fraction less than 35%. QRS duration more than 130. If patient is a subset for ICD, give CRTD rather than giving only an ICD. What we have seen, it significantly improves the LV volume and LVEF in YHA class. Otherwise, rest of the things probably doesn't really help. What are the predictors? So predictors, if you see non-ischemic cardiomyopathy, they are the best responder for CRTs with left bundle branch block. And these are the things like, if you have end-diastolic diameter or end systolic diameter, which does suggest like probably patient is going to respond to CRTs or not. But if you see the funnel, the reverse funnel, so gender, female gender, LBBB more than 150 millisecond, they are the best. Narrow QRS, they are the worst. Male, again, in between an ischemic cardiomyopathy. Again, depend upon the scarring. If it is on the posterior side or the lateral side where the circumflex lies, where you are going to put your LV lead, that the scar area probably is not going to really work. So this is like typical left bundle branch block, more than 150 millisecond, do a good CRT implantation, and you can get a ECG almost like a normal ECG, almost like a normal ECG. So what are the current criteria? So many trial and many studies have come with the echo also, but again, those are all disappointing because not a single parameter of echo can really suggest which are the patient in which you can really select to give CRTs or not, whether it's a broad QRS or it's a narrow QRS. So far, the QRS is the king. So left bundle branch block with QRS duration of more than 150 millisecond, that's the more important thing. Do we have any role of echocardiography? Yes. If the patient has got more than what we call as more than right bundle branch block. So what is more than right bundle branch block? It means the chest lead, the standard lead showing left bundle branch block pattern and the precordial lead showing right bundle branch block pattern. In these patients, if suppose the patient has got an indication for ICD or patient has got an indication of any pacing, so better you do a radial strain, and radial strain you see the delay between the septum and the posterior wall. If it is significant, these are the patients who are going to respond very well to CRT. In fact, during the implant, what we see QLV, like, from onset of the QRS to the later part of the activation of the left ventricle, if the QLV is more than 110 millisecond, probably we say that, these patients are going to respond to CRTs. So right bundle branch block, mechanical or electrical LV delay, if yes, certainly these are the candidates in which you should consider giving CRTs. And this is one example, like, post-cabbage, severe LV dysfunction, right bundle, left axis, patient had got a recurrent syncope. So obviously recurrent syncope, patient becomes a candidate for a pacemaker. Since it's an LV dysfunction, so candidate for an ICD because it's a post-CABG patient. And in this patient, if you see the radial strain and you think that probably CRT is going to improve, you can put a CRT. In this patient, what we did a conventional CRT, but on table the QRS was not getting narrowed down. So what we did, we modified it to LOT CRT. So we put the fourth lead in the left bundle pacing. So left bundle pacing along with the LV pacing, and you can see the ECG is absolutely normal. It's almost 2 years down the line, the patient has improved remarkably. So, selected patient of right bundle branch block, you have to pick up which patient you really want to give CRTs. So what are the measurable outcomes? NYHA functional class, quality of life, 6-minute hall walk test, which is very simple, and peak consumption. So what are the trials which has favored? Companion trial, optimal medical therapy versus CRT. CRT both arms, CRT-P versus CRT-D. Almost 130 center in the United States, almost 1500 patient, LV ejection fraction less than 35%, class 3-4, cure duration more than 120. What was the primary endpoint? All-cause mortality plus all-cause hospitalization. And it was prematurely terminated. Why? The event rate, if you see all-cause mortality predicted was 24, actual was 19. And all-cause mortality plus all-cause hospitalization predicted 40, actual 68. So, it showed CRT was much, much superior than the medical management. And if you compare between the two, CRT-P versus CRT-D with optimal medical therapy, primary endpoint with CRT 34%, D 40%, secondary outcome 24%, 36%, and P-value in both the segment was significantly better. The other trial which came was CARE-HF trial, again LV ejection fraction less than 35%, class 3-4 patient, cure duration more than 150, control versus CRTs, and the endpoint, again, it was prematurely terminated. The reason why, because if you see, the primary endpoint, all-cause mortality or hospitalization on major cardiovascular event was occurring less in CRT group rather than the medical therapy, and even the secondary endpoint of all-cause mortality was much, much significantly lower in CRT group than the control. And if you see, the p-value was less than 0.001. So that suggests CRT is much, much superior than medical management. Obviously, the patient should be on optimal medical management before that. So what is the recommended right now target population for CRT? So class 3-4, LV less than 35, left bundle branch block, dilated LV sinusitism. This is class 1 indication. A patient has got a right bundle or non-specific IVCD with more than QRS duration of 150 milliseconds selected. You have to really choose those patients. On table also, and you can now, on table you can convert these patients to lot CRT or hot CRTs. Patient who are class 1 or 2 indication for ICDs should get a CRT if the patient QRS duration is more than 130 milliseconds. Chronic AF required, because of you cannot control the AF rate and patient is going to LV dysfunction, and you are doing AV node junction ablation. In that situation, you have to decide whether you want to give CRT versus CSP. That is the thing. If the patient who requires a pacemaker and his LV function is less than 40% and you think that patient requirement of pacing is going to be more, in that situation, again, you have to give CRTs. So the latest 2022 guidelines, what it says, the recommendation of CRTs. So this is what is very important, what is the general status, any comorbidities or not. If the patient is not going to survive for a longer time, probably you are going to keep on guideline-directed medical therapy. If not, if the patient survival is good, what is the ejection fraction, what is the NVIJ class, and then you decide what exactly you really want to give. And this is how you decide about CRT-P versus CRT-D also. Coming to the second device, ICD implantation, probably in our part of the world, what we are doing is mostly secondary indication. Patient who has suffered about a sudden cardiac death or documented VT, scar VT or polymorphic VTs, those are the patients we are doing. And what are the studies which favor the secondary, the AVIT, CASH and SIDS and CABG patch trial. But primary indication, probably Western world, they are doing a lot of primary indication. In fact, in our patient population also, we suggest all the patients who had got a post-MI, LV dysfunction more than 40 days, less than 35% ejection fraction, according to the MADIT-2, we say they should undergo ICD implantation. Definite trial was for non-ischemic cardiomyopathy. In fact, when they implanted ICD and on follow-up they saw a lot of patients got an appropriate shock for VT. So that again suggests probably certain kind of patient or non-ischemic cardiomyopathy, they can be benefited for primary indication. Nowadays what we do a cardiac MR and see whether there's any late gadolinium enhancement or not, any scarring or not, and then we decide whether you really want to do. So MADIT-2 again conventional therapy versus ICD, and the difference was 5.6%, p-value was significant, almost the number was, both arm was significant, more than 300 patients. And what it says, all the trials, MADIT-2, SCUDEFT and companion trial, CRT-D versus CRT-P or a CARE-HF trial, what it says, if the patient, suppose you assume patient is going to survive for 2 years, so probably you are going to save 1 life out of 25 devices. If suppose the patient is going to survive for 5 years, probably you are going to save 1 life out of 10 devices. That's quite a lot. And if 10 years survival, excluding replacement, again 1 in 10 device. So that's very significant. So patient should be given ICD who has got a LV dysfunction, ischemic cardiomyopathy or scarring on MRI, cardiac MRI. So what is the efficacy of ICDs? Patient has to survive some years to get the ICD benefit. He should not die because of pump failure. He dies because of pump failure, ICD is not going to work. So assume the benefit one patient with every 10 device implant considered attractive. So predictive life expectancy free of sudden death should be 5 to 7 years. And this is what I'm said, like, you have to really pick up your patient. They should not have a lot of comorbidities. Patient should not be an elderly that, they are going to die because of some other cause rather than arrhythmias and all. So how it works as a pacemaker also. It gives anti-tachycardia pacing, it cardiovert if it is a VT, it defibrillate if it's a VF, and it's a very small pocket-like thing. So, really good, and it saves a lot of life. So this is very important. Newer device, they have got anti-tachycardia pacing even during the charging also. So, you avoid shocks. And what I said, if the shock is delivered for VT, what we call as a cardioversion. If it is delivered for VF, we call it as a defibrillation. Why it is important? Because painless, highly effective, no battery drain. What are the indication of 2023? Again, class 1A indication. And now this is very important. ACS guidelines has added value statement, high value. So, again, it's a high value category of A. So, this definitely provides saving the life and everything. So, what MEDIT 2 again is a class 1 indication. MEDIT 2 says, like, for a primary indication you should give. Few point about CRTP versus CRTD. So, how do you select? If it is a ischemic cardiomyopathy, no question, you give CRTD. Non-ischemic, Danish trial has shown, like, if you improve the patient LV function, probably they do not require ICD. So how you are going to judge? Probably you do a ELR or Holter monitor to see what is the burden, get a cardiac MR, see whether there's scarring or not. If not, give CRTP. The other thing is, if suppose patient has got a short life expectancy or has got major comorbidities or has got a renal failure, not going to survive more, probably give CRTP. So this is the seesaw thing. So, it's driven. Life expectancy less than 5 years, give CRTP. If life expectancy more than 10 years, give CRTD. That's very important. So you see that thing. So what are the benefit and problem with the ICD and CRT? CRT definitely improve the LV function. That's very, very important. Improve quality of life, increase longevity, probably prevent worsening of heart failure, prevent sudden cardiac death. Although problems are variable response, we know the response rate is 70%, not more than that. You have to choose your patient. It doesn't treat near sudden cardiac death. ICD, it will treat all near sudden cardiac death. Problem with ICDs is inappropriate shock sometime, the cost, the size. Because see, if you are putting an ICD, CRTD, it's a big device. You have to manage the pocket also. So to take home message conclusion, CRT has become an important part. Guidelines broaden the scope of patient who can benefit. You have to really choose which you really want to select. QRS duration, symptomatic heart failure, low AF, CRTP versus CRTD, that's very important. Counseling the patient, shared decision, patient, family, and the physician. It's a shared decision whether you want CRTP versus CRTD. AICD should be considered in all ischemic cardiomyopathy less than 35% patient. And what is the quote? All patient will die eventually. Waking up in the morning carries a risk. Alternative may not be attractive. So important statement, doctor should manage risk in an intelligent fashion to choose the best treatment for each person on individual basis. I'll stop here, take your question. Thank you very much.
Sir, we have one question. We have a case of alcoholic non-ischemic cardiomyopathy, severe LV dysfunction. The QRS complex around 110, but we have the plan for QRS complex is 110, not broad QRS complex, but LV function around 28% and NYHA class 3 symptoms. We planned for the dobutamine stress echo, and the rate dependent LVB was there, and simultaneously we performed the CRT echo, but the AV delay significant and septal to posterior significant delay. We thought and discussed about the CRT implantation future. Would you recommend that case? Should we recommend that case for the CRTD or not?
No, I could get half of the question. Means what you want to ask, QRS duration of 110 milliseconds?
Before the stress-induced dobutamine stress echo, the QRS complex was 110. And after the dobutamine stress echo, the QRS complex was 170.
So what was the rate? What was the heart rate during 170 QRS? So with dobutamine, you mean to say it was a rate related?
Rate dependent because high heart rate and around heart rate was 133.
So the thing is that, if the patient is a candidate for an ICD, suppose the patient is a candidate for an ICD, if it is ischemic cardiomyopathy and you're thinking of putting an ICD, probably I'll go for CRTD. If not, if it is non-ischemic only for CRT, I will get a Holter or ELR, and I'll see, like, how much duration of time the patient is getting left bundle branch block. What is the heart rate variability during the routine activity? Because see, we know that dobutamine from rate of 70 or 80 baseline rate can go up to 140, 150. Suppose his LBBB is happening at 130, 140, which is not going to remain in the patient. Probably they are going to be non-responders. So, if you perform a EL or a Holter and you show like LBB is coming at a rate of 100, 110, or probably majority of time the patient is getting left bundle branch block, probably that patient may be a candidate for CRT.
What should be the acceptable magnitude of mitral regurgitation before going for, say, CRT? Would you like to do something before going for CRT for severe mitral regurgitation?
So that's a good question. So now the thing is that, what is the etiology? If it is a purely because of the LV dilatation, you think that this is dilated cardiomyopathy, pure, because of LV dilatation, it's a secondary MR. Probably we'll go for CRT because that is going to reduce the MR, one thing. If suppose you think that it is not a secondary MR and MR has got some other etiology, in that situation, probably a combination of therapy both, like, CRT as well as mitral clip. So which you really want to do first is an important thing. If LV function is less than 25% with severe MR, obviously though these patients are inoperable, so probably they are not going to benefit with a mitral clip also. So probably first you have to put CRT, see what is happening to the MR. If the MR persists, in that situation, probably you will go for a mitral regurgitation repair with mitral clip. Thank you.
Any question from the audience? Thanks, Dr. Anup Gupta, for a great overview. Now we can move on to the next presentation by Dr. Daljit Kaur, Tips and Tricks of Conduction System Pacing, still at Development. Over to you, Dr. Daljit.
Again, good evening, one and all. So without wasting time, I think I'll start my talk. So all physicians search for the physiological pacing or narrow QRS has led to a lot of the improvement or lot of the boom about the conduction system pacing, that is pacing the his bundle or pacing the left bundle and achieving the narrower QRS so that you don't have pacing induced cardiomyopathy. So once you talk about physiological pacing, you are doing a his bundle pacing, or you're doing left bundle pacing, or you're doing left bundle branch area pacing. Because my talk is particularly on the stylet driven lead, I'll not talk about the leadless, without stylet lumenless lead, which is from Medtronic. So I just talk about what are the differences in the leads. So this side, it's a lumenless lead, which is a smaller size, and this side, it's a stylet driven lead. Across others, so Medtronic has lumenless lead, other three companies, Abbott, Boston, and Biotronic has a stylet driven lead, which is the distance from the tip of the active screw to the anode is 14.8 here and 14.6 here. This is very important. Why? I'll tell you. So once you talk about other company, that was Solia from Biotronic. These two leads, this one is a fixed helix lead from Boston Scientific, and this is a retractable screw from Boston Scientific. This is Ingevity family. So what is the problem with the Boston Scientific fixed helix is from the tip of the screw, which is active, to the your anode, the distance is around 17.2 millimeter. So your septum are usually not so much of thick, so your anode will not go and touch there. I'll tell why I'm talking about it. That's why I don't like using this lead. Whereas your Ingevity lead, if you see distance from the tip, which is an active, your helix, which is an active screw, to the onset of the anode or the end of the anode. Onset of the anode, it's up around something 12.5 millimeter, and end of the anode, it will go up to 14-15 millimeter. So I think we can still utilize this lead. And Abbott has a tendril lead, which is similar to the Solia lead. The dimensions are almost similar to the Solia lead. So 3 companies like starting from Biotronic has 3 sheets which are fixed sheet. There's no deflection. There is a secondary curve, and the one is 40. 40 is this angle. Other is 55. Third is 60. So this is my workhorse. Usually I use 40 or 55. Abbott has a deflectable sheath, which is biggest sheath, and tip has electrodes so that you can pace if there is a loss of capture. I'm not a big fan of this. I've not done many cases with this Abbott because I feel there is no secondary curve, and there's a difficulty because there is no 3D curve in the Agilis Pro. I think they're coming up with their next sheath with the 3D curve. Then comes to Boston Scientific. Boston Scientific has 4 curves. This, the first side they use for his. Second is called SSPC2, which has a little bit secondary curve. Third is extended loop, and this fourth is for the right side. For me, I've not done much cases, but I'm utilizing SSP, that is selective side pacing, 3 more useful as compared to the others. This is just a difference between all 4 companies. The only thing is I'd like to highlight here is Abbott sheath is the biggest size sheath that you'll need. Outer, if you're using like 11 French, you need a sheath. Other are almost between 7 to 9 French. So we started our work with his bundle pacing in 2017, and you can, why I'm showing this is, maximum cases, if you can see, is we ended up using CRT 3-lead device. Why that happens is, with the his, when you do a his pacing, you have a very small area to use. Secondly, it's not a big area for you to use. So chances of rising threshold is little bit high. Chances of lead dislodgement is little bit high. Secondly, because you are above the tricuspid annulus when you're doing his pacing, this is a small area we are doing the his bundle pacing. Chances of over-sensing is high. So I think that's the reason world over now slowly are moving towards left bundle pacing. Why? Because you have a bigger target area to pace, thicker and the bigger, and you are below the tricuspid annulus, so over-sensing issues are not there. Your R-wave sensing will be better, lead thresholds are better. You don't need backup lead, most important is, because his bundle you do many times, if you're doing for heart block, you should think that you may need a backup lead if there is some loss of capture or something, and learning curve is shorter because you don't need very meticulous, it's a small area. So you need a lot of EP understanding when you're doing his bundle pacing as compared to, because now non-EP, our cardiologist, intervention cardiologist has taken up left bundle pacing. So it is much more forgiving. So when we talk about steps, mainly for the stylet-driven lead, so this is what you do, like you put a sheath first across. I'll show some fluoro images. So operators may do different methods. The way I do is, first you are using this trousers, and then you are first taking out the helix, which you take like 12 to 14 tons. Once your helix is out, next what you do is, once your helix is out, you use this green tool, and you again give some 4 to 5 turns, so that you are tightening that helix, because later on you'll have to do manual whole lead clockwise movement. And when you do that, if your helix is not tightened, it may retract back. So it's important that you little bit tighten it and leave this green tool on this electrode. Next, it's always better to use this tool what they provide while inserting the lead, because it's a valve. And many times you enter and you come back. So when you're doing it repeatedly, this valve may get damaged and it starts bleeding. So it's better to use this tool so that you're not damaging the valve. And next thing is, when you're doing mapping, when you're doing the going and sitting on the septum, you should do the unipolar first, because your sensing is better. You're picking up even a smallest of the signal, and you can use your tip electrode to on the stylet, so that you can do mapping even when your stylet is in, or when you're moving clocking your lead. And your other electrode, that is red one, will be on the patient's skin, or on your self-retaining retractor. So this is how you map. For example, if you're a new operator, it's always better, because we are electrophysiologists, we are in a habit of leaving, like starting you can leave one catheter here, and if this is my recording of the His, this is little bit RO. If my recording of the His is here, you have to go 1.5 to 2 centimeter below and distal to that site anatomically. An electrophysiologist may say that I don't need this, so you can use this sheath and lead itself to map the His and just go distal to that so that you can go and localize that site. And once you feel that, I'll show you should be seeing a current of injury on the lead tip before screwing itself. If your contact with your septum is very good, even without screwing, you'll get some current of injury, and then you have to go to left LO view. And once you go to LO view, you will form this L because you're nicely perpendicular to the septum. And once you are perpendicular to the septum, your sheath will give you a very good support to clockwise rotate whole body of the lead so that it can bore inside the septum. So this is what I was talking about. Usually we see the current of injury after we screw, right? Here, starting itself, you should have some current of injury which will tell you that you are in a very good contact with the septum, like you are not dancing, you should not away from the septum. So if it's having good contact, and always have a habit, this PSA, you should tell your rep to have the PSA in front of your eyes. It should not be somewhere else and he'll keep telling you something. Don't believe that guy. Always have your PSA in front of your eyes and keep watching what is happening. So once you have a good current of injury, you have to rotate whole. Now remember, your helix is already out. So you have to rotate clockwise whole body of the lead and keep watching on the LO view. I'll show the image. And you can give like 10 to 12 talks and keep watching how your lead is moving. Little pushing and keep quickly giving clockwise talk. And when you do this, keep watching your 12-lead ECG. We as electrophysiologists, I watch the local EGMs also because I see unipolar current of injury on my EP tracer. But yes, if you don't have that, the first thing you'll see is a patient is having LBBB with baseline QRS of 154. This is the initial site. So you choose a site. As soon as you go little distal and distal to the His, you'll get 2 and 3 which are discordant, 2 positive, 3 negative. AV or AVL discordant to each other, and V1 will be negative having some notch. So once you start fixating, you may get the fixation beats or template beats. Now what do you mean by fixation beats and template beats? If I irritate myocardium, it will give rise to PVCs, right? And if I'm giving very quick turns, it will start giving rise to PVCs. And sometimes this PVCs tells you that you have, because it's already small terminal R is coming, that is residual RBBB is coming, and it will tell me that I should stop here and should not screw more. So once you stop pacing, stop screwing, again check unipolar neck. Now you can see it's a terminal R in lead V1. You'll get some terminal R in AVR. It's not seen precisely here, but it is here. And then you can measure your left ventricular activation time, that which you measure on the V5 or V6, that is from your stim to the peak of the R wave. The left ventricular activation time which is accepted is usually less than 75 millisecond. So if you have left ventricular activation time little longer, you can now, if you feel like you have to screw. Secondly, first once you start screwing, your impedance will start rising. And why it rises? Because you're going deep within the septum. So there is more resistance. After some turns, you may start dropping your impedance. Once your impedance start dropping, you have to be very cautious because you have to go beat by beat, otherwise you'll cause perforation. So this is the non-selective, and once you got the selective left bundle capture, you can see your left ventricular activation time in V5 is 74 millisecond. There is a nice rounded terminal R in lead V1, and there is a terminal R in lead AVR. And if this doesn't belong to this patient, if you have underlying left bundle branch block, you'll not get left bundle potential because it's a block, right? If you want to demonstrate left bundle potential, and if you have a His catheter, and if you pace from His and capture left bundle, you may appreciate this. This is from another case. If there is a narrow QRS, you may get this left bundle potential, and you can see why it is left bundle potential. It is before the QRS, and normal left bundle potential is 15 to 25 millisecond. So this is what I was trying to tell that. So once you have screwed, I don't use now sheath angiogram, but you can do that. So you can see that your anode is in a very good contact with the septum. If you are able to achieve this, this is always good, because if you have anodal capture also, you can get bilateral bundle branch capture, which will have a narrower QRS as compared to only left bundle capture. I think it's hung up. So, I'm sorry. So this is, you can see that. So you were doing unipolar pacing, right? This is the ECG of the patient. There is residual RBBB with the terminal R in V1, with the terminal S in V5, V6. Same case when you have a bipolar pacing, there is no residual terminal RBBB. So why this is what I was trying to tell, that if you have a good anodal threshold, once you do bipolar pacing, you have bilateral bundle branch capture. But when you made DDD in this patient, despite of only unipolar pacing, you have a very good AV nodal conduction, so there is no residual RBBB in this patient. So because of the good AV nodal conduction with DDD, there is a loss of RBBB, and you have a bilateral bundle branch capture, and this is the QRS of this patient. I think I'll stop here. Thank you very much.
Any question? So it was a very nice presentation about the conduction system pacing, but it's more about a electrophysiologist, and it's really challenging for interventional cardiologists especially. Any comment from Dr. Nayak? And it's about.
I think there's no question. We'll stop. Thank you, sir. Thank you.
With the sheath that you would want to do?
Counter. So once you enter into the RA, you have to clock to cross annulus.
Do you want to repeat my question so that everyone understands?
So her question is, for example, I've kept the sheath there and there is no current of injury. That means I'm not in good contact with the septum. What maneuver should I do? So I'm starting from basic. How do you enter there? So first, to enter into the annulus or into the anterior, first you have to clock the sheath. You cross the tricuspid annulus because this is a little anterior structure. Then you have to push and counter the whole assembly. So once you counter, your septum is a little posterior structure and you have to push it. So if I'm not having current of injury, I'll little bit counter more and I'll push the whole assembly more. Thank you very much.
Thank you. Dr. Aparna is there?
Yes, am I audible?
Yeah, you are very, very well audible. Hello, Dr. Aparna, how are you? Dr. Sanjeev
Very
Sharma.
well. Not being there, and I cannot even express how much I wish to be there. Are my slides visible?
Yeah, it's very well, very nicely visible.
And Jitendra has been stern enough that the first go we have to stop. So at the outset, I'd like to thank Jitendra for the opportunity. And I think this talk is very well positioned after Dr. Anoop's and Daljit's talk as to, does it really matter which device we choose? So in the next couple of minutes, I'll make you walk through. I think all of us are quite keen to learn about devices and the ECGs that we saw, but one thing which is often neglected is this segment, is talking about the longevity of devices. And I think there can be no more apt after from where Dr. Anoop left. And I'll start with this case. This is an 82-year-old gentleman. He underwent a bypass several decades ago. He's a sudden cardiac arrest survivor. Obviously, he underwent an ICD. He underwent an ICD 10 years ago. He's led a good life, and he's in NYHA functional class 2, and he's had documented VTs with successful therapies. We are well aware that if an individual who has CAD, LV dysfunction, is having VTs on ICD, it's a good idea to modify his car. He undergoes that. And at the outset, all of us have concluded this is an ideal patient who should have had an ICD. Now, going back from where Dr. Anoop left with all of these trials, the only thing I want to bring to your attention is that when Marriott was done, year of publication 1996, then Scud Heft, at 5 years, our patients survived, 72% of them survived at 5 years. And if we were to look at Marriott CRT, which was a landmark trial, because Marriott CRT told us the benefit of CRT truly is in individuals who have left bundle branch block with a QRS duration of more than 150, and when offered to that subset, 90% of them survived at 5 years. So if I look at my patient whose CABG was done in 1994, he's actually walked through this entire heart failure paradigm, and he's gone through all of these therapeutic strategies that we've had to offer such that he's doing well. He has also been a beneficiary of ARNI as well as SGLT2 inhibitors, which brings us to our own patient who has been doing very well in October 22, and he came just about a few months ago, but I don't have that card, but he has done very well with a single device which was implanted in 2014. That means his battery, if you can see here, still shows a battery of about 6 years, and it was implanted in 2014, highlighting the importance of longevity in this individual patient. Let me now draw your attention to a second individual who's a young male who has had recurrent syncope. He has hypertrophic cardiomyopathy, and hypertrophic cardiomyopathy has shown significant late gadolinium enhancement. He's lost one sibling, so he clearly needs a defibrillator. He also has bradycardia, implying he needs a dual chamber ICD. Now, in this individual, you want to give it 17 years of age, you really want to give him a device which has the longest battery longevity. So you choose and you need to think which is the device wherein my patient will have the longest time to explant and change the device for the battery. There are certain disease processes where we know that ICDs almost eliminate the premature arrhythmic death, and the cause of the death in these patients is actually heart failure, meaning thereby giving these patients the devices with the longest battery really makes a change to their lifetime. Similarly, if we were to look at patients who suffered from Brugada or ARVD, these are young individuals and they're the most important advocates for the maximizing the longevity of ICDs. These are young patients with extremely good survival. As a result, if we intervene and give them devices with the longest battery, they would survive very well. Which brings us to the point that there truly is a need for longer lasting devices. Thus, what are the factors which affect device longevity? There are several factors. We have also understood that the time to device replacement is the earliest for devices which are most complicated. For instance, CRT-Ds have the lowest battery if we were to compare them with the dual chamber ICD or with a single chamber ICD. But the factors which affect device longevity are many, and in fact are changing with changing times, because we as clinicians have been wanting more and more algorithms to be fit into the devices at the cost of battery longevity. But some things which have been common is the collection and storage of data, the background current, and of course, we are all aware about the pacing thresholds. When we implant a device, especially in patients who need a CRT, wherein we want more than 99% of bi-V pacing, you want to only accept thresholds which are lesser than 2, preferably less than 1.5. Which brings us to the point that how have these devices evolved over the years? So irrespective of the make of these devices, if you look at the red bar and the green bar, the red bar is the recent generation devices and the green bar is the earlier generation devices. So irrespective of the make, what we can see is there have been significant changes in the devices, as a result of which the newer generation devices have better longevity compared to the previous generation devices in all of the makes. However, if you were to compare within them, it is apparent that one of them scores above the others. And is there a particular reason that this one would score, Boston Scientific would score over the others? So this is the answer that we need to understand as to why does this happen. This has been studied in several papers and several product performance reports to understand, is it replicating itself, that a certain device industry make actually is superior to the others, and if so, why is it so? So let me take you down the history line, and we understand when these devices came in, the first devices lasted just for a few hours, and after great advancements, they came to 2 years. These devices were unpredictable, short service life, but yes, they've undergone a lot of technological advancements, which brings us to the most important point as to what is the battery technology in these devices. So we are aware that in pacemakers, it is lithium iodine. It has remained to be largely lithium iodine. However, there has been a shift even in the pacemaker devices. But if you look at more complex devices such as ICDs and CRTDs, the shift has been to lithium silver vanadium oxide and lithium manganese dioxide battery technology. So why has this happened and how has this changed? So whenever we talk of the battery longevity, the capacity depends upon ampere hours. Higher the ampere hours, it is a stronger predictor of survival to the elective replacement indicator, or the relative replacement time as we call in the modern devices. So as you can see, if the ampere hour was higher, there was a longer time that the patient took to the relative replacement time in all of these devices. It was also noted that manganese dioxide batteries are able to maintain a high battery voltage and stable internal resistance during most of their discharge. So on this, we understand how these device technologies have changed over the years, and majority have shifted to the newer technologies. There has been a shift of Boston Scientific to lithium manganese dioxide. Biotronic always was lithium manganese dioxide. However, as you can see, the ampere hours of Biotronic and of Boston is different, although the technology is the same. Medtronic has been using lithium silver vanadium oxide carbon monofluoride, and Abbott has been using the lithium silver vanadium oxide. So that's how it has been doing. But what we have seen is when we see the highest ampere hour, it is the ampere hour which will decide how long the battery will survive. We have been noting that in low energy devices, it has been lithium iodide. However, with ICDs and CRTDs, it has changed to lithium silver vanadium oxide carbon monofluoride. And of course, lithium manganese dioxide has the highest ampere hour. Now, there is this technology which is called the stacking. They stack the anode and the cathode one over the other, and it has been noted that it is because of this stacking technology that you are able to actually have a very compact device and higher ampere hours. As I was mentioning, when the devices came into being to what we are seeing now, we have had significant advancements. We have been wanting better electrograms, we want CRT, rate responsive. We've always been wanting as clinicians the size of the device be small. It should be able to give us ATP. RF telemetry is something which I think all of us, most of us in my age group have seen it evolve. We have been witness to remote monitoring, which I'll just tell you how the battery is consumed during remote monitoring. We have been wanting lesser and lesser size of devices, quadripolar pacing. We want to give improved outcomes with CRT. Hence, the algorithms have been more and more complex with multi-site pacing. So that's what has resulted in trying technological advancements in these devices at the cost of, although battery depletion, but since the battery technology also improvised, we now have devices which last longer. So whenever you give remote monitoring to the patient, we should remember that whenever the remote monitor interrogates or communicates with the device, it results in very minimal battery consumption. However, when the device communicates with the communicator, it results in a battery drain. Both these situations will happen depending upon the clinical need of a device. But yes, we are always fearful that should I give a remote monitor to my patient, there are several randomized controlled trials which have said that the benefit of remote monitoring is largely reserved for those patients who have heart failure and are given ICDs or CRTDs, because you can avoid their hospital admissions, you can help them treat from having inappropriate therapies. So yes, it should be happening. But remember, when the device communicates with the communicator, it would consume certain amount of battery. We already mentioned about the LV lead. When we implant CRTs, the challenge is of the LV lead. If you have high LV lead outputs and when you have unipolar LV lead, it results in a higher battery drain. Remember, whenever you have a unipolar lead or when you have very low impedances, it will cause an increased consumption of the battery. Today, we barely use unipolar LV lead. So that is largely taken care of. And when we implant the CRT, we try to implant the CRT with quadrupolar leads, which allows us to get the right kind of thresholds without phrenic nerve stimulation, so as to abate this problem and avoid the battery depletion. So longer battery means fewer replacements. What does it imply? We are also aware that when it is not a replacement, is not a simple thing to happen, especially when you're dealing with complex devices in comorbid patients, elderly patients, those who have CKD. They are liable to have, and they're at a much higher risk for infections, hematoma formations. A hematoma in itself puts the patient at risk of infections. And whenever the replacements are done, it can result in lead malfunction. It can also result in lead damage, lead dislodgements. And we don't want to do these interventions unless there really is a need. So longer battery truly means fewer replacements and better outcomes. So there are certain committees which have actually said that should you use a specific technology. So in UK, it has been recommended that they should use lithium manganese dioxide powered devices because of its higher ampere hour, and also because there is enough evidence that there is clinical and patient benefit whenever there are fewer replacement procedures. So much so that the guidelines were revised in 2021, and they still recommend that one should use lithium manganese dioxide batteries so that the patients have fewer replacements and the outcomes are better. Also, there are certain economic implications of a CID implant. Whenever a patient is given a CID, the biggest issue comes when the patient receives the implant at the very outset. Subsequently, during his lifetime, there are certain issues, repeat hospitalization, worsening heart failure, but the maximum economic implication again comes when the patient undergoes another replacement, because we understand that these devices, the replacements are not for free, and the patient has to buy the device each time it is replaced. Thus, we should all realize that patients who are in transplant list, well, it is that subset where it really doesn't make such a big difference. But outside of that, I think it makes a difference for every patient, and the most for those patients who are young, patients with channelopathies. As I showed you, the child that we had, 17-year-old, who had an entire lifetime to live. You don't want him to have too many replacements. So I think we've all been wanting to have devices with longest battery longevity. Also, it should be understood that it is not that other battery technologies are inferior. We have had cases that patients with lithium silver vanadium oxide carbon monofluoride also do very well. They last long if the patient receives good outputs and the thresholds are good. Also, we understand that when we give lithium manganese dioxide, it comes at a price that the patient cannot have remote monitoring. So in every patient, we have to decide what is it that we want to offer to our patient. So a lot of debate took place about this with the key opinion leaders of IHRS. And it was concluded with all the discussion that what is best? It is important to give a longer battery life, or is it important to give other algorithms? So I think it was very clear that the bottom line, as Dr. Yash mentioned, longevity trumps everything. It changes out health costs, potential infections, and inconveniences. So whenever you choose a device, I think it's extremely important we understand that battery longevity is extremely important in deciding which device we wish to offer to our patients. Thank you very much.
Yeah, Dr. Aparna, it was a very exhaustive review about the longevity of the devices. You covered almost all aspects. I think most of the devices available these days have got a main emphasis on the battery life. And one important thing you pointed out is about the remote monitoring of the devices, which usually company offers to all the patients with the new generation pacemakers, should be avoided. Like it also drains the battery, but it's a very small amount of battery is being drained by that. So should we advise for everyone or just a selective indication as you pointed out?
I think that in pacemakers, it can be avoided. We really don't have hard evidence in randomized trials that for pacemakers you need to do remote monitoring, and it is going to be a value addition because it really comes at a cost for a country like ours. However, when we have patients who are located far off, can afford the devices which offer remote monitoring, and today we are also well aware that we have Bluetooth technology available. But yes, again, it comes at a price. The patient has to pay significantly more trying to pick up Bluetooth technology. But I would think that if my patient is living far away, has difficulty in visiting, has heart failure, it's a value addition. It should be considered for patients who have CRTDs. The maximum value I would think I would give 2 CRTDs followed by ICDs.
Any question from the audience?
One question, ma'am. Does hyperthyroidism or hypothyroidism cases affect the battery longevity in patient after the implantation? Do you have any experience in your life?
So, this is a very important question. I am truly not aware if particularly hyper or hypothyroidism would affect, but what do we need to understand is whenever the patient has hyperthyroidism, it results in sinus tachycardia. And this is what we follow for our young children. What do we do for them? We don't want their heart rates running very high. So in fact, when they come to us for pacemaker interrogation, we change their settings as they grow up. We know they have a VVI pacemaker, and when they are very small, they go back home at a VVI 90. As they are growing up, we change the requirements to VVI 70. In fact, we also add a nitrate. Similarly, if a patient has a CRT and is having sinus tachycardia, the patient is going to be paced 99% of the time. And if the patient continues to have tachycardia, one, it will decompensate the heart failure, and second, higher pacing burden will also take the battery life. Typically, whether this disease process will drain the battery, I don't think so.
Thank you.
Yeah, Dr. Panna, thank you very much. And this time we missed you personally. Otherwise, you are a regular visitor for JHRS. Next time, we would like to have you in person. Thank you very much.
I will certainly be there. Thank you, Sanjeev. Thank you so much.
So with this, I think this session is over.
Yes, thank you very much, Dr. Aparna Jaiswal. We would like to express our gratitude on the behalf of Jaipur Heart Rhythm Summit. You have joined us online. Thank you very much, ma'am. So, ladies and gentlemen, we have just wrapped up an insightful session on device therapy in heart failure, shedding light on the crucial aspect of device-based treatment. Now gear up for our upcoming session, case-based discussion. Engage in interactive discussion as our esteemed speakers present real-world cases and share their insights. So stay curious and ready to learn. Now I would like to invite, as a chairperson of this session, Dr. Vikram Goyal sir. Dr. Vikram Goyal sir, renowned CTVS surgeon, Dr. Sita Raman sir, Dr. Siddharth Sethi sir, Dr. Dipendra Bhatnagar sir, Dr. D.K. Garg sir, Dr. Rahul Ajmera, Dr. Sanjeev Sidana. May I request all the chairperson to come forward for chairing the session. Thank you. And I will request Dr. Ajay Naik sir for the next presentation.
Good evening, everyone. Thank you, Dr. Jitendra, Dr. Kush, for inviting me here. We are going on to, from the technically advanced presentations that we heard in the last hour or so, back to bedside. So this is a hypothetical case of heart failure. This is a 64-year-old gentleman who's presented hospitalized for acutely decompensated heart failure, cough, expectoration, pedal edema, weakness since 3 days, known case of hypertension, coronary artery disease, COPD, Parkinson's. On presentation, BP was 160/90, saturation 76, ECG showed sinus tachycardia LVH, and echo showed EF of 28%. Now, routine therapy, oxygen, IV diuretics. After stabilization, patient was started on ARNI. This is during hospitalization. And his blood pressure was okay, so they decided to start 50 milligram twice daily. Post-treatment during hospitalization, saturation improved, patient improved over the next 4 days, and patient was discharged at ARNI dose of 50 milligram BID. He was followed up, and this is very important for heart failure patient. They have to be given a date for follow-up, that they have to follow up after 2 weeks in the outpatient. If you leave it to the patient and family, they are never going to turn up, and that worsens the patient's outcomes considerably. So heart failure therapy has to be comprehensive treatment. So after 4 weeks, ARNI was up titrated to 100 milligram BID, and in fact the echo showed improvement to 38%. And this is what we have seen in our clinical practice over the past few years. The patient presents in heart failure, fast rates, often in atrial fibrillation, fast ventricular rates. EF is around 20-25, but once everything is stabilized, patient is say back in sinus rhythm, the LV function is actually looks better on echo. And over the next 1 year, the patient has been doing fairly well. So it's important to manage these patients very well. 80% of heart failure patients remain undiagnosed until the time of the first hospital admission. And in fact, that is so true in our Indian patients. We all know heart failure is an inexorable progressive disease, and 5-year survival is 50%, and a large number of them have sudden deaths. Early diagnosis and predicting risk in heart failure allows physicians and patients to make decisions on appropriateness and timings of treatments. So there are certain risk prediction tools that how is this patient going to do, which will estimate prognosis for these patients. There are various prediction scores. You may have heard of 1 or 2 of them. I have heard of Predict HF, Magic, but there are a whole lot of other tools are present. We don't often use them. There are certain apps which are available which may help you decide which one fits to your patient the best. But what we developed along with one of the companies, the company producing ARNI, is create a one-page sheet which has a checklist. And when a patient of heart failure is admitted to the hospital, at the time of discharge, the checklist should be gone through, and we make sure that the patient is on all optimal guideline-directed medical therapy. The patient has been advised regarding diet, fluid restriction, salt restriction, etc. And the patient should get proper counseling regarding rehab, exercise, and proper follow-up. So this is most important, and using a checklist like this has really improved the heart failure outcomes in our patients. So tools for screening and risk prediction for heart failure and outpatient checklists. We don't use it not only for inpatients, but also for outpatient. So the tools for screening are Framingham Heart Failure Diagnostic Criteria. These are clinical criteria, fairly simple to use. And the MAGIC score, which I just talked about, it has a whole lot of other objective parameters also. So what is the right clinical approach for a de novo heart failure patient? Introduction of guideline-directed medical therapy. You're going to hear this GDMT a lot now because this is what is emphasized upon. So introduction of guideline-directed medical therapy during hospitalization is key target to reduce the risk of mortality and rehospitalization. Continuation of GDMT throughout hospitalization or initiation before discharge, making sure that the patient is on requisite drugs, and aggressive titration or starting at a high dose can result in hypotension, it can cause renal dysfunction. So you have to individualize therapy, maybe start off with smaller doses and then up titrate as the patient's condition permits. So lack of GDMT is associated with high risk of hospitalization and emergency room visits. So this is all-cause hospitalization. There is 29% greater risk of all-cause hospitalization if the patient is not on guideline-directed medical therapy, more cardiovascular-related hospitalization, and 28% greater risk of emergency room visits. Like I said, the care delivery pathway to optimize GDMT should include everybody. Physicians, assistant to the physicians, pharmacists, ambulatory care has to be proper. The patient should be aware of what urgent care would be needed, where they should need to go, emergency room, etc., and hospitalization if required, how it is to be done. So that reduces the morbidity and mortality of these patients. Key goals of GDMT are up titration to target doses, the trial advised doses, introduction of newer therapies as they come in. We are all aware of not only ARNI, but SGLT2 inhibitors, and now we heard about vericiguat also, and evidence-based approaches to comorbidities. What do the guidelines recommend? For optimizing heart failure therapy during hospitalization, immediate improved hemodynamics, organ perfusion, restore oxygenation, reduce the symptoms, reduce cardiac and renal damage. Cardio-renal access is so important in heart failure. We need to preserve the renal function. Once the kidneys start going down, everything goes haywire. Prevention of thromboembolism, very important. So when the patient is hospitalized, necessary to give them LMWH during hospitalization. Minimize the ICU length of stay and mobilize as quickly as possible. Identify the etiology, related comorbidities, titrate therapy to control symptoms, keep the patient decongested, and initiate and up-titrate optimal pharmacological therapy. Consider device therapy in appropriate patients. That has to be done at every juncture. Will the patient improve by a CRT? Whether the patient requires a mitra clip, whether the patient requires a heart transplant or LVAD, that has to be revisited every time the patient comes to you. Pre-discharge, like I said, checklist and make sure that the patient is on GDMT, and long-term enroll in a disease management program where the patient is regularly following up in your heart failure clinic. And if the patient is not physically able to come, there's a phone call which goes from your office to the patient. We do this in our heart failure clinic, and it's really helped us a lot and helped our patients a lot. Prevention of early readmission, improving symptoms, quality of life, all improve survival. The ACC recommends that GDMT is the foundation of heart failure care. GDMT with the highest expected benefit should be prioritized. Now, in hospital initiation of heart failure therapies, with ACE inhibitors or ARBs, we did not have too many trials. With mineralocorticoid receptors, the drug was started 30 to 90 days post-discharge. Beta blockers, limited trial again for patients with de novo heart failure. So sacubitril valsartan, ARNI, is the only therapy having evidence for in-hospital initiation of heart failure therapies. So that way it is unique, and it is the current era which has made it possible. So ACC 22 and ESC 2021 guidelines recommend initiation of GDMT pre-discharge, and ARNI is recommended as first line of therapy in hospitalized HFrEF patients. It is of high economic value, it prevents rehospitalization, it reduces the cost of the patients, cost to the society also. Finally, a few slides which tell you the evidence backing the use of ARNI. Early initiation of ARNI helps hospitalized HFrEF patients live longer. So this is the 20% reduction in death with patients who were on ACE inhibitors, ARBs, and this is ARNI compared to that. But if the patient were not on ACE inhibitor, ARB, compared to other therapy, ARNI reduced mortality by 46%. Keeping the patients out of hospital. If the patient, compared to ACE, ARB, 40% reduction by ARNI. Prevention of early reinitiation with ARNI keeps hospitalized HFrEF patients better protected. So reduction in composite clinical events compared to ARNI, compared to ACE inhibitors, ARB, ARNI at 44% reduction. And this is again objective evidence. You've all seen these charts. ARNI shows reduction in NT-proBNP in HFrEF patients. These are patients on ARNI, on ACE inhibitor ARB, and this is patients on ARNI. So NT-proBNP, while in hospitalized patients when ARNI was started, there's 28% reduction in NT-proBNP. In terms of clinical outcome, how the patients feel, the patients who were initially mainly in class 3, 4, a larger number of patients went to NYHA class 1 and 2. So 26% in-hospital patients achieved NYHA class 1 status with ARNI by 26 weeks. And reduction in edema or dyspnea over the 26 weeks with ARNI, edema and dyspnea on effort both improved for the patient. What about reaching target dose? We start off with 50 milligram twice a day. Sometimes we have to start with a smaller dose. We try to take it to 100 milligram twice a day. Getting to 200 milligram is difficult, but 100 milligram at least patients are able to tolerate. In the trial, 53% of the patients achieved the target dose of ARNI by 26 weeks. If you are able to achieve even up till 100 milligram dose, I think it's a great benefit to the patient. Also, your ARNI did not restrict the use of other drugs, so beta blockers and MRAs could be given at optimal doses while ARNI was being given. If there was hyperkalemia, then you have to scale back or you have to decide what drug to give credence to. So in de novo, acutely decompensated heart failure patients, ARNI can be started with confidence. Yeah, that's it. I'll stop here. Right on time.
Any question from audience?
Well, just one thing. Is there any absolute contraindication to start ARNI?
Yeah, it's like in your clinical practice, it's going to be mainly two things. One is hypertension and the other is azotemia. These are the two things which are going to prevent you from starting ARNI in hospital. So once the patient stabilizes, probably you would be able to start it at a smaller dose. And then you have to be really individualize the therapy. You may not start at 50 milligram twice a day. You might have to start 50 milligram once a day, or maybe 25 milligram twice a day, and then gradually up titrate if possible. So hypertension and azotemia, these are the two main things we are worried about always.
History of angioedema is also a contraindication.
Say that again, sorry.
History of angioedema.
Yeah, so how it used to happen earlier was patients, I'm talking about 3, 4, 5 years in the recent past, patients used to be on one of the prills, and we needed to start ARNI. So I used to shift the patient to valsartan for a week and then shift to ARNI, rather than waiting for ACE inhibitors to be stopped, giving a gap of 3-4 days and then starting ARNI. It didn't work out well for the patient. It is easier for the patient to remember that you have to stop this drug, take valsartan for a week, and then immediately start ARNI. It used to work better.
Is there any need of regular monitoring of potassium also?
You'll have to again individualize therapy. Basically, you would probably want to do it after 2 or 4 weeks for the first time. And then if required, anyway, these patients, if they have azotemia or a gross heart failure, you are going to monitor them at least once in 3 months.
Till what level of creatinine you accept?
Whether I would give ARNI? I would probably give up till a creatinine of 2 or 2.5. I would not go beyond that.
Potassium level are more important. If potassium is more than 5.5, then we should not give. But if potassium is less than 5, then definitely.
Now in the West, we have drugs like paratomar and all which prevent hyperkalemia. We still don't have them in India. If they come in, that will also help manage these patients. Also, what has helped in management of heart failure patients after ARNI came in is the availability of SGLT2 inhibitors. A lot of patients where we could not initiate ARNI, we are at least able to give SGLT2 inhibitors and then think of ARNI later.
If we start both the drugs together, there are less chances of hyperkalemia.
Yes.
So we'll invite next speaker.
Thank you.
Thank you, Dr. Ajit. Our next speaker is Dr. Sanjeev Sharma. He is Director of Interventional Cardiologist at Eternal Hospital. He will speak on early initiation of ARNI in heart failure with mildly reduced ejection fraction.
May I request Dr. Sanjeev Roy, sir, to chair the session. Thank you very much.
Yeah, good evening everyone and welcome to JHRS 2023. As we are running a little late, so I would like to sum up a little fast. We've been using this ARNI for heart failure with reduced ejection fraction, like EF equal to less than 40% for almost 5 years now. Now it's time to move on to the heart failure with mid-range ejection fraction and also for the preserved ejection fraction. So my case is a 72 years old female who has been symptomatic with the class 3 dyspnea, progressive dyspnea and fatigue over last 2 to 4 weeks. And she's a known case of hypertension for last 30 years, diabetic for last 20 years, and CKD for last 2 years. BMI is 32, slightly obese. Hemodynamics are stable. There are basal crafts and a little bit of edema. And NT-proBNP level is 850. This is marginally raised. And EGFR is 48. Echo showed ejection fraction of 45 to 50%. And there's evidence of LV hypertrophy with diastolic dysfunction. And LA volume index is 35. So it's clearly is a mid-range ejection fraction, and she presented with the heart failure. So what best we can offer? How to categorize this patient? EF is around 45 to 50%, so it categorizes in the mid-range ejection fraction. And how best we can treat in 2023? We have a clinical evidence. There's a clear correlation between heart failure with mid-range ejection fraction, ischemic heart disease, and renal dysfunction. Heart failure with mid-range ejection fraction have multiple comorbid conditions as compared to the HFrEF. There's high prevalence of underlying ischemic heart disease, and close to 26% patients have a concomitant renal insufficiency also. These are typical phenotype. You can compare with the different HFrEF, mid-range ejection fraction, and the preserved ejection fraction. As compared to the preserved ejection fraction, we can see there is a prevalence of chronic kidney disease, hypertension, and AF. As compared to HFrEF, it's quite more common, but less than the heart failure with the preserved ejection fraction. And the women is more common with the preserved ejection fraction, and mid-range is close to the HFrEF. Heart failure with mid-range ejection fraction, it's a categorization of the patient with a heart failure and shared the most important clinical features with HFrEF. It's more closer to the HFrEF if we compare it with the HFrEF. Hence, it was suggested that drugs that are effective in the patient with HFrEF might also be effective in the patient with mid-range ejection fraction because underlying etiology is same like ischemic heart disease. So she was started on treatment. She was started on SGLT2 inhibitor, ARNI, or aldosterone antagonist, and also low-dose diuretic to reduce the edema. This is all about the ACC 2022 guidelines, which clearly recommends about the mid-range ejection fraction. EF is 41 to 49%. Diuretic to reduce the patient's symptoms. And SGLT2 inhibitor is a class 2A indication. ASERB is a class 2B. MRA is class 2B. And evidence-based beta blocker is also 2B. So there is only 2A is SGLT2. Now we have got other agents like ARNI. It's going to be 2A in times to come. So sacubitril valsartan combination, even it's being recommended by the ESC 2021 guidelines in a mid-range ejection fraction to reduce the risk of rehospitalization as well as death. The ACE or ARNI and beta blocker MRI may be as considered in the patient with mid-range ejection fraction. So therapy is same. It's a continuum from reduced ejection fraction to mid-range and to the preserved ejection fraction. So what are the evidence we do have about use of ARNI in mid-range ejection fraction? And this is how we compare the valsartan with this ARNI when we look into the improvement in the ejection fraction. Like in the baseline, if you compare, there's a clearly significant improvement in EF over a period of time of 12 months, like 5.48% improvement in ejection fraction with ARNI as compared to the valsartan alone. In same, you get a reduction in the other parameters, echo parameters, like there's a reduction in LV end-diastolic dimensions and also end-diastolic volume if we give this ARNI as compared to the valsartan. Significant reduction in the LV end-diastolic volume. And this also reduces the rehospitalization as compared to the valsartan alone. You can clearly see the 7.14% as compared to the 18.6% with valsartan alone. So it reduces the rehospitalization as compared to the valsartan. And there is an improvement in EGFR with this combination as compared to the valsartan alone. So it works in all the parameters. It improves the ejection fraction, reduces the endoscopic diameter, improves your EGFR. So guidelines, as we discussed, that it's going to be a class 2 in the future. And other evidence, what we can see is there's a reduction in the NT-proBNP level, which we expect whenever we prescribe the ARNI. And there is a clear-cut improvement in the NT-proBNP level during the course of treatment. And this is on the basis of one of the meta-analysis. There's an improvement in the 6-minute walk test distance and also improvement in the quality of life status. Patient, though class 3, class 4, they are reduced to class 2 as shown by the Dr. Naik also. This improves the quality of life, improves the symptoms. And there is a 46% reduction in the rehospitalization with the heart failure, 31% reduction in the 1-year mortality, and 38% reduction in the cardiac death. So significant reduction in the rehospitalization and also all-cause mortality and the cardiovascular death. So this is time to adopt the GDMT as stressed by Dr. Naik also. As the guideline-directed medical therapy is the bottom line, irrespective of ejection fraction, whether it's a HFrEF or the mid-range ejection fraction or the preserved ejection fraction. These drugs act on throughout the spectrum of the heart failure. So this is from one of the pooled analysis of the Paragon heart failure and the Paradigm heart failure, that this drug really is effective across the spectrum of the ejection fraction. Like this is endorsed, the heart failure with mid-range ejection fraction or the mildly reduced ejection fraction would be expected to benefit from the sacubitril valsartan compared with the RAS inhibition. And this is again from the same meta-analysis that it is effective across the spectrum of ejection fraction. There's a 46% reduction in the risk of the total heart failure hospitalization or the cardiovascular death with ARNI across the range of LV ejection fraction. And there is a reduction in the cardiovascular death in the tune of 24%, irrespective of ejection fraction. And there is 17% reduction in the overall all-cause mortality all across the spectrum of ejection fraction. So real-world evidence with the sacubitril valsartan we do have in the heart failure with mid-range ejection fraction. And this is also one of the meta-analysis which is also giving the same insight. There is a clear-cut reduction, statistically significant 23% reduction in the all-cause mortality compared with the ACE or ARB. And with the same tune, 23% reduction in the cardiovascular death also, although it didn't reach the statistical significance. So this ARNI is effective across the spectrum of ejection fraction, reduced ejection fraction, mid-range, and also in the preserved ejection fraction. So post-treatment observation, patient got better clinically, symptomatic status got improved. She is now class 2. NT-proBNP level came down from 800 to 380 now, and she is hemodynamic stable and saturation is normal. So to conclude, early initiation of guideline-directed medical therapy in heart failure with mid-range ejection fraction improves the quality of life, improves the symptom, improves the NIH class, reduces the other biochemical evidence like a reduction in the NT-proBNP level and cause a reverse remodeling, improvement in the cardiac structure and the function, reducing the LV end-diastolic dimension, improvement in ejection fraction. It also reduces cardiovascular mortality, all-cause mortality, and moreover, it reduces the rehospitalization rate, which is the very important endpoint in the treatment of heart failure. And this is a unique salt complex, sacubitril valsartan, and this is an important ARNI, original, which has got a 5+ years of experience. So better to use the innovator brand to get the maximum benefit out of it. Thank you very much.
Any questions from the audience? If there are no questions, then we can, I think, go to the next session.
Such a comprehensive talk, Dr. Sanjeev. There is no question from the audience as well as from the panelists.
Yeah, thank you.
So now, throughout the day, we have been witnessing such a fantastic discussion on the various cardiology topics. And now this is the time to shift gear from the cardiology to the cardiac surgery. And I invite Dr. Rakesh Sitaraman, who is a fantastic surgeon, to talk about the surgical management of the heart failure. And I must tell this is such a Herculean task to summarize your topic in 15-minute time.
Thank you, sir. Thank you for those words. At the outset, good evening to all the delegates and the chairpersons. And I would like to thank Dr. Makka sir and Dr. Kush for giving me this opportunity. I know it's a tough ask, but I'll try to do justice. I will touch on the salient features and what, as a surgeon, we could offer in this condition. So this is the Indian data where heart failure is the commonest cause of hospitalization with 1% of the general population, which adds up to 8 to 10 million patients a year, of which in the age group 65 to 79, if you look, it accounts to 5 to 10% of the heart patients, and above 80, it accounts to 20%. However, in the Indian scenario, we have more younger, sicker patients who end up with higher morbidity and mortality. And also the heart failure treatments, the dosages, and the devices, they all have their own demerits. So this is to just summarize the 4 stages of heart failure, where in stage A, where the primary prevention, stage B is for secondary, and stage C is where the actual medical treatment starts, and stage D is where the advanced heart failure, where the medical therapy fails and the surgeon has the role. So these are the common causes. Most common is being ischemic cardiomyopathy, dilated cardiomyopathy, and valvular heart disease, and the congenital heart disease. These are the main subsets which add up to adult heart failure. So looking at the medical management option, this is the first step when anyone presents with heart failure. You initiate the GDMT, which is ARNI, beta blocker, mineralocorticoid receptor antagonist, SGLT inhibitors, and diuretics. And you see the response. If they improve, then you follow them up. If they don't improve, then comes the next line of management, be it adding hydrolyzine and nitrates, or you add ICD, CRTD, and you continue monitoring these patients. If they end up in refractory heart failure, then comes the options available to us are either durable mechanical support, cardiac transplant, or if they are unfit for any of this, then we have to go into the palliative pathway. So the commonest heart failure condition we deal with is in our day-to-day practice is ischemic cardiomyopathy. And so the patient, so these are patients who often present with very poor LV function with significant coronary artery disease. The first thing as a surgeon, what we look in these patients is to make sure they have a suitable anatomy for revascularization. If they have, then the next question is there any viable myocardium? So we do viability assessment in these patients. So if there is enough viability, good suitable anatomy for revascularization, then we subject these patients for surgery, be it either isolated coronary artery bypass grafting, or you do an additional procedure, mitral valve repair or replacement, because most patients do have moderate to severe MR in addition to coronary disease. And also the recent incidence of LV aneurysm or ventricular septal rupture has significantly declined because of early PCI and early interventions. However, this also add up to reducing the heart failure symptoms. But if you don't have a suitable anatomy for revascularization or there is no viability, then these patients have to go into the arm of GDMT. If it fails, then go to transplant arm, where you have heart transplant, heart lung, or durable VAD options. So these were patients probably 5-10 years earlier who present with 20% EF or 30% EF with coronary artery disease, who are considered very high risk for surgery, have been, these are patients which we commonly operate now. Probably 60-70% of our surgical practice involves these patients these days, thanks to the evolution of medical therapy, where the ARNIs and the SGL2 inhibitors, they also help in optimizing these patients pre-op, intra-op, and in the post-operative period. So we have started to get better outcomes, and our results have significantly improved. So it is most important to have a combination of medical and surgical therapy to have a better outcome in these patients. So this is the outline of STITCH trial. So initially when the results came, there were, it was a bit of a gray because it said that the surgical and the medical therapy, there was no significant advantage. But when it came in 2016, when the extended results were published, so you can see that at 2 years' time, the curve starts diverging between medical therapy and CABG. So there is a survival advantage with CABG in selected patients. And likewise, death from any cause or cardiovascular hospitalization, CABG has an upper hand. And same with patients, death from all cause or any cardiovascular mortality, CABG definitely has an advantage in this group of patients. The interesting bit is, from the STITCH study, although we in our practice, we commonly follow that to see for viability assessment, the conclusion they drew was, although the study was not powered to assess that, they find even surgical revascularization in patients with non-viable myocardium had an advantage over isolated medical therapy. So next comes, the next commonest cause for heart failure is valve-related issues, and most common is mitral valve pathology. If it is a primary MR, it is very clear, then you need to address it by repair. Secondary MR is a condition where we have trouble, because it is secondary to ventricular issue. Then comes the discussion of whether repair or replacement. Previously, repair was advocated as a better choice because patients fared better. But however, early recurrences were very high. But now, with the advancement of total caudal preservation of mitral valve replacement, we have a good early and long-term results with addressing the mitral valve. So, having treated what are the reversible causes, be it coronary artery disease or valvular artery disease, we can reverse certain set of patients. But there are, however, a vast majority of patients where this is not possible, and we have to offer either an assist device or a transplant as an option in these patients. So if looking into assist devices, we have two categories. One is short-term and the other one is durable VAD. Short-term is often IABP, ECMO, which most of us are aware. And the next thing, upcoming thing, is an Impella or a Centrimag LVAD or a BiVAD. Most often we use for, in the short term, the first thing of choice from a surgical point of view is an ECMO. Because if you have to subject someone to a ventricular assist device, it doesn't have an oxygenator in the circuit. So very often a patient presenting in a cardiogenic shock or a gross pulmonary edema, if you just put him on a ventricular assist device, his oxygenation is not going to be taken care. So you put him on a veno-arterial ECMO, be it peripheral or central, depending on the expertise in the center. Then you assess the patient. Then you see if they are a candidate for transplant. If they are not a candidate for transplant, then you think of durable long-term LVAD as a destination therapy. But if they are candidates for transplant, then you bridge them to a suitable short-term VAD, be it a Centrimag LVAD or BiVAD, depending on whether it is LV dysfunction or a biventricular dysfunction. So this is Impella, is the recent addition to the short-term VADs, where we have Impella 2.5 and 5.5. 2.5 is a percutaneously inserted device, wherein you insert it through the femoral artery all the way up to the descending aorta, cross it across the aortic valve and keep it in the ventricle. So it gives you support, and this has been widely used by the cardiology group now for their complex PCI and high-risk interventions. Impella 5 is often more of a surgical device where we need to do a cut down either in the femoral artery, or you can do it trans-aortic or trans-axillary. We can implant this. This can be used as an additional venting device, the newer concept where ECPella has come, where you put a patient on ECMO, still you find in the transthoracic echo that LV is significantly distended and you are not able to decompress the LV. Then in addition to an ECMO, you can add this Impella. So this will act as an LV vent by decompressing the left ventricle and helps in myocardial recovery. So having seen the short-term devices, then what are the long-term devices available now? So these are three generations basically. The first generation devices were pulsatile flow or pneumatic devices. Second generation were axial pumps. The third generation or the recent ones are based on magnetic levitation. So these are the, so first generation was Thoratec, HeartMate, which was introduced. XVE was the first electric pump to be introduced. And subsequently, we moved on to HeartMate 2. There were quite a few implants in India. And now HeartMate 3 is the only FDA-approved device. And which, because of its magnetic levitation, it has significant advantages, which we will see in the subsequent slides. So what are the indications for VATS? So either it is a bridge to cardiac transplantation, because a patient, you have assessed a patient, he is a suitable candidate for transplant. Depending on the loco-regional issues, the waiting list time varies in different parts of the world and different parts of country within India itself. So if you think your patient, although he is on the waiting list, but he cannot sustain him till he gets a suitable donor organ, then he can put him on a durable VAD and then buy time for him. The next thing is to bridge to decision. Patient presenting on cardiogenic shock. You have never worked up this patient whether he is a candidate for transplant. Then you, but he is in cardiogenic shock, you have put him on ECMO, you have done your assessment. So this is as a bridge to decision making, to see whether he goes to the destination therapy or you can bridge him to a candidate for transplant. Or the next comes a category where you bridge to recovery for heart function, especially in patient with viral myocarditis. Where ECMO, but still it's taking longer time to recover. Then you can bridge them with durable VATs, and then once they recover, you can always expand the device at a later date. So bridge to transplantation is, in most countries, bridge to transplantation is what the LVATs are approved for, except in the US where destination therapy is approved. In India, the only, I think the most important, we don't have strict guidelines. It all comes to affordability, because any of these VATs, LVAT, they cost around 1 to 1.2 crores to start off. So that is going to be the main determining factor. Hopefully, in association with IIT, there is an Indian VAT which is being in trial now, which would cost around 20 lakhs. Hopefully, if it comes into clinical use, then we could offer it would be a cheaper and a better alternate for these patients. So who are the candidates where we can advocate this as a destination therapy? If a candidate, whoever is not a transplant candidate, for whatever causes he may be, who is in NIHA class 4, EF 25%, and in spite of maximal medical therapy, he needs inotropes, or you are not able to discharge him, then these are patients where you can use it for destination therapy. So Intermax, Interagency Registry for Mechanical Assisted Circulatory Support. This is a score based on the clinical symptoms. The patients are graded into 7 categories. Class 7, Intermax level 7 is where the patient is in NYHA class 3. So between 5 to 7, there is no survival benefit of adding a ventricular assist device in these patients. Whereas in category 3 to 4, these are ideal patients where they are frequent flyers to hospital or they are needing inotropic support. These are ideal patients to, you list them for transplant because they won't survive till they get an organ. So you put them on a durable VAD and they'll be very good candidates for bridge. And you, at the same time, you prevent developing pulmonary hypertension or RV dysfunction in these patients, and equally also end organ dysfunction. So whereas category 1 and 2 are the patients where they are crashing and they are on inotropic support. So here you can only put on short-term VATs. These are not candidates for durable LVATs because they have multi-organ dysfunction and they are not going to sustain this durable VATs. So HeartMate 2 and 3 are the most common VATs which were and which are being currently used in India. HeartMate 2 is an axial pump which weighed around 350 grams, and it is a completely intracorporeal device with just a drive line coming out. And HeartMate 3 is a fully magnetically levitated centriflow device. This is complete, there is no contact with, there is no fixed component and there is no motor contact with any of the cellular components of the blood. So the biggest advantage of this is the incidence of pump thrombosis is almost negligible with HeartMate 3. So these are the pictures just to show you how this HeartMate 3 is implanted. The first on the left corner is where we have put the plageted sutures. You can see the scarred myocardium. This is the LV apex, and this is the cuff we are suturing in to secure the inflow pump. And this is the coring device. You can see it is being used to core the muscle, and this is the muscle has been cored out. This is the LV cavity with blood, you can see. And the inflow component of the pump is being primed with fluid, and then it's being connected. And then the outflow component is being sutured to the ascending aorta, and we get the drive line out. So these are the studies and the results which have been published compared to LVAD over medical therapy. The first ever study was published in 2001, which was with HeartMate 2, the earlier generation device, which showed the 1 year and 2 year survival was 52 and 23% versus 25 and 8% in over medical therapy. Whereas with HeartMate 2, this significantly improved to 68 and 58%. However, with HeartMate 3, you can see the survival rate has significantly improved, and the incidence of freedom from reoperation to replace or remove pump because of pump thrombosis has significantly dropped at the end of 2 years. And the longest surviving patient on a HeartMate 3 has crossed 6 years, where we have around 70% survival rate without any major complications in this patient group. Considering, whereas in HeartMate 2, we used to have multiple strokes and bleeding and thrombosis once we cross the period of 2 years. So this is the algorithm for management of advanced heart failure, where any patient coming with heart failure, if he is eligible for orthotopic heart transplant, then he gets listed. Then the question comes whether we need to bridge him, whether he has enough time, whether he can sustain the waiting period. If he can't, then you add him to the long-term durable MCS. If patient is in acute cardiogenic shock, you introduce the short-term mechanical support and then bridge him to transplant or destination therapy depending on his eligibility. So the orthotopic heart transplant is the gold standard in the management of heart failure. The biggest disadvantage or the shortcoming of this procedure is lack of donor organs. If we have enough donor organs, then we don't have to think about anything else. That is the biggest limiting factor to offer this gold standard treatment. As we all know, the first orthotopic heart transplant was done in 1967. And the second important step forward in the success of heart transplant was to introduction of transvenous endomyocardial biopsy, because this helped monitoring the rejection. And the next important step in 1981 was cyclosporin. This revolutionized the management of immunosuppression, and this increased the acceptance of heart transplant as a treatment option, and the success rate improved. So widely around 2,700 transplants are performed annually, and in India roughly around 200 heart transplants are being performed. However, in the northern part of India, we have very limited cases happening. One is mainly due to less donation in this part. In Rajasthan, for that matter, if you see in the last year, we have done only 3 heart transplants. Such a big state, we are lagging because we don't get many donor offers. So the first transplant in India was done in '94 by Dr. Venugopal in AIIMS. This is the indications I'm just in them. Before I finish, I'll focus on this important part, this contraindication, because indication everybody knows. Contraindication is where patients develop pulmonary hypertension, where the PVR is above more than 5 Wood units, or you develop a transpulmonary gradient more than 16 to 20. We all talk about the benefits of medical therapy, but what we also need to remember is when we initiate the patient on medical therapy, we see on a symptom status and the LV function. What equally important is to monitor is PA pressure. Any time a patient PA pressure is starting to increase, let's say 30, then becomes 35. If we continue to medical therapy, then we are even losing the option of even offering the transplant to these patients. So it is very important. Any time you see a patient on medical therapy with heart failure, developing pulmonary hypertension, you refer him early to the surgeon. At least we can consider either a ventricular assist device, or we can work him up and list him for transplant. Whereas if this doesn't happen, if he comes in the end stage where medical therapy has failed, he has developed severe pulmonary hypertension, then we have only either destination therapy or we have to do a heart-lung transplant. So this is very important to make sure that we refer the patient early and continue the medical therapy as adjunct. So if you look at the survival rate of heart transplants, this is a decade-wise transplant. If you see, the 1 year survival is around 90% currently, and 10-year survival is around 75 to 80%. Whereas if you look at for a heart-lung transplant, it is going to be, the lung transplant decides the outcome of heart-lung. So lung as an organ, if you transplant it, the 1 year survival is 70, 2 year survival is only 50. For a patient who would have had otherwise a 10 year, 15 year survival, if he ends up with a heart lung, he's going to just have a median survival of 2 years in spite of transplant. So the need of the hour is synchronized multimodal approach. A patient coming into a heart failure clinic we should have a team where you have a heart failure specialist, electrophysiologist, a surgeon, and all three chart out a plan for him, rather than being either the patient ends up in a physician side or on the surgical side where they don't get the best of both worlds. Thank you.
Thank you, Dr. Sitaraman, for the exhaustive and good talk about the surgical treatment of heart failure. In interest of time, we'll end this session, and Nitesh, you can invite the chairpersons for the next session.
Yes.
Thank you.
So as we progress through the Jaipur Heart Rhythm Summit 2023, our next session is on the horizon. Get ready for AF Symposium, where we will delve into the world of atrial fibrillation, discussing its management challenges and innovative solution. So let's keep the momentum going. Now I would like to invite Dr. R.K. Gokhru sir as a chairperson, Dr. Sanjeev Sharma sir, Dr. Sanjeev Roy sir, Dr. Narendra Sen sir, Dr. Balveer Pachar sir, Dr. Rahul Ajmera sir, Dr. Sanjeev Sidana sir, and Dr. Pradeep Meena. So we will request all of chairperson to come forward, and I will request Dr. Ajay Nayak sir for the next presentation.
Thank you. My talk is going to be preamble for the next 3 talks. So I'll be very quick and short about it. Integrated approach for atrial fibrillation is basically A, B, C. Avoiding stroke is A, avoid strokes. B is better symptom control. And C is managing the comorbidities or additional cardiovascular management. So avoid stroke, better symptom control, and comorbidity management. We all know problems caused by AF are stroke, the irregular rhythm can cause LV dysfunction, heart failure, impairs quality of life. So we need to optimize the stroke prevention, symptom control with rate or rhythm control, which Dr. Neeti will talk about, management of cardiovascular risk factors and comorbidities. And these are important things: patient education, self-management, making sure that the patient understands what the disease is, how it is going to be a long-term management of the patient of the disease, which is important. Lifestyle modification, this is extremely important in terms of smoking cessation, avoiding tobacco in all forms, limiting use of alcohol, dietary intervention, reducing the BMI, management of reducing the weight. That goes a long way. If there is evidence of obstructive sleep apnea, we need to take care of it. That is a very important component of atrial fibrillation. And exercise, physiotherapy, rehabilitation, lifestyle modification is extremely important. And finally, something we don't talk about much in our part of the world, psychosocial management, cognitive behavioral therapy, stress management, other psychological assessment and or treatment. And all the people who are going to take care of these patients. So healthcare professional education is also very important. We talk about rate control, rhythm control, stroke prevention. Rate control is by drugs, AV node blocking drugs, or we do procedures like AV node ablation plus pacemaker implantation. In rhythm control, again, antiarrhythmic drugs, and intervene with either cardioversion or catheter ablation. Stroke prevention by anticoagulants, the vitamin K antagonists, NOACs, or now left atrial appendage occlusion. So for rate control, it's going to be rate controlling drugs versus AV node ablation pacemaker, where the drugs don't work very well. This is a decision that we need to take: ablate the AV node and give regular rhythm with a pacemaker. With the advent of conduction system pacing, which you heard a lot today, it has been now it is a very attractive option. Otherwise, after AV node ablation, even though previously the patient had narrow QRS, would end up with a wide QRS. But with conduction system pacing, carefully done AV node ablation, and leaving the patient with narrow QRS, it's a very elegant way of managing this. For rhythm control, apart from antiarrhythmic drug, DC pharmacological cardioversion by drugs like flecainide and propafenone, which is pill in the pocket approach, or ibutalide, which is injectable, and amiodarone for long term. Pharmacological cardioversion is done with this, but electrical cardioversion, wherever applicable, it is a much more predictive way of taking care of this. And finally, ablation. So ablation, the wide antral circumferential ablation, radiofrequency ablation, cryoablation, and what we do, what is available nowadays in the West is phased array ablation, which is safer for the patient. There are newer technologies like contact force sensing ablation, which has made things much safer, and cryoablation, which has made the procedure more predictable and time bound. So that works very well. AF ablation protocol, otherwise it has to be very stringent. Each center needs to develop its own, and we follow this very meticulously. And I'm going to skip this. Stroke prevention with anticoagulation, and we all need to be aware of CHADS VASC when we take care of patient. At the same time, what goes hand in hand with CHADS VASC is the HAS-BLED score. So the propensity for the patient to have a bleed, that needs to be assessed each time the patient comes to you. And if the patient is at a higher risk of bleeding, then putting in a left atrial appendage occluder device becomes a good option for some of the patients. So this is typically for non-valvular atrial fibrillation patients. Just to summarize, I went through this very quickly. This is one of the patients. This is a final unification. A 72-year-old lady, this was 3-4 years ago, recurrent atrial fibrillation on multiple antiarrhythmic drug therapy. Patient has had a CVA in the past and had GI bleed on vitamin K antagonist, switched to one NOAC, had a bleed on that, switched to another NOAC, had a bleed on that also. So this patient is at high risk. So for this patient, what we went ahead and did was atrial fibrillation ablation, VACA. So this is done with 3D mapping. We isolated the pulmonary veins, and the patient on table was restored to sinus rhythm. And then at the same sitting, went ahead and did, once the atrial fibrillation was taken care of, went ahead and did left atrial appendage occlusion. This is the Amplatz device which is being put, and that was used to occlude the left atrial appendage. So it was a 4.5 hours procedure, but AF ablation, restoration of sinus rhythm, and at the same time taking care of the bleeding issues by putting in a left atrial appendage occluder, and the patient is still following up after 4 years and doing quite well. This is our X-ray now, and this is the device in location. So just summarizing again, and Dr. Neeti and my subsequent speakers will talk about it. Rate control with AV node blocking drugs. If it doesn't work well, AV node ablation, pacemaker implantation, now with conduction system pacing. Rhythm control with antiarrhythmic drugs, pharmacological or electrical cardioversion, catheter ablation, and stroke prevention, anticoagulation, vitamin K antagonist. Virtually, we have switched on to NOACs for all patients, LA appendage occlusion wherever applicable. And just remember the ABC again: avoid stroke, better symptom control, and taking care of the comorbidities. Thank you.
Thank you, Dr. Ajay, for an excellent presentation, overview of how to manage atrial fibrillation. We have 3 minutes in this session. Can we have questions in the last? We'll, because of the short of time, we are already late. May I request Dr. Neeti, Dr. Negi to present rate versus rhythm control, a very important topic. And all of we as adult cardiologists or physicians our main intent remains that the rate should be controlled. So let's see anything new in it. Dr. Neeti, please.
Thank you, sir, for the kind introduction. And it's wonderful to see such a lovely gathering at this time. The topic of my presentation is rate versus rhythm control in atrial fibrillation. So why the discussion? Because the studies have shown that rate versus rhythm control have got similar results, and there is no significant difference in cardiovascular death, all-cause mortality, stroke, or major bleeding. And based on these studies, the current guidelines were set. However, the management of atrial fibrillation has since evolved, and there is time for more discussion. So the relevant guidelines, which are existing guidelines, is 2019 ACC guidelines and 2020 ESC guidelines, which suggests that rhythm control therapy, especially with catheter ablation, is more efficacious for symptomatic patients, and it should be resorted to when there is a symptomatic atrial fibrillation and an improvement in quality of life of such patients. So what is the evidence for rate control that we have? Now these trials were largely conducted in 2002 to 2005, wherein this AFFIRM trial, the staff PIF rate study, it showed that both the rate control and rhythm control have got largely similar results as case of survival benefit or hospitalization. So there is no difference in symptoms. In some studies, as such, rhythm control group had more hospitalizations because they had side effects with the rhythm control drugs. The evidence for rhythm control, these studies have largely been conducted late 2019, 2020, the EAST AF-NET 4 trial. Now the EAST AF-NET 4 trial had patients had a history of atrial fibrillation in the past 1 year. Now this is important. Last 1 year history of AF and concomitant cardiac high-risk conditions. In these patients, rhythm control fare better than rate control, and in these studies, the catheter ablation were also included in the trials. And the rhythm control fared better for death due to cardiovascular causes, stroke, and hospitalization for heart failure. Initially, the trials showed only symptomatic improvement. Now we are talking of the death, the adverse events, the death due to cardiovascular causes, the stroke, and hospitalization for heart failure. So the efficacy outcomes showed better results as compared to the primary outcome as well as the secondary outcome. The evidence for catheter ablation, Castle AF trial was a major trial which was released in NEJM 2018, and ATTACK trial in Circulation 2016. Now they specifically included patients with atrial fibrillation and LV dysfunction, and they showed that catheter ablation was associated with significantly lower risk of death and heart failure hospitalization. These are the results. So as it is, they showed that the primary outcomes and the secondary outcomes both fared better when the patients were subjected to catheter ablation or a rhythm control strategy. So both primary outcome, all-cause mortality, and worsening heart failure hospitalizations were better when the patients were ablated versus those when they were not ablated. The Cabana trial needs a mention because it was released in JAMA 2019. Cabana trial actually said that there is no significant reduction in death and disabling stroke or serious bleeding at 1 year. However, a post-hoc analysis of Cabana, which is Cabana heart failure trial, has recently been released in 2021, And it said that in the heart failure population, the catheter ablation led to a significant improvement in both the death due to cardiovascular causes, the serious bleeding, and the stroke outcomes. Even the cryoablation trials have shown benefit. The STOP AF trial, wherein the trial included cryoablation versus the antiarrhythmic drugs for the rhythm control, and these patients were monitored on a ECG and a Holter, and the early AF, which again randomized patients to cryoablation versus antiarrhythmics, they were monitored via the implantable cardiac monitor. Both showed that the ablation was associated with a significantly lower rate of AF recurrence, and the primary and the secondary outcomes were better with ablation. So the upper figure shows the cryoablation balloon, and the lower one is the radiofrequency ablation which is going on. Meta-analysis of various trials were released in 2019, which suggested that significant reduction in heart failure, hospitalization, and arrhythmia recurrence with catheter ablation versus antiarrhythmics in patient with or without LV dysfunction. So now we are moving towards, the studies are largely showing that catheter ablation improves the primary endpoint as well as the secondary endpoint. In 2023, a meta-analysis was released with the studies from 2000 to 2022 was included. Again, it showed better heart failure outcomes, better stroke outcomes, and all-cause mortality as well. So, summary is a debate really continuing. The rhythm control strategies edging ahead gradually but surely. Catheter ablation of atrial ablation is leading the race to the touch point, and even the cryoablation also suggesting improved outcomes, but it's early to say. Thank you so much.
We can have discussion at the end of all the talks. Thank you, Dr. Niti. So our next speaker is Dr. Sanjeev Roy, and he'll speak on anticoagulation in AF, safety versus efficacy. Dr. Sanjeev Roy.
Good evening, everybody, and thank you, Dr. Makkar, and the organizers of the Jaipur Heart Rhythm Society Summit for having me here. Can I have the first slide? In atrial fibrillation, the safety and efficacy. So as Dr. Ajay Nayak had nicely introduced you towards the management of this topic, management of atrial fibrillation starts from CC to ABC. CC is you need to confirm the atrial fibrillation, be it with a 12-lead ECG or a rhythm strafe, where you find the AF to be having persisted for more than 30 seconds. We need to characterize the atrial fibrillation, and the algorithm is 4S, 4AF scheme, where we need to assess the stroke risk by the JHRS score. We need to look at the symptom severity with the EHRA symptom score. We need to look at the severity of the AF burden in terms of the duration, the spontaneous termination. And finally, we need to look at the substrate severity in terms of the age, comorbidities, atrial enlargement, and fibrosis. And once we do that, the treatment algorithm is ABC. A stands for the anticoagulation or the avoiding strokes. B is better symptom control. And C is managing the comorbidities and cardiovascular risk factors. So, and as he emphasized, it is integrated management beyond this, where we need to look at the patient education, we need to look at this lifestyle modification, the psychological management, and finally, if necessary, surgeries. And this is a multidisciplinary team approach, and a very structured follow-up is needed for that. So let me focus on the anticoagulation and avoid the stroke. That is the A of the ABC algorithm. So first, any patient who comes with an atrial fibrillation, we need to see if the patient is eligible for oral anticoagulation. So we need first to look out whether they are having a prosthetic heart valve or any moderate to severe stenosis. If yes, they are eligible for vitamin K antagonist, preferably with a high time to the therapeutic range. Or if they are in low risk, what we need is to assess the CHADVAS score, where if they are in CHADVAS score 0 or 1, it is a low risk. They don't need any antithrombotic therapy. If the CHADVAS score is more than 1 in male or more than 2 in the female, then we need to look at them. We need to look at the Hasbled score. We need to look at the modifiable risk factors, whichever are there. Some of the risk factors are non-modifiable, but if we can actually manage the modifiable risk factors and reduce the Hasbled score, we can actually introduce the antithrombotic therapy in them. So we do the CHADVAS score, and if the CHADVAS score is 1 in male or 2 in female, the oral anticoagulation is class 2 indication. But if it is more than that, all of them, the CHADVAS, the oral anticoagulation is recommended. And in here, preferably it is NOACs. However, vitamin K antagonist can be given in situations, but we need to maintain the time in therapeutic range at a higher values. So if we are initiating the vitamin K antagonist, we need to calculate the SAMT2R2 score, where if the score is less, we can consider the vitamin K, and with score more than 2, we need to regularly monitor them. So there has been a milestones in the anticoagulation therapy way back starting in the first part of the last century, where it was heparin, came the warfarin in 1940s, and then thereafter more emphasis on the NOACs, or the novel anticoagulations, that was in more of between 2007 and 14. So what are the oral anticoagulations we have? The vitamin K antagonist, where does it act? It acts at the factor 7, the tissue factor, the factor 10A, and thrombin. And these actually was initially started in 1940s, and where most of them were linked from the sweet clover disease in actually hay-infected seed clover disease. And these were good as a rodenticide. But however, its use in Eisenhower, the famous US president in 1950s, popularized this therapy. So prototype drugs are warfarin, and basically it acts on the epoxide reductase enzyme, and it inhibits the factor 7, 9, 10, and prothrombin. However, it has many, many limitations. And one of the most important is the time in the therapeutic range, which ideally should be more than 60% in most of the patients. But even if you look at the one encircled in the blue, it is in India, it is most often less than 50%. So what are the risks and benefits of using a vitamin K antagonist like warfarin or acetrom, what we have? It has several limitations, and it makes it very, very difficult to use in most of the situations. It has a slow onset and offset of action. It needs a bridging therapy for initiation. We need to overlap with the heparin. It has a very narrow therapeutic index. Between when we do the INR, the range is only between 2 and 3. It needs a routine coagulation monitoring, and only 60% are in the therapeutic range. It has an unpredictable response. It needs a frequent dose adjustment, numerous food and drug interactions, intracranial bleed, which is much more higher than the others, and finally, the warfarin resistance have also been noted. In Asian populations, if you look at here, use of anticoagulation is the risk of intracerebral bleed is almost 4 times. Warfarin, though effective, but if you look at the data from the Garfield AF registry in the atrial fibrillation, most of the Asians spend majority in the time outside the therapeutic range. So there is a quest which started in 50 years back. We're pushing away from this molecule warfarin to much more safer molecule, and these are the NOACs, or the non-VK antagonists, and these include the rivaroxaban, the apixaban, and enroxaban, which actually act at the factor 10A, and dabigatran, which acts at the thrombin level. So these are the various NOACs which are available: apixaban, betrixaban, dabigatran, edoxaban, and rivaroxaban. Betrixaban doesn't have a US FDA approval for AF, but rest of the 4 molecules they have. An important thing is if you look at here, the dabigatran is a prodrug and it's dialysable. Rest of the drugs are not dialysable and not prodrug. And I'll come into the other pharmacodynamic effects in the next couple of slides. And if we look at the 4 molecules, dabigatran, and this is almost like 20% hepatic excretion, and rest of the time it is 80% is renal excretion. While the edoxaban and apixaban, they have almost like, apixaban and rivaroxaban, they are almost 60 to 70% hepatic metabolism, and about 25 to 35% the renal metabolism. Edoxaban is like 50-50. So in the stroke prevention, oral anticoagulation becomes a standard care. Aspirin, it causes only 22% relative reduction compared to placebo. Vitamin K antagonist causes nearly 38% relative risk reduction over and above that of aspirin. And NOACs, it further reduces the relative risk by about 19% over and above the vitamin K antagonist. However, if we look at the efficacy of aspirin, antiplatelet monotherapy is not recommended for stroke prevention in atrial fibrillation regardless of the stroke risk, and this is as per the ESC guidelines. So what are the evidence and efficacy that we have for the NOACs? So we have the RELY trial for the dabigatran, the ROCKET for the rivaroxaban, apixaban, we had the Averroes trial and the Aristotle, and finally the edoxaban, which is not available in India. This is ENGAGE AF trial. And if we look at the patient included, the most high-risk population was in the ROCKET AF. Averroes, Aristotle had relatively lesser risk, and the lowest risk was in the RELY trial. So these are the trials, if you look at here, which were included nearly about 71,000 patients, and we can have the relative efficacy of each one of them, but these are not a head-on-head comparison. These are as per the trials which included the population. So if you look at comparison to the warfarin, in terms of prevention of stroke or systemic embolism, the dabigatran, apixaban had been more effective in doses of 150 BD, and apixaban, both doses, that is 5 and 2.5, were more effective than compared to the other NOACs or warfarin. If we look at the all-cause death, the most impressive data was with apixaban and edoxaban, but all of them were better than the warfarin. Most importantly, if you look at the intracranial hemorrhage, and in this intracranial hemorrhage, irrespective of the dose, each of the NOACs caused much less intracranial hemorrhage compared to warfarin. And also major bleeding, if you look at dabigatran and rivaroxaban had slightly more bleed compared to the other molecules. Dabigatran at dose of 150 compared to dabigatran at dose of 110, and the other apixaban molecule and edoxaban. So if you look at in a nutshell, what I said in the last couple of slides, if you look at dabigatran is very useful, it reduces the intracranial hemorrhage compared to warfarin, also has less number of bleeds. Dabigatran 150 is better for stroke prevention, also had slightly more bleed than 110, but it is better than warfarin. Rivaroxaban is better for reducing the intracranial hemorrhage. Apixaban was found better in terms of reduction of the stroke, ICH, death, and major bleed, all of them put together. Let's look at some of the specific clinical scenarios related to atrial fibrillation. If it is an elderly patient, if you look at here, I think the most effective, I'll just run through a couple of slides. Most effective, if you find the safety records, it is with apixaban. And that is why, if you look at FORTA, that is the fit for aged classification, apixaban has a class 1A, class 1A, and remaining are class B. If we look at the renal dysfunction patient, that is CKD patient, now CKD is very double-edged sword. It increases the risk of stroke on one side, also increases the risk of bleeding. So in a nutshell, if you look at here, most of the time, if the renal clearance is less than 50, these molecules have been safely used, but we need to actually check on the creatine clearance in months, because if the creatine clearance comes down, particularly it is true with the dabigatran, we need to adjust our doses, as also with apixaban and rivaroxaban. So apixaban, apixaban and dabigatran 150, they have been found in CKD patient to reduce the stroke, but they have not been very significant results in terms of major bleed and mortality. So if you look at here the doses adjustment, dabigatran, whenever the creatine clearance is more than 50, a dose of 150 is quite suffices, while between 30 and 50, we need to taper down to less than 100. And between 15 and 30, though it is not available in our country, in US, a dose of 75 twice daily has been approved, US FDA approved medications. Rivaroxaban, whenever it comes down to below 50, that is between 30 and 50, we need to reduce the dose to 15. And apixaban, again, in a similar way, we need to reduce the dose, particularly in patients who has a serum creatine of more than 1.5, or an age of more than 80, or a body weight of less than 60, we need to reduce the dose from 5 to 2.5. So overall, if you look at, again, apixaban had been found to be very, very safe in this kind of bleeding. Another very important is the GI bleed. Again, here the worst are the rivaroxaban, followed by, comparatively safer are the dabigatran and apixaban and edoxaban. So this was the clinical epidemiology conclusions. The GI bleed, whenever it happens, apixaban and edoxaban are most favorable in terms of reduction of the GI bleeding. And as also, if you look at the ESC guideline, again, apixaban and dabigatran 110 was found to be a favorable compared to the other molecules. So this is a nutshell. If you look at the 2017 expert consensus, as well as the 2018 CHEST guidelines. So if you look here in elderly patients, apixaban is quite safe, as also in reducing the GI bleed. While if you look at the bleeding incidences, it has been less with apixaban, edoxaban, and dabigatran 110. What about diabetic subsets? Just 2 minutes more. Diabetic subsets, again, we found that apixaban and dabigatran had a favorable outcome, particularly in terms of low GI bleed. So what happens when patients are on NOACs and elective surgery is indicated? We need to look at these patients who are in a high surgical risk or low surgical risk. Those who are in high surgical risk, they include the left-sided ablations, any spinal or epidural anesthesia, thoracic, abdominal, and orthopedic surgery, liver biopsy, and transurethral and kidney surgeries. So in these cases, we need to actually adjust our doses, stop the medications. Those who are at low risk and renal functions are normal, as far as dabigatran is concerned, we can stop 24 hours earlier. But if the renal function is compromised, it should be stopped at least 2 days prior. As for the other molecules, again, for the low risk, it is only a day prior you can stop. But if it is a high risk surgery, you need to stop this at least 2 days earlier. And if the bleeding happens, we don't have much of monitoring parameters except for direct factor 10A. You only have an anti-factor 10A assay. For dabigatran, you have a diluted thrombin time, which is not available in most of the parts. So in a nutshell, if you look at if you have a minor bleeding, you just delay or discontinue the next dose and reconsider concomitant medicines. If you have a moderate bleeding, you need supportive measure. And if you have a life-threatening bleed, you need a platelet, you need a prothrombin complex or APCC. And sometimes we have a reversal agent, which includes, the idarucizumab, and then you have the adenosate and sirapiranotag. And these are the various reversal agents. Most often, the Praxbind or the idarucizumab is used, and this is very effective for dabigatran, but other molecules which is not available in India, that is anti-succinate, which is not available. So to conclude, if you have a patient with atrial fibrillation, first we need to see if the patient is warfarin or not warfarin. If the patient is on warfarin and the time in, the TTTR is more than 70%, you can just continue and be watchful. If not, if patient is not on warfarin, we need to do a CHADVAS score. And if the CHADVAS score is favorable, we can use the NOACs. If we are looking for vitamin K antagonists, we need to look for these parameters to look at the bleeding complications. Also address the has bleed and look for the reversible or partially modifiable causes of high bleeding risk. Thank you.
Thank you, Sanjeev, for an excellent presentation, role of NOACs and vitamin K antagonists. We will take up the question in the last. The important message carry home is, before you start any NOACs or vitamin K antagonist, you have to assess the hepatic and renal functions before you can choose anyone, antithrombin versus antivitamin K. Next we pass on to last presentation of the day, Dr. Kush Bhagat, atrial fibrillation, radio frequency ablation versus cryoablation. Dr. Kush.
Thank you so much, sir. I think my job has been made very easy by Ajay Nayak sir and Niti ma'am and Sanjeev Roy sir. So I'll focus on AF ablation. So I think about the definition of paroxysmal, persistent, long-lasting, permanent, everything has been discussed. And it is important to treat AF, and it's very important to treat at an earlier stage, not at a later stage when there is a lot of remodeling in the heart, the LA is dilated. Then it becomes very difficult to treat atrial fibrillation. And as far as the guidelines are concerned, then any patient who is symptomatic, refractory to or intolerant to at least class 1 or class 3 antiarrhythmic medication, and with the paroxysmal AF, catheter ablation is recommended with the class 1 and level of evidence A. So that means any paroxysmal AF patient who is on medication, who is not tolerating medication, or despite medication he is having recurrent AF episode, then we should go for atrial fibrillation catheter ablation with the evidence of class 1 and level of evidence A. So this is very important. Now, strategy of AF ablation, as discussed by Dr. Niti ma'am, that pulmonary vein isolation is the cornerstone for AF ablation procedure. Now, the question is that for PV isolation, we have two strategies to go for pulmonary vein isolation. So, yeah, so this is the two strategies. One is the radiofrequency ablation and other is the cryoablation. So I'll focus my presentation on these two things only. So what is basically radiofrequency ablation, what is cryoablation, and what is the difference between these two ablation? When should we choose radiofrequency over cryo or cryo over radiofrequency? So I'll discuss in brief about that. So what we do in radiofrequency ablation, I'll present with the help of a case. So he's a 45 years old male patient who has history of recurrent palpitation, and ECG was done suggestive of paroxysmal atrial fibrillation. He was on amidron and obviously anticoagulant and beta blockers as discussed by Roy sir. And despite being on medication, he had symptomatic episodes of AF. So according to guidelines, it's class 1 with level of evidence A, indication for atrial fibrillation ablation. So both by ACC and ESC guidelines. So this is actually what we do. Ajay Nayak sir also showed a case in which we isolated the pulmonary vein from the left atrium. So these are the 4 pulmonary veins, and these brown dots are the ablation points. So this is radiofrequency ablation, which we do to isolate the pulmonary vein from the left atrium, and this is how we actually treat this atrial fibrillation. This is point-to-point ablation. Now, what is cryoablation and what is the difference between the cryoablation and radiofrequency ablation? As far as studies are concerned, Dr. Niti has already showed about the various studies, and it is very much clear that cryoablation was already approved by US FDA for paroxysmal AF, and it was also recently approved for persistent AF by US FDA. And various trials were done which has shown that cryoballoon ablation is undoubtedly it is superior to antiarrhythmic drugs for prevention of atrial arrhythmia recurrence. So how do we do cryoablation? So in short, this is the whole console of cryoablation. This is the cryo console, this is the balloon, this is the catheter, this is the mapping catheter, and these 4 things are used for cryoballoon ablation. Now, the concept is same, that we have to isolate these pulmonary veins from the left atrium. The technique is different. In radiofrequency ablation, we give point-by-point ablation dots to isolate the vein, and in cryoablation, what we do that this is the mapping catheter. We insert the mapping catheter in the pulmonary vein. After that, we take this balloon, which is called as the cryo balloon, and the balloon is moved and it is positioned in the pulmonary vein, and we just inflate the balloon, give cryo energy, and this whole vein is isolated from the left atrium. So this is how we go, we do cryo balloon ablation. So The best part of this cryo versus radiofrequency ablation is that we just have to insert the balloon and deliver the cryo energy, and all the vein will be isolated at one go. But in radiofrequency ablation, we have to go by point radiofrequency ablation. We have to give one burn here, then we have to again move the catheter, As Ajay Nayak showed that, sir showed that it took 4 hours for radiofrequency ablation as well as LA appendage closure. Probably with cryo balloon ablation, it would have taken a much lesser time. So this is how we go for a cryo balloon ablation, and this is by delivering cold energy, this is by burning the tissue. Point by point catheter ablation, at one go we can isolate the pulmonary vein. It is comparatively simpler with a shorter learning curve. It is easier to reach the target area within short span of time, and as far as results, efficacy and safety are concerned, then definitely it has got a reduced risk of complications, more efficacious as compared to radiofrequency ablation with fewer repeat ablations, and most importantly in our cath lab, it enables time for additional EP lab or interventional cardiology procedures. Now, if we look at the lesion, so this is the cryo lesion at 1 week, the well demarcated with minimal thrombus, and the endocardium is intact. And this is the radiofrequency burn. It is basically a lot of thrombus is there, the endocardium is disrupted. So this is basically the difference between the lesion, between the radiofrequency and cryo lesion. So more safer, more efficacious, takes less time. And in short, I'll discuss one case. So she was a 64-year-old female with history of recurrent atrial fibrillation episode, and she had heart failure hospitalization also. So she had mitral regurgitation because of prolapse and recurrent AF episode. So before going for cryo balloon ablation procedure, we do a T to rule out LA appendage clot. We do a CT venogram, pulmonary vein venogram, to look whether there are any accessory veins or not, and it helps us in negotiating these veins. These are all 4 pulmonary veins, and we do the transseptal puncture by T-guided transseptal puncture is done, and this is how the setup looks. So this is the left atrium, this is the CS catheter in the superior vena cava and in the coronary sinus, and this catheter is placed for phrenic nerve pacing, because one of the complication of this cryo balloon ablation can be phrenic nerve damage. And this is actually how we do. So we have, this is the catheter, a mapping catheter, which is in the left superior pulmonary vein. This is the balloon which is inflated. We are giving contrast inside the vein, and we can clearly see the vein is filling. There is no significant leakage back in the left atrium, and then we just give cryo energy. So this is how we isolate all the 4 pulmonary veins. So that was the superior, this is the left inferior, this is right superior, and this is the left inferior pulmonary vein. So just to summarize, cryo balloon ablation is accurate, it is safe, it is efficacious, fewer CV hospitalization and repeat ablations, short learning curve, easy to adopt, strong evidence, simple, safe, fast, and predictable, and a shorter procedure duration. So just to summarize, that earlier treatment with catheter ablation is very important, and it has been shown to reduce atrial arrhythmia recurrence. Thank you so much, sir.
Wonderful session. I would like to congratulate to Dr. Sanjeev Roy sir, Dr. Ajay sir, Dr. Neeti, and Dr. Kush. Would like to summarize this session. Atrial fibrillation is very important to day-to-day practice. All physicians, cardiologists, clinical cardiologists, interventional cardiologists, and cardiac surgeon and intensive care unit. Atrial fibrillation requires an integrated approach to treat with teamwork, with all direction, the 360 degree. We have to keep in the mind of the risk factor, the management of the atrial fibrillations or rate, and the rate control is very important, antiarrhythmic drugs, and catheter ablation and cardioversion. Apart from that, Novak therapy is very important. Apixaban is a conclusion. The apixaban is at the lower bleeding rate, low stroke rate, and low hospitalization rate. It's very important to, apart from the medical management, the cardiac intervention is cryoablation or radiofrequency ablation is required, along with the left anterior appendage devices. Thank you so much for the wonderful session. Enjoy. Do you have any question for the audience? Thank you so much.
Thank you. Thank you so much.
So very good evening. A big thanks to all the participants, speakers, who made the AF symposium session so informative and engaging. We approach the final leg of our summit. Let's look forward to the panel discussion on the natural history of AF. Time for appropriate intervention. Join us for this thought-provoking discussion. Your active participation is what makes this summit so special. So for this session, may I request the chairperson of the session, Dr. Pintu Nahata sir, Dr. R.K. Gokhru sir, Dr. Rajiv Gupta sir, Dr. Sanjeev sir, Dr. Sanjeev Roy sir, Dr. Suresh Gupta sir, Dr. Vimal Kant, Dr. Anup Gupta, Dr. Ajay Nayak, and Dr. Daljit Kaur. And now I will request Dr. Makkad sir for the proceeding. Thank you.
Good evening, everyone, and thank you once again for being there in such a good number. So this is the last part. I am the only one now in between